Uh, Friends, it's my proud privilege to welcome you all here in this hospital for the conference cum workshop on endotherapy in pancreatic diseases. Not very often or very much talked about topic in this part of the country, and that's the reason we chose this one-day workshop on this. We have three very eminent speakers who will be introduced in due course of time, and we have some procedures also to demonstrate. I welcome you all once again and hand over the mic to Dr. 𝗟𝗓𝗡 to invite Dr. Ramesh and chairpersons for the first session. Dr. 𝗟𝗓𝗡.
Good morning, everybody. The first lecture will be delivered by Dr. Ramesh, who is head of the Department of Gastroenterology in AIIMS Patna. Dr. Ramesh will discuss on acute pancreatitis and at presentation management issues and challenges. Now I invite chairpersons Dr. Sanjeev Jha, who is a consultant in Indira Gandhi Institute of Medical Sciences Patna, Dr. V.M. Dayal, who is the head of the department IGMS Patna, and Dr. Vijay Sankar, who is a consultant gastroenterologist working in Patna. Thank you.
Good morning to everyone, and at the outset I would like to thank the organizer, especially Vijay Prakash sir and Dr. Pankaj, for making me part of this wonderful meeting. As topic so next 20 minutes or so I will be talking about dealing with patient with acute pancreatitis at presentation. So coming to first challenge, that is diagnostic challenge. Acute pancreatitis, as proposed by revised Atlanta classification. Uh, it requires 2 out of 3 criteria, that is typical abdominal pain, raised enzymes to the level of more than 3 times, and presence of pancreatitis on cross-sectional imaging. Now, the problem with this criteria is that it takes about 3 to 5 days before we can categorize patient into different mild, moderate, and severe. There are many diagnostic pitfalls with regard to diagnosis of acute pancreatitis criteria. Typical pain has been described, but it may not be present in all patients. Various other acute abdominal conditions can have pain that simulate acute pancreatitis. The typical pain which has been described as radiation to back has been found only in 50% of cases, and about 5 to 10% of acute pancreatitis can even be painless. In a recent systemic analysis, it was found that most common presentation of painless acute pancreatitis was fever and abdominal distension, and most of these patients had high fatality rate. Coming to pitfalls regarding pancreatic enzymes, serum amylase may be falsely normal in fatal case of pancreatitis and mild attack of pancreatitis and certain etiology like in hypertriglyceridemia. Also, serum amylase may be elevated in others condition like acute abdominal condition like mesenteric ischemia, intestinal obstruction, perforation pancreatitis, and also in non-pancreatic. Serum amylase may be falsely high. Serum lipase is more specific, but it can also be elevated in other GI conditions as well as renal failure. A recent Cochrane-based systematic review of 10 studies found that if we go by first 2 criteria, that is pain and elevated enzymes, we are going to miss out on about 25% cases of acute pancreatitis, and we will make a false diagnosis in about 10% cases. So whenever there is a high index of suspicion, we should always consider cross-sectional imaging and CT can be the investigation of choice in this case. Combining both amylase and lipase is not a good idea because it just increases the cost without improving the diagnostic accuracy. So if we have to choose between amylase and lipase, which one is better? The evidence suggests that lipase is better than amylase because it is more sensitive, more specific, it is elevated for a longer period of time, and also it is elevated in conditions where amylase may be normal, like in case of hypertriglyceridemia. In general, amylase may be elevated up to 8 to 14 days from the onset of pancreatitis. About 75% of acute pancreatitis is either biliary or alcohol in origin, and it is very important to know the etiology of the pancreatitis because it is essential for prevention of recurrent pancreatitis. We can see here in case of biliary pancreatitis, if cholecystectomy is not performed, the chances of recurrent pancreatitis is very high, 30 to 50%, and the median time of recurrence is about 108 days. Biliary pancreatitis is very common, but ultrasound can miss out gallstone even when it is present in presence of distended abdomen. So in these scenarios, baseline serum ALT, that is LFT, can help us in a diagnosis of biliary pancreatitis. As studies have found that if baseline serum ALT is more than 150 within 48 hours, the chances of biliary pancreatitis is about 85%. Although this criteria has less sensitivity, around 48%, lipase-amylase ratio more than 3 can differentiate alcoholic from non-alcoholic causes of pancreatitis, although contradictory reports are also there. Now coming to prediction of severity. According to revised Atlanta classification, 3 grades of severity has been described: mild, moderate, and severe, based on presence of local complications and organ failure. However, this classification takes about 3 to 4 days, because baseline at the presentation we cannot say whether this pancreatitis is actually mild, moderate, or severe. We can only predict. Because the mortality rate of severe acute pancreatitis, which constitutes about 10% of acute pancreatitis, is very high, 36 to 50%, which is much higher than the overall mortality rate of 3 to 10%. So, determination of predicted severity is important. Also, inadequate treatment in predicted severe cases increases the likelihood of progression to severe pancreatitis. So, prediction is important for predicting the course of illness, predicting the outcomes, as well as formulating the therapeutic strategies. A number of clinical features, laboratory markers, and scoring systems have been developed and described. However, despite a large body of literature, no perfect predictor is available as of today. Most predictors have high negative predictive value but limited positive predictive value. Combination of predictors may be helpful but cumbersome to use. These are the classical scoring system. Age long, like ransom and CT severity index, not helpful at all, because they take time. At baseline, their value is very limited. Apache 2 is probably the most validated one, superior to most other score, and it stood the test of time most of the time. But again, it is cumbersome to use in routine clinical practice. Apache 2 score more than 8 suggests severe acute pancreatitis, mortality rate 11 to 80%. Recently, another scoring system that has gained popularity is bicep score, which is based on very simple parameters: blood urea, nitrogen, impaired mentation, SIRS, age more than 60, and presence of pleural effusion. 1 for each point and 1 point for each parameters. And if score is more than 3, it is associated with high mortality. And interestingly, bicep score within first 24 hours predict the severity with accuracy similar to Apache 2. So this is very simple score which can be used in our day-to-day clinical practice. In absence of any ideal predictors, most of the experts and reviews recommend use of simple predictors at admission, multiple predictors in fact, along with clinical judgment. So these predictors are hematocrit more than 43, blood urea nitrogen more than 25, pleural effusion at advanced age, CRP more than 150 at 48 hours, and SIRS at admission and 48 hours. Coming to another important issue, that is fluid management in acute pancreatitis. Fluid management is important because most of the patients of acute pancreatitis has varying level of fluid deficit. The causes are vomiting, poor intake, diaphoresis, and most important in severe acute pancreatitis is fluid sequestration. Prospective studies have found fluid sequestration is about 3.2 liters in severe acute pancreatitis. So IV fluid hydration is important for replenishment of fluid deficit. It also ensures the better pancreatic perfusion, possibly also help in excretion of cytokines by forced diuresis. Studies have found that early hydration may maintain microcirculations, prevent necrosis of pancreas, and improve outcome. So when it comes to making decisions about fluid resuscitation, many questions come up like which fluid, what volume, what rate, and what should they target. There is no confusion about between crystalloid and colloid. Crystalloid is better because of septic ulcer and associated with colloid. And among crystalloid, we have two main options, normal saline and renal lactate. We can see here both are isotonic fluid, and there is some concern with normal saline because it can cause hyperchloremic acidosis, and in acidic pH there may be more activation of pancreatic enzymes and increased production of pro-inflammatory cytokines. And also chloride load can cause acute kidney injury. Lactate has aged over this from this aspect because lactate can be converted to bicarbonate in liver, and that will help balancing the acidosis. Decrease in inflammation has also been found associated with use of lactate because it inhibits lipopolysaccharide-induced macrophage activation. Also, calcium ringer lactate can bind with non-esterified fatty acid to reduce inflammation. So, lactate RL has certainly aged over normal saline. In fact, 4 randomized control trial has found lactate to be better than normal saline in terms of reduction in inflammatory parameters and length of hospitalization. So far, evidence suggests that ringer lactate should be the fluid of choice when it comes to resuscitation of a patient with acute pancreatitis. There is more challenge about rate and volume of fluid due to conflicting data from the randomized control trials. 5 RCTs compared aggressive versus non-aggressive fluid therapy. And benefit of aggressive fluid therapy was noted only in one trial in patients with mild acute pancreatitis, while two trials from China reported worse outcome with aggressive fluid therapy. And patients were severe acute pancreatitis. The problem with aggressive fluid therapy in patients with severe acute pancreatitis is most of these patients have high capillary permeability. So aggressive fluid therapy may aggravate the vascular leak, sequestration, and tissue hypoxemia, leading to organ dysfunction. Recently, last the waterfall trial was published in NEJM, which compared aggressive fluid therapy versus moderate fluid therapy. And in moderate group, 1.5 ml per kg per hour fluid was given, and with additional 10 ml per kg only when there was evidence of hypovolemia. And it was found that moderate resuscitation was equally effective in preventing moderate to severe pancreatitis. And in contrast, the fluid overload was significantly higher in patients with aggressive resuscitation than moderate. And this clearly suggests that moderate fluid resuscitation is better than the aggressive fluid resuscitation. Because acute pancreatitis is a dynamic condition, one should always monitor the adequacy of hydration. And the frequency of monitoring can be every 8 to 12 hour intervals. And both over and under hydration is detrimental, so the fluid therapy has to be adjusted according to the demand. Many targets has been suggested. The commonly used are mean arterial pressure more than 65, urine output more than 0.5 ml per kg per hour, blood urea natural less than 20, and hematocrit less than about 35 to 44. Recently, ultrasound guided IBC diameter 2 to 3 centimeter below the above atrial junction was advocated by some group. If IBC is more than 2.5 centimeter or collapsibility during inspiration is less than 50%, one should suspect fluid overload. So coming to conclusion about the fluid volume, use of early fluid with moderate strategy is better, 1.5 ml per kg per hour or ringer lactate. Those with hypovolemia should receive initial bolus of 10 ml per kg. In general, daily fluid volume should not cross beyond 4 liters, and fluid requirement must be assessed periodically. There is a little confusion about prophylactic antibiotic, where most of the guidelines are against it, except Japanese guidelines, which recommend prophylactic antibiotic in severe acute pancreatitis during first 72 hours. However, meta-analysis has clearly shown no benefit of prophylactic antibiotic when it comes to rate of infected necrosis, requirement of surgery, or mortality. So, even prophylactic antibiotic may increase the risk of drug-resistant bacteria and fungal infection. Coming to pain management, Uh, Most guidelines again non-committal on the analgesia management, mainly because of paucity of high-quality evidence. Opioid and NSAID are among the most frequently prescribed. There are some concern about use of opioid that it might trigger the spasm of sphincter of eye and exacerbate ileus of the small intestine. However, in a meta-analysis, these concerns were not very evident. And this is the meta-analysis of 12 RCTs. No significant difference was found between opioid and non-opioid with regard to pain score, clinical outcome, and adverse events. However, opioid were found to be superior to non-opioid with regard to need of rescue analgesia. So, in absence of proper guidelines, what we can follow is the analgesic ladder as suggested by WHO. We can increase the analgesia in a stepwise manner, starting from the low-potent opioid or NSAID to high-potent opioid, and finally interventional treatment like subdural anesthesia, something like that, epidural. Coming to another important aspect, that is nutrition. Most of patients of acute pancreatitis are prone to malnutrition because of various reasons. So they require nutrition. The earlier concept of nil per oral and pancreatic rest is not advocated as of today because it has been found that the injured acinus is not doesn't respond to the increased physiological stimulus. Also, fasting impairs the blood mucosal barrier and facilitate bacterial translocation. Meta-analysis of 11 studies have found harmful effect with TPN. So early enteral nutrition is now recommended. This is meta-analysis of 8 studies which found that early enteral nutrition in predicted severe or severe acute pancreatitis shows significant reduction in multi-organ failure and pancreatic-related infection. However, such benefit was not observed in patients with mild to moderate acute pancreatitis. The only condition where probably we can avoid early nutrition is hypertriglyceridemia-induced acute pancreatitis in order to expedite the clearance of circulating triglyceride. Despite lack of evidence in mild to moderate, AGA technical review and guidelines recommend early feeding within 24 hours for all patients with acute pancreatitis, irrespective of severity. Start with liquid immediately. If tolerated, proceed with the low-fat diet. If patient is unable to tolerate by mouth, after 3 to 5 days, consider tube feeding. And between tube feeding, both nasojejunal and nasogastric has been found to be equivalent in 2 meta-analyses. However, there is some concern with nasogastric feeding is that it may stimulate pancreatic secretion and exacerbate inflammatory process. However, the data of detrimental effect has not been shown. Few slides about some unconventional therapy which might require in some patients, like use of anticoagulation, octreotide, and ulunestatin. Splanchnic venous thrombosis can occur in about 16% patients with severe acute pancreatitis, and there is no clear-cut guidelines whether these patients should be anticoagulated or not. There is no RCT on this aspect, and if at all we decide, the benefit has to be weighed against the risk of bleeding complication, also the future requirement of invasive intervention. This is a systematic review of 16 observational studies where around 46% of patients received anticoagulation therapy. Recanalization rate was statistically similar between those anticoagulated or not, although the bleeding complication was greater in those who received anticoagulant therapy. So evidence so far is against the use of anticoagulation. Regarding octreotide, is commonly used in some Asian country. The basis is to reduce pancreatic secretion in order to avoid the further autodigestion. However, randomized control trial revealed no statistical difference in patients' outcome when comparing to octreotide, somatostatin, or placebo. So international guidelines do not recommend use of somatostatin or octreotide. Ulunestatin is a broad-spectrum serine protease inhibitor broadly used in many Asian countries and also recommended by some Chinese guidelines. However, no quality data available in a recent systematic review did not find any sufficient evidence to support use of ulunestatin in acute pancreatitis. I think we close with this slide. Any questions?
Mr. Ramesh, you have nicely summarized acute pancreatitis in such a short period, such a vast subject. I have three queries. Three queries. One is, you have shown data that 75% of etiological factor are either alcohol or gallstone. These are Western figure. I am not interested. I am interested if you can tell you or anyone what is the figure in India and what is the figure in Bihar. Both figures, if you can quote me, I will be happy. So this is one. You can answer one by one so that.
I don't think, sir, our situation is different. Gallstone is highly prevalent in our area. So I think we see here more of gallstone-induced pancreatitis, more than 60 to 70%. And alcohol, of course, because it is banned over here, so now we are seeing less of. But I'm not very aware of Indian studies, but I think the situation is same. So.
I would request you to put Indian data rather than, it's all right, you have quoted Western figure, but our figure should also be there. Second query was, you have highlighted diclofenac and put a chart which is used for cancer pain and any other type of pain. I am not sure whether diclofenac can be given in acute pancreatitis. So just, I am not a physician, so I want this point to be clarified, whether Dalona should be given or should not be given.
Yeah, it should be. It can be given. In fact, many studies have been have used diclofenac. Only issue is the risk of peptic ulceration, and it cannot be given in patient with concomitant renal failure. Otherwise, it can be given. So mild.
Third and the last query is regarding little longer. If the gallstone is there, let me complete question. Whether if the gallstone is present, should we treat it as biliary pancreatitis? Number two, if the no gallstone but the CBD diameter is say 7 mm, what should we consider? And you have just highlighted ALT. What is about alkaline or GGPT and other things? One, since we have, as you said rightly, that we come across more biliary pancreatitis, so we should be able to pinpoint, yes, this patient is in that group. Can you just clarify? Thank you.
What happened in case of biliary pancreatitis? Most of the time there has to be some stone in CBD, but after an episode, majority of times a stone passes on its own. So we don't have to do anything. This is particularly can be the case where CBD is dilated mildly. But in case there is a persistent jaundice or evidence of cholangitis, we have to go for early ERCP. Otherwise, stone normally pass out. And there are recommendations also that if CBD is dilated, one can consider EUS before going for ERCP.
Sorry, my question was not regarding the treatment. I just, when we can call that this is a biliary pancreatitis, if the gallstone is present, say 10 mm stone is present and everything else is normal, SGPT and CBD is diameter, would you call it biliary pancreatitis or you will call it idiopathic or alcoholic? That was one. Similarly, if no gallstone but CBD diameter is 7 mm, for example, can we call it, it could be, or we will just rely on the alkaline phosphatase and ALP? That was my
question. Sir, if CBD, only the guideline says if the baseline LFT is deranged, especially ALT, there is no data about alkaline phosphatase and other parameters, but serum SGPT is elevated more than 150 within 48 hours, the chances of biliary etiology is 88%. If it is there, you can, and if patient has gallstone and pancreatitis and LFT is normal, so it is very difficult to say whether it is there is a causal association, but one can presume it to be a cause.
Yeah, Dr. Ramesh, very nice talk. Excellent presentation. And I have three questions, Ramesh. First, many patients of acute pancreatitis present with intra-abdominal hypertension. So what should be the fluid management in such type of case? Second question is, what is the duration of this aggressive or moderately aggressive fluid resuscitations? And third, in most of our cases come as biliary acute pancreatitis. So any role of antibiotic in this particular subset of patient, because there are also some form of cholangitis, associated cholangitis. So no antibiotic policy is applicable for biliary pancreatitis also, or it is applicable for only alcoholic?
First question is regarding abdominal compartment syndrome. It is very common in severe acute pancreatitis. So obviously it is related to overhydration also. So once there is evidence of abdominal compartment syndrome, one should avoid excessive fluid resuscitation. That is one point. And other, I don't think there is any specific therapy except for putting rice tube and try to decompress the bowel loop and use prokinetics and all. It is difficult to diagnose clinically because there is a two method, direct and indirect. Direct method requires placement of catheter in the peritoneal cavity. Most of the time we follow the indirect method. We measure the pressure of bladder or stomach. If it is more than say 12 mm of mercury, then we can make diagnosis. Second question was regarding
duration of fluid.
Duration of fluid. Most of the guidelines suggest now we have to give fluid as per the requirement. We have to see the monitor parameters, like I said, some of the targets. But first, after 1 or 2 days, after 48 hours, there is no use of excessive fluid hydration. Most of the time, it requires within first 12 to 24 hours when it comes to giving aggressive hydration. Even waterfall trial given aggressive hydration for 48 hours. And in moderate hydration group, the fluid was reduced once patient start having tolerating the oral fluid.
Just interrupting, in Indian scenario, most of the patients come after 12 to 24 hours because they are from the periphery or something. Then you consider for aggressive fluid management in this patient, or you consider that from the zero time? What should be time?
We have to consider from onset of pancreatitis actually.
Most of the patients do not.
If patient comes very late, then there is no point in giving aggressive fluid, or you can gauge as per the patient requirement. If hematocrit is high, blood urea nitrogen high, you can give.
Last question was antibiotic in biliary.
Antibiotic, I'm not sure if patient has biliary pancreatitis or suspicion of cholangitis, we must give antibiotic. If counts is high or patient has jaundice, it's better to give antibiotic. There's no harm in giving that.
A couple of short comments and question also. First, to Dr. Khandelwal's observation, I think taken together, alcohol and gallstone disease do make more than 80% of cases. You said 75%. There may be difference in proportion in Western and our data, but taken together, there is no difference in the statistics. That's number one observation. Second, you very rightly spoke against very aggressive fluid therapy. I remember 6 months ago losing a patient who had COPD and post-ERCP pancreatitis because of fluid overload, losing him because over-aggressive therapy was done. Third is use of antibiotic. I'm sure nobody does it here in this audience, but the common practice is that the total count goes up and the antibiotic is jacked up. One has to remember that pancreatitis is a non-infective inflammation. And since it's an inflammation, so total count is bound to rise. So total count of WBC cannot be an indicator of using antibiotic or jacking up antibiotic. Small question from you, the data of anticoagulant in acute splenic vein thrombosis you used, what anticoagulants were used? Heparin or the low molecular weight heparin or newer anticoagulant?
Low molecular heparin.
Okay. And still patient bled to the extent you quoted?
Yeah, 20%.
Okay. Thank you.
So normally heparin is given for initial period of time, then overlapping with oral.
Yeah, so basically following up on Dr. Khandelwal's question about the etiology, like if you find big gallstones, whether it is not. Similarly, when would you call a patient who has got an history of alcohol intake, may not be that significant. Whether he, I mean, how do you decide whether to dub him alcoholic pancreatitis or not?
It's a difficult question, but alcoholic pancreatitis, if patient has significant history of alcohol consumption, at least for 5 years, with recent drinking, and we can call it alcoholic pancreatitis if other etiology is not found. Especially, there are some parameters like transferrin deficient, carbohydrate deficient transferrin, and lipase amylase ratio. These can predict, but there is no 100% accuracy in that.
So regarding fluid management of acute pancreatitis, I only want to say the hyperperfusion of pancreas should not be the goal of fluid management. The one should give the fluid according to patient's need, and in my view, if the patient come to you and just do ultrasound and take the IVC diameter, measure at 2 to 3 centimeter distal to the cava atrial junction. If the IVC diameter is more than 2.5, do not overhydrate. If the diameter is less than 1.5, give the aggressive fluid therapy. If it is in between 1.5 and 2.5, just do the collapsibility index.
Yes.
If the index is less than 50%, then do not overhydrate. And if it is less than more than 50%, aggressively hydrate. In addition to that, do the point of care ultrasound, bedside ultrasound, and if of lung, if there is a evidence of the fluid in the form of the curly B line and something else, do not overhydrate. And regarding the rate of fluid, the waterfall trial clearly said that the fluid rate should be the 1.5 ml per kg per hour and 10 ml per kg if the patient is hypovolemic. But the other trials also said, according to the Baxbaum or the CLO trial, the first give the bolus followed by either the 3 ml or 1.5 ml per kg. But in clinical practice line, I think the IVC diameter and the point of care ultrasound should be done prior to deciding the rate of fluid therapy.
Yeah, I think fully agree with your points. I think. Yeah.
Dr. Ramesh, nice talk. My query was related to inflammatory markers. The whole story revolves around the inflammatory mediator IL-6, 10, TNF and all. The issue with modifying those activity related to drugs evolved was targeted to 1 or 2 inflammatory markers that are very less. So I just wanted to know from you recent work on dampening those response interleukin storm in acute pancreatitis, particularly early stage. Has some recent work been done to dampen those effects like cytoparesis and all? Do we have any data on that?
I'm not sure about this point, but there are so many cytokines which are elevated. Their predictive ability has been tested, like IL-6, TNF alpha, CRP also. But in general, the therapy of acute pancreatitis is supportive. There is no role of any anti-inflammatory kind of treatment, or I'm not aware of plasmapheresis in patient with acute pancreatitis.
So with this, if one query, last question, please.
Good morning, sir. Sir, I have a query. Like, if a patient with chronic liver disease who is decompensated and he presents with acute pancreatitis on day 1, then how to manage the fluid therapy in that patient? Because we have to keep that patient with lower fluid intake per day, around 1 to 1.5 liters.
You have to monitor the same parameter. I don't think there is separate guidelines with chronic liver disease patient. But if ascites, if the pre-event fluid condition is not bad, you can give the fluid as per the requirement.
If patient is having tense ascites or moderate ascites with pedal edema,
then you have to gauge the situation. I mean, if pancreatitis is going to be severe, you have to hydrate.
Usually, alcoholic pancreatitis and alcohol-related CLD are very common, and most of the time we don't know how to manage this fluid, because for aggressive treatment we have to give more amount of fluid.
No, you can follow moderate resuscitation and closely monitor, maybe every 6 hourly or so. If there is evidence of fluid overload, you can stop at right at that point.
So it was a crisp and simple presentation, Dr. Ramesh.
Thank you.
Many congratulations and a nice interacting discussion.
Thank you,
We
Dr.
should wind up
Ramesh.
the session now.
Now I request chairpersons to present a memento and salt to Dr. Ramesh. Now we move to the second session. The chairperson for the second sessions are Dr. 𝗟𝗜𝗙𝗙𝗓, who is a senior GI surgeon in Patna. Dr. Ashish Jha, who is associate professor of gastroenterology in IGMS Patna, and Dr. Priyaranjan, who is a senior GI surgeon in Patna. Now the speaker for the next session is a renowned gastroenterologist from AIG Hyderabad, Dr. Sandeep Ladkhatia, who did his MBBS from Allahabad, MD from PGI Chandigarh, and DM from SGPGI Lucknow. He has a vast experience in endoscopic ultrasound and related procedures. He will be speaking on, on the endotherapy of pancreatic diseases. Sir, please.
Thank you, Amit. Good morning, everybody. At the outset, I would like to thank Dr. Vijay Prakash and the entire gastroenterologist team at Patna for inviting me here. Amit, little clarification, I did my MBBS from Maulana Azad Medical College, although I belong to Allahabad, but I studied in MAMC first, and then PJ Chandigarh, and then Sanjay Gandhi PJ. But I was amazed by the talk. Ramesh, you gave a fantastic talk, and the level of awareness is commendable. Thank you very much for all of you. So I'll be speaking on endotherapy of in pancreatic diseases. This also is a vast topic, but I try to minimize it or tailor it to the requirements that are there. So in this, I would like to cover where are the endotherapy required in acute pancreatitis, chronic pancreatitis, in tumors and cystic neoplasms, and the endoscopic method that we generally use is by ERCP, EUS, and lithotripsy because of chronic calcific pancreatitis. So, limiting myself first to acute pancreatitis, as Dr. 𝗟𝗏𝗙𝗓 very rightly pointed out, what is the whether presence of gallstones and pancreatitis, is it a cause and effect relationship, or gallstones are innocent bystanders, is very, very important. We should not undertake an unnecessary cholecystectomy in a patient who has other cause of pancreatitis, because he'll come back with the same problem after the surgery too. Sometimes there are other causes which are mistaught, which may mimic a biliary cause. Is a pancreatic biliary tumors. A small located tumor in the head of the pancreas or ampullary lesions can cause pancreatitis, especially in elderly. Beyond 60, start thinking in those things as well. It can go up to 3 to 10% in that population of high. Plus the advantage of EUS sometimes, which helps in differentiating these things, is it has no contrast to be given, so it is safe and identifies also the collections if they are happening to occur. So the most important indication which Ramesh was alluding to is the need of ERCP is very, very low in acute biliary pancreatitis. The only indication which is clear cut is somebody is having pancreatitis and cholangitis. Difficult to differentiate, but rising TLC, rising abnormal bilirubin or LFTs mark us towards that direction. Or if you have an impacted ampullary stone which is not passed out, which is likely to, but that can keep increasing the PD pressure, so that also can be considered for the ERCP. If these two things are there, cholangitis has been proven without doubt, but how to confirm is debatable, which we can keep discussing. So that's why we often resort to an EUS at the early onset of pancreatitis to confirm the diagnosis. If the patient is clinically deteriorating, as an abnormal liver function test in the first 24 hours itself. Very tiny stones may be picked up. I'll just replay this patient who had acute pancreatitis. You see this is a bile duct which is normal caliber, but these are very tiny stones causing a shadow below. Maybe we can switch off this light so that the videos can be seen better. I'll control from it. Thank you. This is another patient which did not have pancreatitis, and look at this pancreas, and you see these stones will be seen very nicely here. These are the tiny stones. Let me move it forward first. And you see many stones in the bile duct which is dilated above. But here the pancreas is normal. So it is difficult to pick up stones in the bile duct also. Sometimes they can be so small, and somebody has to really spend time in confirming the diagnosis. So that's the main role of the endoscopic part during the early phase of pancreatitis, to differentiate what is the cause and if something needs to be done on that cause. It's in the later phase of acute pancreatitis, somewhere around the 4 weeks or so of the acute severe pancreatitis, when the collections start forming, and there EUS comes into picture of draining these collections. So I will address this section of the talk on drainage of the endoscopic drainage of pancreatic fluid collections. And we often have CT and EUS and MRI if required to find out how severe the pancreatitis is, how big is the collection, where it's located, what are the other things which are happening in the pancreas, are there pseudoaneurysm, collaterals, and so on and so forth. And EUS generally has a better interpretation of the collection maturity. But the best imaging actually is an MRI, which will tell you how large the collection is, how much is a rough percentage of debris. The current CT scans also are quite good. They tell about the maturity and the vascular part of it, but the debris estimation is suboptimal by CT scan. It is better by MRI and better by EUS. I will tell you why this is important in later part of the talk. Also, EUS tells us, is there any collaterals on the way? If you have to go through it, we should be avoiding those vessels so that bleed does not happen. How much is the rough percentage of debris in context of the over volume of the collection? And the indications are pretty standard, which all of you I'm sure are aware of it. If any collection which is infected is having refractory abdominal pain or is causing any critical luminal obstruction, is it esophageal outlet or gastric outlet or biliary obstruction, or the patient is just not improving in spite of the best supportive care. And there are several ways of draining these collections. It can be percutaneous, endoscopic, and surgical. More and more endoscopic drainage is being done. I was talking to the surgical colleague before, and of this, EUS is now coming more and more because of ability to bulge not only the bulging collections, but also avoiding the blood vessels which can be on the way. So the major advantage which EUS or endoscopic ultrasound offers in draining the pancreatic fluid collection is improves localization, visualization, and avoidance of blood vessels in the wall of the collection. Select the best entry point, which is generally the thinnest point or the most inferior point from the gravity perspective, and ability to puncture the non-bulging collections or even the little distant collections as well. The only drawback which EUS has compared to a duodenoscope, which were used more than 10-15 years for draining these collections, was that the channel diameter of the echo-endoscope or EUS scope is about 3.7 to the largest size, whereas a therapeutic ERCP scope is 4.2 channels. So that will take a 10 French stent assembly easily across, whereas a 10 French stent will go with struggle to the EUS scope. The question then comes often is which stents to use, plastic or a metal stent. Now a lot of metal stents have come, dedicated metal stents specially meant for draining this pancreatic fluid collections, and several of them are available. I'll discuss this in the second part of this section. Is that, but when we drain these collections, generally there are 4 steps to it, which I thought I'll just allude to. Some of you may have seen this slide, but nevertheless it's worth re-seeing them again. So this is a large collection with a debris here. So we puncture with a 19 gauge needle, coil a guide wire inside, which is seen under fluoroscopy, and then any of the 19 gauge needle can be used, and then the guide wire is passed inside. It has to be a long guide wire, at least 450 centimeter the current guide wire that we use also for ERCP, and they should be sufficiently coiled enough so that they accidentally do not slip out at the time of drainage. And once the wire is nicely anchored inside, then you withdraw the needle and leave them inside. Then over this guide wire we pass one of these 2 instruments, either a mechanical bougie or a cystotome, to create a fistula between the stomach and the cyst cavity. Stomach is the commonest route of entry, although sometimes we can go through esophagus and duodenum too, but that we can discuss later on. So 6 French cystotome is the most preferred device which goes over a regular guide wire. How it looks like is this is a cavity wall from the stomach side where the guide wire is inside, and we're passing a tapered catheter or a bougie to go inside. The catheters or the bougies are generally not so stiff and can buckle, and that's why the 6 French cystotome is a much preferred instrument which just burns its way in. And once now we have created a fistula, we dilate this fistula with a balloon, and several calibers of balloon are available. 12, 10 or 15 millimeters from the stomach side is the average one that we use. And once we have dilated good enough, which we can also see by EUS, then we place plastic stents in the next step. So this is the third step. The first step is puncture and wire. Second step is creating the fistula. Third step is dilating the fistula with a balloon. And the fourth and the final step is the stent placement. When we say a balloon dilatation, it also depends on which way we have entered the cyst cavity. If we have entered by the stomach, 10 to 15 millimeters average. 10 is generally for non-infected, non-debris type of collection like pure pseudocyst. 15 millimeters are those with debris or walled-off necrosis. If we happen to go by esophagus, if the pseudocyst or collection is located more in the mediastinum, then we should not dilate too much. 4 or 6 millimeters is good enough. If we go via duodenum, 6 and 8 millimeter balloon is good enough. If you're placing a metal stent, then a small caliber balloon, 4 or 6 millimeters is good enough. So this is how a small caliber balloon dilatation is being done. In the previous video, I showed a large caliber. So this is a Titan balloon being used. So coming to the last step is placing the stent inside. And I said plastic or a metal. The decision to use either one of them is dependent on several factors, including the cost, which is a very important factor. If cost is not a constraint, then if collection has lot of debris inside, which is visible on your EUS at the time of drainage, then we use a metal stent. But if it is very small amount of debris, then we often use only a plastic stent. So whenever we use plastic stents, which are the commonest, have been used more traditionally, we always place 2 plastic stents, never place 1 stent. And when we place 2 stents, that means we need 2 guide wires. It should not happen that we place 1 stent and then try to cannulate that fistulous opening which has been dilated by another wire. Place first 2 wires and then place 2 stents. So this is, first stent has been placed and the second stent is now going beside it. Always these stents have to be a double pigtail stent. Never use a straight stent. The reason being that if you use a straight stent, there is a risk of migration inside the cyst cavity, and then that poses additional challenges and difficulties to you and the patient too. The appearance of fully covered short length biflange metal stents have really made our job very easy. So this is a Nagi stent which was designed by Dr. Reddy, as he is popularly called as Nagi. And this is actually not made by Indian company, this is made by Taivung, a Korean company. Nevertheless, it's a very good stent. It has biflanges, both the flanges are about 26 millimeter diameter, the length is about 2 to 3 centimeters, and the central widest diameter is about 16 millimeter that we commonly use. The assembly is about 10 French, that is about 3.3 millimeters, can easily go after we have dilated with a small balloon. And when you place these stent, the aim is to place in such a way that half the stent is inside the cyst cavity and half is in the stomach. This is quite important. If it is skewed, say 3/4 is inside the cyst cavity and 1/4 in the stomach, there is always a risk of this stent migrating inside the cyst cavity next few days. And then the additional challenges come in when patient may come back with a problem. And this is how a stent would look like if nicely placed. This is how the stent from the flower in the gastric end. You can also see under the fluoroscopy. And if the central most point is the thinnest point, then your position is perfect. If this thinnest point is here, then it's a skewed delivery and one should be aware of it. You can actually pull it back a little bit if it is more in the cavity. But if it is more in the stomach, you cannot push it in. So in that case, sometimes we use a double pigtail plastic stent to keep it anchored so it doesn't accidentally migrates inwards or outwards. Sometimes we see on EUS also a nice final position of the stent like a bow tie. appearance of hot lamps or hot axio stent has really made our life quite easy. They are very effective stents, very easy to place, very good stents. The only drawback is the cost. They are the most expensive stents. So if insurance is taking care of it or the patient can take care of his finances, I think this may be a good stent to use. So let me show how in the cartoon video how it looks like. It has self-delivery mechanism where the operator itself controls everything. There is no dependency on the assistant. It has 4-step delivery system by which we puncture our way in after with burning on hot cautery. Then by adjusting the buttons, we pull back the inner flange, adjust it and fix it to the proximal end of the wall. Then pull the whole assembly backwards and then deploy the gastric end of the flange. The whole delivery procedure would take not more than 2 or 3 minutes in expert hands, and they are quite effective and widely used in the Western world. Let me show you one example of hot lamps or hot axios being used in a patient who had infected wall of necrosis. This is a collection and you can see the debris below. Even the fluid is not very black, it's very turbid as per the appearance. So we knew that this patient, and he was a toxic patient, so we knew that he was having infected pancreatic necrosis. And we burn our way in, and everything can be done bedside. Inside, fluoro also may not be required. I'll just go slow in this video. We hope to show one of these cases today. And once the inner flange is opened up, this is the inner flange getting deployed. So the flange comes up, it hugs the back wall of the pseudocyst or the collection, and then we pull it even more because the length of the stent is only 1 centimeter. But since it's a lumen opposing metal stent, the risk of migrating towards the stomach lumen is much, much lesser. And once it's nicely hugging the wall, then we deploy the gastric end of the stent, and you can see now frank pus draining out of the collection. If need be, we can also place a plastic stent through this. So there are several types of these large caliber dedicated metal stents meant only to drain the pancreatic fluid collections are available. And there are 2 broad categories. LAMS, as the name suggests, lumen opposing metal stent, include 2 stents in this category, Axios and Spaxus. Both are cold as well as a hot version available. The biflange metal stents, which they are biflanged, but they don't have strong lumen opposing capability, which means that they can migrate if you try to push or pull it in. So Nagi is one of them. There are a few more, Plumber and BCF, and some more stents are now available. Whichever stents we place, most of these collections are very efficiently drained, and this is how a collection looks at the start, and this is how it looks when we are planning to remove the stent, which is generally at 3 to 4 weeks period. So when we are placing these stents, we use several imaging. We have 3 imaging available in a typical endoscopy suite, which is endoscopy, EUS and fluoroscopy. Which one to use at which step is mentioned in this table. Inspection we always do by EUS, puncture we always do under EUS vision, guide wire is always placed in the EUS vision, but we also check with fluoroscopy. Fistula creation is always under EUS but also checked on fluoroscopy. Balloon dilatation can be done by EUS, by fluoroscopy and endoscopy, and final step of stent placement is all 3 images together. So we had our own publication almost now 6 years back of use of metal stent, the Nagi stent in wall of necrosis, and we used a step-up approach. In this, all the corrections or wall of corrections were drained by Nagi stent first, and a majority of the collections improved just by drainage of with the Nagi stent. 75% improved out of 205, 153 improving here. But 25% of them still continue to have symptom or new onset symptoms, and these were then managed in an incremental manner by endoscopic method. What we did was we passed an endoscope inside and see if the stent was clogged by the debris, which happens quite often and it's causing the blockage of the stent. We remove this debris which is causing the lumen. If the patient does not improve or the debris is adherent to the back wall and not very loose to take it out, then we place a nasocystic tube and irrigate externally. For 3-4 days we watch such things, and if that does not help, then we fall upon to the direct endoscopic necrosectomy. I'll show a video of that, how we do it. So our incremental success actually increased from 75 to almost 96% if we used this algorithm of management. Of course, radiologists and endoscope and surgeons were with us in this group while we were doing the study. So this is what I meant by declogging. The stent is blocked by debris, but if you take any instrument, especially snare, and try to just grab this with a snare delicately, then you can pull it out and the stent lumen remains open. You can also peep inside the cyst cavity and any loose debris can also be pulled back at the same sitting. If this does not work out, then we place this neocystic tube which irrigate externally with saline, and if that doesn't happen, then we It's okay. Can you see the video? It's okay. Fine. Okay, then it's fine. So then we go inside the cyst cavity, either taking the endoscope or the accessories inside, and this is a very labor-intensive procedure. It takes on average half an hour to 45 minutes or even more. You have to irrigate the cyst cavity, so the pump facility should be there in endoscope, and grabbing facility using several instruments which are available now. So the major advantage of all these large caliber metal stents are that they are very easy to deploy, high technical success, they are large diameter, so they have very efficient drainage. They are fully covered, so prevent leakage and perforation, which were happening sometimes with a plastic stent. And since they are self-expandable, any small vessel, if accidentally gets punctured, also gets tamponaded by the self-expansion of these metal stents. And since these stents are saddle or shaped or biflange, the spontaneous migration is very less, but however, once the cyst collapses, the Nagi type of stents can get expelled into the gastric lumen, which is actually a good thing to happen, whereas the lamps sometimes do not migrate or often do not migrate and have to be physically pulled out. And reintervention, if required, can always be done through these stents by doing necrosectomy or other procedures. However, there is still some disadvantages with metal stents. Let me tell you, malposition I mentioned in the beginning, because they have very short length, not like a esophageal stent or a biliary stent where malposition is not so common. Bleedings do happen from the vessels on the far away wall of the collection. So as the collection decompresses, those vessels also come closer to the edge of the stent and may rub against it. So if you feel these stents are soft, even if you rub, the vessels may not bleed, but some of these stents have a very sharp edge and rubbing can cause bleeding or pseudaneurysm formation. So one must be wary, and that's why these stents have to be pulled out after 3 to 4 weeks and never kept indefinitely, unlike plastic stent which can be left inside. Migrations can happen either spontaneously or at necrosectomy, and sometimes they can also be hindrance to the direct endoscopic necrosectomy. What happens is when you go inside the cyst cavity, the debris is on the sides of the flanges, so you cannot reach it, you cannot make a U-turn inside the cyst cavity which is already collapsed. So that's why you have to sometimes pull out the stent, and then these debris will now be more easily accessible. So decision of using which stent then depends on several factors I told earlier, but going clinically, the plastic stents are used in pure pseudocysts which do not have debris, or they have very limited amount of debris, that is 10% or less in the overall proportion of comparison to the overall volume. Those which have large collection or have significant amount of debris, 30% or more, metal stents are preferred. But between 10 and 30, which is a gray zone, you can err on either side and take your own call. So let me show you a direct endoscopic necrosectomy. This is a LAMS, a Nagi stent which is blocked by debris. So we're taking a snare, and a braided snare is preferred. Braided snare because then it catches the debris better. A monofilament snare will slip on it and may not drag it out. Here it was a large chunk which was inside the cavity, so it dragged also the stent into the stomach. I'll show you soon. So this is the necroma which is removed, and now we go into the cyst cavity, into the stomach again, and see that the stent is migrated into the lumen, but that's a good sign to happen because now the pus is freely draining out. So you can remove this stent out of the patient's mouth, keep it by the side, clean it up, and be reloaded and put it back. That's a major advantage of this. And then that's while this is being done, you can actually go inside the cyst cavity, inspect it, and clean up as much as you can. Visualization of the healthy granulation tissue means that your end point is quite near, and sometimes we see very large, big vessels on the base. Having said that, all these things also come with their own adverse events, association, and bleeding, perforation, infection, and embolism have all been known. Air embolism is almost negligible now with the use of carbon dioxide in the most units. A word about EUS guided PD intervention. Pancreatic duct intervention by EUS is very, very uncommon. Most often we manage PD by ERCP, but it's supposed to be the most difficult of all EUS interventions, and it's always a backup option. Unlike in EUS BD, where we drain the biliary system by EUS, we don't have a backup PTBD option like situation in pancreatic duct. And we consider this kind of a procedure only in patients who have chronic pancreatitis where ERCP is failing and not possible and surgery is not being considered for a variety of reasons, or patients who have disconnected pancreatic duct. So this is a disconnected pancreatic duct, as the name suggests, that this is a disconnection between this pancreas and this pancreas because of a stricture-like appearance there. In disconnected pancreatic duct, which follows acute severe pancreatitis, because of necrosis of pancreas and healing by scarring, there is no pancreas tissue in that part. So upstream and downstream, the two bridges are not joined together. It can be a very short disconnection or it can be a large disconnection. As you can see, the red line is a short, one bridge is broken, or here many pillars are broken in the river of our Ganges river. So the juice from the upstream pancreas now is unable to drain out to the duodenal side. So it keeps accumulating here, the duct dilate above, they can have recurrent pancreatitis, or even if this river can rupture and can cause a pseudocyst formation or a ascites or a pleural effusion. So we can drain this part with EUS if need arises, although this requirement is very, very less, as has been shown by earlier publication from our group. Also, sometimes patients have an external pancreatic fistula when they have been drained upfront by a percutaneous catheter or a surgical drainage, and because of the disconnection they keep draining juice, and which can be 50 to 100 ml or even more for months or weeks together, and which is very debilitating to the patient. So let me show an example of a patient who had walled off necrosis, had drainage by a metal stent, then his stent was removed after resolution, and he came back 6 months later with a pancreatic pain. So we tried to, and he had MRCP was showing a dilated PD, so we tried ERCP first and hoping to cross and reach the, but there's nothing going on. We're filling the side branches, but nothing is going in spite of pressure being applied, except for a small residual collection. So we converted immediately to the EUS scope, and you see when we punctured the pancreatic duct, the duct is quite dilated up to the tail, and then we pass a guide wire which actually coiled in that remnant small pseudocyst, and we happen to move the wire towards the tail and place a stent. So this is now draining the upstream pancreas. So in this segment, metal stents are used of the talk. I would just sum it up by saying that for pancreatic, EUS guided pancreatic fluid collections, we use metal stents worn with significant debris, plastic stents for especially for pseudocysts or those worn having minimal debris. Remove all the metal stents if you have placed by 3 to 4 weeks time. Re-intervene only if the patient continues to have symptoms. And EUS PD drainage can be considered occasionally to bail out of crisis. Now changing gears, going to a different part of the pancreas, which is chronic pancreatitis. Sometimes acute pancreatitis leads to chronic pancreatitis over several months to years, and if they are having smaller episodes of pancreatitis. So the prevalence is quite high in India compared to the rest of the world. I'm sure Dr. 𝗟𝗓𝗓 is now a little happy. So it's 125 per lakh population in India compared to Japan, which is the next biggest, and China, West and US is quite less. Etiologies are different in different parts of the world, we can discuss that later. But the chronic pancreatitis poses different sets of challenges to the gastroenterologist and endoscopist. And these are some of the challenges: strictures, duct leak, pseudocyst, CBD stricture, pancreatic malignancy, duodenal narrowing, vascular complication, stone formation. So I'll only be touching about pancreatic strictures and pancreatic stones, rest because it's too long a talk and may bore you then. I don't want to do that. So issues with chronic pancreatitis is the issues within the pancreas and issues outside the pancreas. Within the pancreas, it's stricture and stone formation. Outside the pancreas is bile duct, which is going through the CBD, can get obstructed because of fibrosis. Ductal leaks and pseudocysts can happen. Pain is a predominant system which can be managed by celiac plexus block or neurolysis if nothing else is working. if somebody has a gastroduodenal obstruction, then we have to resort to a surgical option to not only drain the pancreatic duct, but also do a GJ so that he has a relief of outlet obstruction. And vascular complications in the form of venous thrombus also are quite common. Splenic vein and portal vein thrombus are frequent, and they are not to be intervened. This is a debatable area, as Ramesh was alluding to. And aneurysm, if they happen to be occurring either in a setting of acute pancreatitis or a chronic pancreatitis, they need to be tackled even if they are asymptomatic. So touching upon only pancreatic stone and stricture, so this is a diagram from NEJM which shows a surgical option of when the stones are there in the pancreatic head with strictures. We can place stent endoscopically after dilating the stricture, but more often than not, if the stone and stricture are coexisting, then we do a lateral pancreatic jejunostomy, or we ask a surgeon, I don't know, but I ask my surgical colleagues to bail us out by doing a LPJ or a phrase procedure where we lay open the pancreatic head and do a pancreatic jejunostomy. So for PD stone alone, if it's a cause of a problem and causing pain, he started with some other issue, but now he's developed stones, and that is the cause for the pain because of ductal hypertension. This is a premise that we all deal with. Or same thing goes for PD stricture. If duct stricture is dilated and upstream juice is not able to enter the duodenum, then we need to dilate this stricture. So these are the two methods, two major pathophysiological mechanisms by which pain occurs in a chronic pancreatitis setting, and we need to tackle them both individually or together. So looking at only pancreatic stone, the aim of endotherapy is to clear the main pancreatic duct of calculi, especially the downstream pancreas located in the head or body, to reduce ductal hypertension. This is the main aim. And how to break these stones or remove these stones, leaving surgery aside, we break the stone is called lithotripsy, which can be done both intraductally or extraductally. Most of these pancreatic stones for the younger colleagues are calcific and hard, and they have tentacles. And these tentacles, like pseudopodia, go into side branches. So unlike a bile duct stone, which is moving freely inside the bile duct, these stones very rarely are very free floating and are always fixed. And that's why going above them can be a challenge towards the body and tail side. So we need to break these stones. Small PD stones can be removed by ERCP, but that's a rarer situation. Large stone need to be crushed. And how do we do that? Extracorporeal shock wave lithotripsy, or ESW as called, when we give high intense shock waves directly focused on the stones, or internally we can do by laser lithotripsy or EHL. Very rarely we rely on mechanical lithotripsy. So this was a guideline which came from ESG, and me and Dr. Eddy were part of this guidelines both in 2012 and 2015. And this European group suggested that for patients with chronic calcific pancreatitis and pain associated with this, if the stones are 5 mm or bigger in size, obstructing the main pancreatic duct, ESWL should be the first step. So if you have large stones, try to break the stones by extracorporeal shock lithotripsy, followed by ERCP removal of the fragments. This has a very high level of evidence and recommendation, and this is how the stones would look like. This is a stone in the head which was giving shock wave lithotripsy, and after at the ERCP we see all the powdered tiny fragments are draining out, and this is how the ERCP looks like. The moment you clean up the duct, it's near clean. It's a very gratifying, not only on ERCP or professionally, but even the patient has pain relief. But sometimes these stones are not one, but they are more than one, and they can also be in the side branches. So when we do ESW, we will not only fragment the main duct, but we also fragment the side branches. So the whole conglomerate of stones are broken like a hammer, which takes, depending on the hardness and the number, over 2 or 3 days. And when subsequent ERCP then removes the main duct stones, we cannot remove the side branch stones, although we can just flush them out and hope that the fragments will fall in the main duct and then can drain out spontaneously later on. So Dr. Manu Tandon actually led our group, and this was the first publication which we published in Indian Journal of Gastroenterology in 2010, 13 years back, of more than 1,000 patients of ESWL, where we could clear up the pancreatic duct in about 3/4 of the patients, and the best clearance gave the best equivalent pain relief symptoms. Although other 24% did not have complete clearance, but even the partial clearance also helps in draining of the juice, and hence pain relief can occur. This was a similar experience from other European group also, that they had significant pain relief. We went on to then publish our bigger group with a longer follow-up now. This was a 1 year follow-up, now this is a 5-year follow-up. And in this we had two categories, groups of patients which had 2 to 5 years and more than 5 years follow-up, 364 and 272 respectively. And the pain relief was in about 60% or so. So you're likely to improve pain in 3 out of 5 patients in long term if you happen to clean up the duct up front. So how do you select your patients? Which one should go to Dr. Khandelwal and the surgical team, Utkarsh and others, or which one to be handled by us is a decision which is very important. I think those stones which are located in the head, that is on the right side of the spine, are the best managed by endoscopic or ESW treatment. Stones which are head or body can be done by also by ESW and endoscopy, you can consider them. But stones which are plenty, head, neck, body, tail, everything, the whole duct is packed. This is not an ERCP, this is a plain X-ray abdomen. So getting a plain X-ray abdomen sometimes is very useful unless you have a CT up front which is also giving you same information. Then these other patients are best managed by surgery. They can lay open the entire duct, remove all the stones, do the head coring as well, and have a very gratifying results. Dr. Manu Tandon didn't stop here. He went on further and now has 5,000 patients from our group, which was published not 4 years back. Now the figures have gone to about 8,000 or so. And this still continues to show that the results continue to be gratifying at a sustained level as well. So complete clearance was now still above 70% plus, and pain could be relieved in them. What are the other methods? Those who don't have ESW facility, how do they manage? Not everybody is so lucky. So there are other ways, and the Europeans and the Americans are also using this of pancreatoscopy guided lithotripsy. That means they pass the spyglass lithotripter, spyglass inside the PD, and then focus on the stone, and this is an EHL being applied when you touch the stone and apply the generator, and you can fragment these stones. This is again a very labor intensive procedure. It may take at least an hour or so, and then you can break the stones from head towards the body if there are more than one, slowly up, going above the stones. The only problem compared to this versus ESW is that in ESW you can do blanket, like it's like carpet bombing. Whereas here it's only a focus, you can only touch one stone at a time and break it, and then if you cannot break it, you cannot go above it. So that's the difference. So single stone, this may be very good. Stone in the body, it may be very good. But many stones in side branches, I think ESW probably scores over, and it's much easier than that way. Now, going to other segment of this chronic pancreatitis, pancreatic strictures. And pancreatic strictures are managed endoscopically by stenting, and these are generally plastic stents which are preferred most over. They can be straight or single pigtail stents, and the calibers have been varied, 3 to 10 French, but most stents that we use is 7 French or 8.5 or 10 French, and they're most often placed transpapillary by ERCP. The aim of the stent placement during ERCP is to cross the dominant stricture, that is the toughest stricture. If there are two strictures, better to cross both of them, but if the one which is very tight, at least one that must be crossed. And how do you decide at ERCP that you have done it? If you have injected contrast and that's not draining out at the time of ERCP soon after, that means your stent is still not working well and there are other strictures to be tackled. These are several types of stents which are available. We prefer single pigtail stents with this pigtail in the duodenal side. All the straight stents also can be used if the stricture is very tight. The results of these have been reasonable, not phenomenal. The pain relief with a single stent is about 80 to 90%, but that's for a short period of time. And these stents often require exchanges at a finite interval, 3 or 6 months, till the stricture opens up. And the good thing is that even if the stricture opens up by about 1 or 2 millimeters also, that's still gratifying, and the stricture is visible on morphology. The pressure upstream actually comes down and the pain relief happens. So one need not be trying to open a full stricture to the diameter of the upstream duct, but little opening also works quite well. Multiple stents give a better pain relief and a sustained pain relief if required, and this has been shown by several studies from last 2 decades or so. Wilcox summarized this in the meta-analysis of more than 1,500 patients and saw that the benefit was varying from 30 to 100%, and the follow-up period time also was variable in some publications. But the bottom line, he summed up by saying that complete stricture resolution by endoscopy is not needed for resolution of pain. Just marginal opening also relieves your pain, and that's what we want. This was from the Guido Costamagna's group, who did multiple plastic stent placement in patients with chronic pancreatitis, following the same analogy that he used for the benign biliary strictures for the biliary side. So the ESG guidelines once again say that dominant PD stricture should be managed by ERCP by inserting a single 10 French plastic stent, and stent exchange can be done at 3 to 4 months period for at least 1 year, even if the patient is asymptomatic, and then give him a stent-free trial. However, the recommendation is not strong enough, and multiple side-by-side plastic stents can be placed in patients which are not improving by single stents. So this is how the management by endoscopy has evolved. A stricture can be dilated and stents placed, and multiple stents can be placed. What to do for patients who are not improving with this also? And here comes the role of a fully covered metal stent. So quite similar. Do I have time? Another 5 minutes more, I think. Is the use of a fully covered stent, which is quite similar to a biliary stricture management, benign biliary stricture management. The difference here versus biliary is that we have side branches in the pancreas which can also get obstructed by the fully covered stent. In bile duct, we don't have side branch except for the cystic duct, which can also be managed. So that's why there are different stent designs which are available now. Another challenge which is posed by a fully covered stent is when we place these stents for 6 months or more, the inner end of the stent, which is inside the pancreatic duct, causes trauma to the pancreas, and tissue hyperplasia happens at that point, and it can lead to a new stricture formation. So you remove the stent and you saw another stricture which was not there earlier. This is because of the insult to the pancreatic duct by the stent which has been there for inside. So there are few more stent designs, plus fully covered stents also have a challenge of migration, which is also seen in benign biliary stricture fully covered stent management. So this thing has still going on. Better designs are being made, but nothing is concrete and accepted as yet. So indications of pancreatic fully covered stent is only if pancreatic pain is persisting and the plastic single or multiple are not working. There's a dominant stricture which is not getting improved, and the patient is unfit for surgery. Actually, most of us would send them to surgeon so that they get a one-time permanent relief. So the other design is called as a bumpy stent. So this stent has different diameters at different levels, and the purpose of this is not to block the side branches. But even this has their own challenges of a new stricture formation. So the process keeps going on, and nothing has been said as yet. And we had our own publication this year in 2023 in GI endoscopy with a lot of elite group from the world over, including Dr. Reddy and myself were there, but these are the big names of the world who are in endoscopy group. And in this metal stent, which is a soft, fully covered metal stent, also did not show that the relief that we were looking at. So the primary endpoint of this was the relief of pain in the patients who were not improving and the safety of these stent. And the conclusion of the study was that 6-month indwelling time of the stent did not give us the pain relief that we wanted. And migrations were also seen. Hence more studies are required. So that the journey continues of pancreatic stricture management, from single stent to wider caliber stents to multiple stents to metal stent fully covered of different designs, and it continues. So how do you decide which patient goes for whom? So if the patient has a dilated PD with a stricture single, dominant, or a very mild narrowing of the duct, they are best managed by ERCP, by stent placement. But strictures which are very long and complex and have multiple in number, with or without associated collections and stones, are best managed by surgery. So in the end, I would like to sum it up by saying in this section of the talk that large pancreatic duct stones, ESWL is preferred. PD strictures are managed by plastics and preferably single or multiple. Fully covered metal stents should only be considered if they are refractory. I did not cover the benign biliary stricture which can occur with this, and there multiple plastic stents and fully covered stents have been tried and proven to be useful. Thank you very much for your very kind attention.
Thank you, sir. Any question? If you
Then may I ask certain clarification till you want to ask? So you can later on ask. Let me, as a chairperson, clarify certain things, and then of course anyone can ask. Time is not important. You are more important. You are here delivering a talk is more important. It was very informative, at least for me, and very comprehensive, very latest, and including technical tips which you have shown so many things. 3 points have queries in my mind. I will start from the last one. You are an endoscopist, so you have rightly shown so many ways of removing pancreatic stone. But I think most of the surgeons will agree that it is not the issue of only pancreatic duct. We were earlier, I have done lateral pancreatitis where pancreatic stones are removed and jejunum is added. But that has now obsolete. No surgeon does like that. It has to be phrased at least where head coring and all the side branches to be opened, and it should be starting from the head near the duodenum to the tail whole. That is the only standard operation. Whereas whatever you are doing just removing stone like CVD stone and then putting some stent, maybe first ES extracorporeal shock-wave lithotripsy, then one stent, two stent, less plastic, and so here are two issues. Firstly, the ideal way of treating, whether the side branching drainage is important or not. If not, then probably your technique is also good. And secondly, the lengthy process that you have shown, first ESWL, and then, whereas the laparoscopically, will do today, and the patient will go discharged after 3-4 days here in this hospital. So if we compare these two things from patient's angle, what should be the standard one? This is the first question.
I think we can leave it to the patient sometimes and let him decide. Some patients are wary about not doing a surgical procedures, or some want a more permanent relief in one time. So we can discuss this, that it's not a one-time procedure endoscopically. Sometimes we have to do 3 monthly stent exchanges. And if he agrees to that, then he is willing to it. Having said that, there is a publication in NEGM comparing surgery versus endoscopy, which scored heavily in favor of surgery. But that study was a skewed surgery. They did not use ESWL at all in the therapy. They only placed stent. So stent alone in a patient who has stones is not going to solve the problem. How do we remove the stones? Unless we remove a roadblock, the juice cannot flow out. So we need to compare apples with apples and not apples with oranges. But yes, patients who have multiple stones extending all over from head, body to tail and have strictures accompanying, one or more, I think surgery is a better solution. But if we are only single stone or a few stones in one part of the pancreas, if the duct can be drained, the aim is to reduce the ductal hypertension, which is the premise we are working on. Having said that, both surgery and endoscopy is also not foolproof. I am sure all of you must have seen that even if you open the stricture, patients do come back with pain. And what is the mechanism of pain? Even after surgery. If ductal hypertension was the only cause, the best surgical results also are 70% or so. Same goes for endoscopy. So that means there are more mechanisms of pain than just ductal hypertension. And this is where we also have to consider the pancreatic neuropathy and the pancreas is not, and the spinal cord issues. The patient now is used to that pain and it's not only a local problem. So that's another other angle to it.
Yes, sir. I have one question, sir. Sir, basically,
सर के 3 क्वेश्चन थे, अभी एक ही हुआ है.
In pancreatic pseudocyst, an endoscopist has put an EUS plastic stent. Without realizing, you must have come across such cases, without realizing how much is the really necrotic part of it. And then gradually, after say a few weeks, you realize that there is a lot of nephrotic content is still inside, though the cyst has collapsed, but there is necrotic and probably it is infected also. So what is the next step? Whether you would like to put again a EUS guided stent, or you subject them to laparoscopy or some other methods?
That's a great question. So let me answer that. So every attempt should be made to upfront know the percentage or amount of debris in the collection. If it's a pure pseudocyst, I think just putting a straw or a double pigtail stent should work. But if it is debris inside, those plastic stents will drain out the fluid but will not drain out the solid debris. They are not large enough to allow it to drain. In that case, there are two options available. Either we dilate the same, now we don't do EUS, we do only endoscopy. We go beside the plastic stent inside the cyst cavity with a cannula and a guide wire, dilate this opening with a large caliber balloon, 15 millimeter or even more, and then go inside the cyst cavity and try to grab the debris and take it out, either in one sitting or a subsequent sitting, which is done 2 or 3 days apart from each other. This was the policy being done till this metal stents came into appearance. But if this is a situation now, I would actually manage it by passing an EUS scope and placing by another metal stent from other side. So this is called as multi-gate drainage technique. That means now you have 2 exit routes. Also at the same time, I will dilate the first path also and maybe exchange the stents or place a nasocystic tube for irrigation. So there are 2 methods of draining now. If this collection is also extending peripherally, I will also ask my IR colleague to put a percutaneous catheter. These patients are generally sick and also malnourished by now. Once they develop fever, the albumin drops very quickly and surgeons are little wary of doing it. Although we discuss such patients in our multidisciplinary meeting where IR and surgeons are together, we involve surgeons or surgeons are willing to come into picture once there are more than one collections which are deeper inside and not accessible to endoscopic or percutaneous methods. Or they have upfront, say debris is more than 50-75%, then we say that we cannot handle this. This will require 5 sessions or maybe more of necrosectomy, and if even then we will not be successful, why don't you take them upfront only?
Thank you. One last question, then of course I will not ask further. One very common thing that I have at least come across,
Yes, sir.
that a patient has had pancreatic pseudocyst, and whatever indications you have said for the treatment, he is not truly false in that. Particularly you have said persistent abdominal pain or significant pain. This is very difficult to define. The patient has come simply because he has symptom, but his symptom is only a bulge or some fula hua hai, utha hua hai, some mild dragging pain or something, not demanding even analgesic. And it 4 months has passed. The size is say 3 inch, 7-8 centimeter, and what should be next? Should we wait, as we have been taught or we have been teaching, that wait till the symptom, or you just put on your endoscope and do the things?
So again a great question, and that's where some of the recent publications are saying that even those to be drained, because patient is not improving. He has no pain, no fever, no outlet obstruction, but he is not improving. He has lost 15-20 kgs weight and he is hanging on, and suddenly he can deteriorate. So this is a judgment which anybody can take at that point of time, and you can go on either side, you can argue on either side, and both sides are correct. But I am now erring more on the side of draining them for the simple reason that the inflammatory things then can drain out well. Patient starts feeling better because the bloating itself is preventing him to eat sufficiently, which is causing his further malnutrition, and they recover faster, rather than just keeping these collections long inside, and sometimes then they rupture spontaneously into a GI tract, which is okay if it's stomach, okay if it's duodenum, okay if it's jejunum, but if it's colon, again sometimes there can be reverse migration of the fecal matter into the collection, and suddenly he was okay and now he's got severe fever.
But most often they disappear as well.
They disappear not by spontaneous rupture. And that's why sometimes if you see CT, they have air inside it, but that air is coming from the stomach or duodenal side, and not because of just bacteria producing air. It is not because of air producing organism. What I mean to say, whenever you see air inside, that air should be taken in the context of the clinical picture. If patient is absolutely normal, then he has developed a spontaneous fistula which has caused the air to go in.
Sir,
Yes,
thank you, sir, for very comprehensive demonstration for endoscopic technique. Sir, I have a few questions. First, the aim of endotherapy in chronic pancreatitis is not to clear stone, but to relieve pain. And still we do not know what is the cause of pain, whether it is due to stone, stricture, ductal hypertension, or neuropathic pain. So what you have shown that you have 5,000 patients of ESW and endotherapy, I wonder that maybe 50% may recover without any interventions. So what is how you decide that pain is due to stone? Because many cases, fibrocalculus pancreatic diabetes, full of stones, multiple duct dilatation, palpitations, but no pain. So in that case, you will do endotherapy and remove all stone because your philosophy is to clear stone in chronic pancreatitis. I think it is entirely wrong.
No,
Second
that-
thing,
okay.
second thing, I just want to. Most of the chronic pancreatitis patient has some form of head mass, and you are just removing stone and leaving that pancreatic head mass, and which is mainly due to some neuropathic changes, mainly chronic pancreatitis, chronic inflammation in long term causing neural hypertrophy, hyperplasia, what you different nomenclatures are there, mechanical allodynia and something. Unless you remove entire pancreatic head, you cannot relieve pain in chronic pancreatitis. Whatever you do with stones, it is inconsequential. That is my thinking. Third, we are going into evidence-based medicines, and most of the evidence, there are two randomized controlled trials, one by 𝗟𝗓𝗓 and other was DIET. You are telling about DIET trial in randomized controlled trial, but again is 𝗟𝗓𝗓's trial which has ESWL, then endotherapy, and then equally they randomized.
𝗟𝗓𝗓's trial did not have ESWL. They had that was the trial I was mentioning.
But DIET, second DIET trial has used ESWL as well as endotherapy, but results were same, and there is meta-analysis also available. And third, where is clearly shown that surgery is more effective than doing endotherapy. Third is there is even a role of early pancreatic surgery, that is escape trial by Dutch group only, where they tried to remove entire pancreatic head in order to halt that neuropathic changes so that it may not go into central pancreatic neuropathy or peripheral neuropathy. So we have to decide, or we have to actually know what is the cause of pain, whether it is due to somatic pain, whether it is due to neuropathic pain. Still we follow EGBK pain score for all this, what is the outcome. So these are the open topics. So I'm not convinced that 5,000 patients and all undergone endotherapy,
Okay.
all stones. So please give me sight.
Let me answer it one by one. So therapy is only required in patients who have pain. 90% of the chronic pancreatitis will have pain. Those 10% those who have painless chronic pancreatitis are not to be touched by any endotherapy, not even surgery. Okay. I am so glad that you are more well read than most of the physicians actually, that this pancreatic neuropathy is a very important subject. We all treat these patients on the premise that they have ductal hypertension. But nobody actually measures the ductal pressure. Even during surgery, you don't put a catheter inside and see whether the duct is high or not. I think that's one thing we should start doing it, and we have done a very preliminary work, which is actually a copy of done almost 50 years back when they were putting the catheter in the pancreatic duct of animals and the humans to find the ductal pressures in patients of different diseases. Very recently we have done, which was also in DDW last year in the abstract form with Johns Hopkins group, we pass a guide wire in the pancreas of patients who are coming for some endotherapy of measuring the pressure inside the duct. This guide wire is a pressure sensor. This is the same guide wire which is also used by the cardiologists when they put a coronary stent. They pass this wire, measure the pressure across the narrowing in the coronaries, and once they place the stent, they again measure the pressure. So whether the significant drop has occurred. So same wire we have used, and we found that those patients who have higher pressure, although it's a very pilot study of 10 odd patients only, that those who had higher pressure actually benefited by endoscopic therapy. The drawback of this pilot study was that we could not put wires deep inside in patients who had significant amount of stones. So only strictures which could be caused by the guide wire or smaller amount of stones. So we have a heterogeneous group, but still good enough to tell us, and this study is still ongoing, hopefully we'll get you more publication. Rupjyoti Talukdar from our group is also looking at the pancreatic neuropathy part of it, and even the spinal stimulation and the brain stimulation part of it, including EEG changes and the NMR changes also inside. And he's found that there are permanent changes in the spinal cord and the nerves and the brain which carry on the pain sensation in spite of that management, whichever way we do. In fact, the group from Denmark, Osborne, who is one of the first authors in this, along with our group, is now collaborating in a study that not to do anything and just treating them with neuromodulators, that pregabalin and those kind of medicines, versus ESW and those things. So that has been done now, and hopefully we'll have a publication with the
symptom leave.
Yeah, because you see, even if you do a total pancreatectomy, which has been done by the Minnesota group, pain still persists. Now you've removed ductal hypertension, you the nerves around it, you've removed the head of the pancreas, but still pain persists. So how is it happening? So it's a phantom thing which is happening. So if we can define this upfront, then we can select our strategies of which way to go.
Thank you, sir.
Thank you, sir. One question regarding this metal versus plastic. Do you really think metal stent is superior even in a significant WPN with significant necrosis? Because study have shown it's equal, and if we have the adequate dilatation, it is probably works same. And although rare, but complication of inward migrated lamps or bleeding is a nightmare. Patient have to land up in surgery if patient is migrated. In our experience, because of long follow-up, patient lost follow-up, then it migrated inward, then ultimately went for surgery, and you have a lot of experience. So after going through this slide, actually message is LAMS is superior in all WPN except pseudocyst. We need clarification here.
So the clarification is still not there in literature. There are evidence both in favor and against it. Some of the meta-analysis have actually shown that the LAMS is superior. However, some studies from the Dutch Pancreatitis group and Shyam Vadraju group said that plastic is as good as metal. But now we not only use that evidence but even experience-based medicine, and I feel the metal stents are better because they take out the debris also. Either spontaneously or mechanically we can pull it out, which is not possible with a plastic stent, unless it is a very loose debris which gets liquefied with passage of time and then drains beside the plastic stents.
I think if we place the two 10 French gauge plastic stent instead of 7 French gauge.
Look, 10 French and 7 French plastic stents is hardly a difference, 2 millimeter versus 3 millimeters. How would a chunk of tissue which is 4 or 5 centimeters as removed by surgery will come through that? It will not, it comes actually beside it, and that's why one stent is never to be used. Two stents are always better, because even if those two will get blocked, the juice actually drains beside the between the two stents like a wick. So metal is always better. I still feel so, although the data is not very hard, but I think the experience and evidence is pointing towards it.
Thank you, sir.
Difference in the cost is just
So cost is huge. So
plastic and plastic.
we have an industry person here who can answer that cost. so a hot lamps versus cold lamps, the cost is different.
Thank you, sir.
Thank
Thank
you,
you, sir. Now I request chairpersons to please give a memento to sir.
Slight change in sequence. We'll break for the tea for 15-20 minutes, and 11:30 we'll reassemble. In the meantime, Dr. Sandeep will move to endoscopy room and will start showing us the procedure. Dr. Pankaj will go with him. I request the auditorium floor to be conducted and controlled by Dr. Priyaranjan, Dr. Deepak, and Dr. Ashish Jha. So, while Dr. Sandeep is doing the procedure, you three will conduct the session here. Articulated by you, is a very valid concern.
एक एक जानकारी आउट ऑफ मैंने दे देना चाहता हूँ। एक नेक्स्ट ईयर 2024 में हम लोग मिल करके ऑल इंडिया कॉन्फ्रेंस कर रहे हैं सर्जिकल गैस्ट्रोएंटरोलॉजी का। कोई उसको अपने से अलग न समझे, चाहे फिजिशियन हो। सर हम लोग ये पूरे बिहार की और पटना की और गैस्ट्रोएंटरोलॉजिस्ट का एक ऑनर है कि हम लोग को ऑल इंडिया बेसिस पर ऑल इंडिया कॉन्फ्रेंस करने का नेक्स्ट हम लोगों ने डेट फिक्स कर लिया है और काम आगे बढ़ रहा है, लेकिन होपफुली ये हम लोग इसको करेंगे ज्ञान भवन में। और डेट भी अक्टूबर, कितना डेट है याद नहीं पड़ रहा है। डेट हम लोगों ने डेट भी फिक्स किया है, वेन्यू भी फिक्स, हाँ कुछ डेट है उसमें 3 से 5 है। तो वो इसलिए बता रहे हैं कि थोड़ा आप लोग उस समय में सब लोगों को इन्वॉल्व होना भी है और देखने भी। ठीक, थैंक यू।
Hello. Good afternoon, everyone. So, the first case which we are going to take is a case of 37-year-old male who had an episode of acute pancreatitis of CT severity index of 8/10 in the first week of June. Then subsequently he developed pressure symptoms in the form of vomiting, and he was not able to tolerate diet. Upper GI endoscopy was done.
ऊपर पूछ लेना। हेलो, ऑन है माइक? एक मिनट रुक जाता, गॉस जल्दी लगा है। ठीक। हेलो हेलो, बस ठीक है, हो गया। थैंक यू। आ जाएगा, फ्लोर आगे आ जाएगा ना जब जरूरत पड़ेगा। ठीक। स्टार्ट करो तो बताना जब, यू टेल मी। हाँ, you can see me? Hello, Ashish, you can hear me? Hello, I can hear you. Can you hear me? Hello, मेरी आवाज आ रही है? Who's chairing upstairs?
Dr. 𝗟𝗓𝗓 Banka.
Okay. Amit, we can start then. Do you have the history?
Okay, should we start?
So as we heard probably earlier is that this patient has a large pancreatic fluid collection. So I'm passing a linear EOS scope. We can actually see the little bit of lumen when we go. हाँ आई थिंक इसका प्रॉब्लम ये बटन का प्रॉब्लम है. Okay, so now it's much better. I have reduced the contents of the stomach, and if you want, we can measure the diameter of the collection. So we'll measure the largest. This is 61 in but this is 45, so not so big. It was much bigger in the CT scan, 15. So maybe is there any rupture which has happened, or is there extension which now this area has more. This is actually air outside. I'll keep moving it around and see. Sometimes there is a paracolic extension which may not be seen very nicely. So this is there, and then it stops. Okay. I'll also go to the duodenum and see the. हाँ हाँ ठीक है, अब ठीक है. So that's the bile duct on top. This is the bile duct, just slightly dilated. Let me measure the diameter of it just to complete the whole examination. 6.7, it's okay, not too dilated. And that's the gallbladder on top, which you can see is anechoic, not fully distended but reasonably okay. I was told the portal vein is thrombosed, but here it looks to be normal. This is a portal vein. The big structure on the not so many there are there, but yeah, this is partly because of inflammation. This is not because of these are small collateral the duodenal wall. But and the CT initially it was mentioned there's some partial portal vein thrombosis. So I've shortened the scope just like the ERCP scope, and now on the right side is the head of the pancreas, which is this is a PD which is in the head. Can you see that? So that's a nice thin PD in the head, and that's a CBD. So this is a CBD, and if I anti-clockwise turn, I see the PD here. This is a thin PD, which is normal. I'll park it here, the D, and unfreeze it. And this is a very heterogeneous pancreas in the neck area. As I pull back my scope to the stomach. This is still the PD. You can see the PD there, very nice PD. Oh, that's a PD now. Nice looking PD extending from head to almost now mid body. So that's a good sign. Now there's edema around. This is the edema in the gastro wall next to the anterior to the pancreas, so between the stomach and as I pull back more, now you start seeing the collection. So collection is more in the distal body and
so this
tail
collection
area
is not communicating with the pancreatic duct?
I cannot say that. I haven't. Sometimes it's very difficult to say. It's better to see later on. So let's do the drainage now. Let's go to the procedure proper. And this is a very mature collection. As you can see, it has a good wall. Can you appreciate that? So this is all the wall. Even the deeper wall is also mature. So we're using a lamps, the hot axios, and we will drain it from the stomach. Also get Doppler on the view. So you see a blood vessel there. So I'll just move a little bit around and pull back the scope. So while the stent is getting ready, I am trying to find the best window from which we can drain it. As I pull back more, now there is more edema. As this wall is thicker, so distally is a much thinner wall. Yes. No, generally no, but this is less than 1 centimeter. I am looking for the thinnest point now, which is relatively avascular. This looks to be a very thin wall. एक मिनट ना वेट कर दिया. So spend time before we actually drain, and this is the, if I have frozen the image, and from here to here is the wall. It's about 3.2 millimeter only, so that's okay. Even if we take at the hypotenuse of a right angle triangle where the track, so I'm using now the hot axios. If the cameraman can focus, this is a tip which has a cautery enhancement, and it has to be completely wet, and this will be done under the free hand. So what I did was a measurement of the thickness, but that exactly it will never be, the puncture will never be perpendicular. So the puncture will come from this side. So eventually when the stent gets deployed, it becomes perpendicular to the wall. So I think that is more important. There is a tiny vessel in the right upper quadrant which I am trying to just move around. एक मिनट हाँ लगा के रख लो. I'll just get the stent out. So paddle is here. Okay. So you see that the tip of the stent. So this is the stent tip here. This white thing. If I move with the elevator, it can move little bit. And if I measure the wall there, as you were saying, so this is actual thickness. So it was 3.5, other this is 4.5, 4.8. So it doesn't make too much difference because I can compress it also. But at the moment I'll just put a Doppler look at the vessel there. So I'll withdraw back little bit. And tiny vessels we need not worry, but we'll try to avoid as much as we can. And now we've got a good view. Here there is no blood vessel. I'll get the stent out again. When the stent comes out that the blood vessel starts visible, that's an artifact, that means. So I'm not worried about that part. I'll switch off the Doppler at this point. You're okay? You can see that tip of the stent. So I'm using a pure cutting. Okay, Ashish? And burn my way in. So I've gone in. Okay. So that's the important part. So first step done. Take it out. I'll take out the. Okay. Because of the device, I don't see the deeper part of the collection. That's okay. As long as I'm not overshooting the collection. So I may be a little in, but it's okay. I can pull back and.
So, sir, audience, extra thing about hot axis, like it has already white, it has cutting thing, everything one.
Yeah. It's all in one. So everything I am doing. So I have done the first step. Now I have removed the safety lock mechanism, and I'll slowly deploy the inner flange, which has now been deployed, and this is the inner flange. I will now pull it back more. Although I'm not seeing the other side of the flange. Normally I see both the sides, but because of the radiopacity, sometimes can I have an X-ray now? Just to see the stent tip. Although I can pass a guide wire also. You can pass a guide wire. Another safety mechanism is passage of guide wire. The scope, endoscope tip दिखाइएगा.
Tip scope.
जाएगा? That's just a safety mechanism to pass a guide wire. If I want to place a plastic stent later on, I can do that also. नहीं जा रहा? O25 जाएगा? O25 जाता है. चलो छोड़. Yeah, O25 वायर. हाँ दे दो, कोई भी दे दो. ये नहीं जाएगा. ये उसमें जीजेम यूज़ कर लेंगे. अच्छा है उसके लिए. So I'm just seeing, because sometimes and in this case I'm not seeing the other flange, other part of the inner flange. You're only seeing this half. That this half is, the umbrella is not seen. So I'm just putting a wire. This is my safety mechanism, and also I can use the same wire for pressing a fluoroscope. Fluoro, please. Wire has gone in. So fluoro will allow me that to see whether the wire has gone nicely inside. और जाला क्या? Screen fluoro? Okay, that's okay. ठीक है. I'll switch on to the big endoscopy mode and chota endosono mode. Now I see it better actually. Now it's better. Huh? Now it's better actually. I have slipped the wire inside and get the endoscopy big with a small EUS. I am looking at the endoscopy view to look at the black marker, which also helps us in telling whether the stent is okay. I actually deploy in the channel of the scope, which I am doing now. I have done it inside the channel of the scope, and I'll now push it out. And you can see on the right upper quadrant of the screen, the stent is there, and that's the position one. Okay. So that's a nice position, and you can see the thick fluid draining out. It's a purulent fluid, and the wire fluoroscope you can. And in X-ray also you can see you have the X-ray view there. Withdraw करें. I'm pulling out इसको. Wire push करते रहना. So I'm withdrawing the assembly now, and the wire is still inside. मोटा वाला डाल दिया. अच्छा. Okay. हाँ स्टेंट डाल देंगे. It's very thick fluid. Look, there's no gush out. When I'll remove the assembly, leaving the guide wire inside. Normally a gush of fluid should have come. Because the fluid is very thick, I told in the beginning there is solid debris and there is small amount of liquid, and there is consistency between liquid and solid, which is there now. I can also see inside the cyst cavity, have a peep there. Are you able to see that? Yeah, so there are a few advantages now. There is no gush, and this lamps also can get blocked by the liquid, by the debris, and before it reaches its full diameter. So I have two options: either I dilate the lamps to some diameter to allow the fluid to drain out, or I let it expand on its own and let the stent be there, which will allow the juice and the stent not to get blocked.
Should we remove the necrotic material, sir?
No, not now. So that's called primary necrosectomy. Stent दे दो. कैप नहीं लगा है. कैप के थ्रू लेते चल. So that's called primary necrosectomy, when we actually dilate it at least to 15 millimeter, take the endoscope guide and do it. But that's usually not advisable because risk of bleeding is more. If time is not a priority, let this stent expand to its full diameter, which will take few days. What I can do is I can irrigate this cavity using a pump or a catheter. That we can do. You have a... I'm sorry, I'm concentrating on the work first, and then I can answer a question. So I'm now passing a double pigtail plastic stent. एक catheter pump है क्या? Flush करने के लिए? Yeah, syringe देना, 50cc syringe with saline. I'll just pump it inside, flush it inside, because it's a very thick pus.
So when we should start to remove the necrotic material?
I think after few days, if the symptoms do not improve. So if you had history of fever or pain, if that continues to be there, then 2-3 days later I will do that. If not, center mark लगा है? End में है? So it's a double pigtail stent which is going in. ये end का mark है, तो release कर देंगे. Screen. Release it. That's just a precautionary mechanism. So I would say, I answered in the morning, 1 out of 5 will require DEN. This patient in all probability will not require DEN, because seeing the debris, the solid debris was very small percentage on the whatever I could see. What I am doing now is a part of primary necrosectomy, where you, apart from drainage, you actually flush, what I am doing now, some more. So this fluid will go inside, saline will go inside, dilute it a little bit and allow it to drain out. Although it could have been done better without the plastic stent. But
So if we required necrosectomy, then we have to remove.
We remove
this
the plastic stent, always
and
remove. Yeah.
Then again put a.
Then put a new one. This is infected. This is very thick pus. Yes, that's a very valid point. While discussing, normally we actually, what I normally do in our practice is pass a catheter inside and irrigate that catheter after aspirating that first pus. एक मिनट catheter देना शिव, एक catheter देना. I think you have a very valid point there. Any cannula you can give me. While we are doing that, let me just suck out the gastric content, so that the stomach should not be overfilled with fluid. Although there was no gush in this patient. This is kind of abscess. This is kind of pancreatic abscess. But yeah, abscess is actually infected pancreatic collection now. The word is now infected pancreatic collection. I am showing the EUS view to if I can peep inside the cavity now. It's not collapsed as well, because the content is very thick. This is the inner flange of the stent. This is the inner flange. If I move around, and you can see it's coming out. Catheter, please. Srinivas, I'll do two things now. I'll pass a catheter, suck out the fluid as suggested rightly for pus culture and sensitivity to titrate my antibiotics. I'll also dilate it a little bit. Allow this thick pus to drain out. Otherwise, it should have drained very vigorously, which didn't happen.
So will hydrogen peroxide will helpful?
No. Just 10 mm balloon. I'm sorry?
According to definition of pancreatic abscess, there should not be any pancreatic necrotic material. CT scan and ultrasound is showing necrotic debris.
Pancreatic abscess is an old term now. It's all infected pancreatic collection now. So any collection which has infection is pancreatic abscess, if you can call it that way. Whether debris is there or not there, I don't think we should go into that finer things. Wire, please. Aspirate. So I'm aspirating the pus. Yes, that's right. It's also diluted now with saline, so that would help. It's very thick actually.
So will hydrogen peroxide will help?
Not at this point. I'll only use saline if required. Nothing is coming out. It's very it's very thick. Aspirate. Aya. Now it will come. It's now at the mouth of the stent. आ रहा है? हाँ. यहाँ ही रख देते हैं. Okay, that's okay. So wire डाल दिया? Wire डाला? कुछ है? So I have got some pus for aspiration, which a thick pus, small amount has come, which can go for culture, and I'll dilate it so that allows it to drain out. Not too much, but small amount. Balloon se 10 mm balloon. The stent that I use is 15 millimeter diameter. It will expand to the maximal level. Screen fluoro, please. Fluoro. Yeah. Fluoro, please. Fluoro. Thank you. Inka? Fluoro once again? Yeah. Okay, that's enough. Exchange? All this I could have done before placing the stent. Because the inner flange was not seen very well on the EUS, I use guide wire first to get my safety first. I think that's a paramount. One should be ready to adjust things according to the need of the case rather than going only a step by step as has one learnt. So I think that was an important thing, and we placed the stent in the beginning itself.
What is the advantage of doing necrosectomy in cell section?
In the same session?
Not in second.
Today?
Yeah.
The
Because in operative setup, we do histogastrophy and remove necrotic material in cell.
So here the concept of step-up approach comes, whether we use endoscopically, percutaneously or surgically. Surgery, you can't keep doing surgery several times, and that's why the concept of percutaneous drainage followed by going through a ward using the same path. I think the same analogy we use in endoscopy also, where we drain first, allow it to evacuate.
Sir, you are committing that these wounds are infected.
Yes, this is.
So remaining necrotic material must be infected. So you are placing infected necrotic material in the background of this stent. So it is not written to remove entire necrotic material in cell.
No. It will allow, the principle of surgery is to drain an abscess, right? You give a cut.
But also removal of that necrotic material in cell. This is the standard cystogastrophy, operative cystogastrophy.
Because you can't operate again and again. Here we are doing endoscopically, allow things to come out. I'm dilating it and I'll irrigate it again, but rest of the material will come out. Oh, wire बाहर आ गया. कोई बात नहीं. I'll take it inside. So I've got the balloon tip which will work as a catheter and wire piece, wire pass. Huh? Okay, inflate. खुद देगा एक को का दो. So one has to be aware of the pros and cons of what we are doing. If I try too aggressively and cause a perforation or a bleeding, then I would not be happy and nobody will be happy with that. Slowing as slow and steady is actually a better way. 10 is what I want, not more. Do you agree? Utkarsh? You agree or you are still not happy? Utpal? So this is 10 mm dilation, which will actually allow me to take my endoscope also inside if need arises. But I'm a conservative endoscopist, I can say that. There is a recent publication which is coming up of primary versus secondary direct endoscopic necrosectomy, where primary is done at upfront after dilation, and then you take the endoscope inside and clean it up as well.
So main complaint of this patient, main presentation is gastric outlet obstruction.
Outlet obstruction, okay.
So
But
as
okay.
Content
So
is not
reduced,
so much large.
okay.
So
Deflate,
what do you
deflate.
think? Patient will symptomatic
So
improve.
syringe देंगे उसके बाद में. हाँ. He is likely to improve once the content comes down. But I think that there's a mismatch in the CT which was done a few weeks back and current. Maybe the natural exit of the liquid part has happened and the thick pus and the debris still remains. हो गया? Okay. We'll flush some more. Utpal, you agree now? No, you can disagree also if you want. But
Very nice demonstration.
look, our ultimate aim is that we should not cause an adverse event or a serious adverse event. Syringe, catheter देना catheter करेंगे. Antibiotics are anyway going upfront. I think before the procedure starts, we start the antibiotic. All the interventions have to have an antibiotic. That's based on the symptom and the source control. So generally about a week, 2 weeks is what happens in majority of the cases.
And we had already taken the culture and sensitivity.
Culture has gone now.
Sir, can we do one thing? Place a rice tube inside this cavity and connect that rice tube to an NS.
That's irrigation.
It will, yes, continuous irrigation for full day.
That's a possibility which can be done. That's a surgical principle of irrigation. Endoscopically, what he places is a nasocystic tube, which is much easier and goes over the guide wire. Although some endoscopies also place Ryle's tube and go a vigorous lavage. Flush, flush, flush.
Hello.
Yes.
Yeah, I'm Dr. Saket. I'm also a GI surgeon.
Yes, Saket.
So my question is, how many of these patients require repeat procedure and necrosectomy after simple surgery?
So 1/4. About 20 to 25% may require a repeat procedure.
And any of these patients require surgery ultimately, or?
Yes, of course. Of course. If they do not improve with all this, then surgery is the next best option. But if we can avoid, the whole thing of doing this way is to avoid surgery. This stent is now gone up to 10 mm diameter and the pus is quite thick.
So should we put NBD tube?
Yes, we can. I think that's another good idea. We'll place an NBT and irrigate it. So in this case, I think that may be good because the pus is not so... 7
NBD tube or 10 French?
Whichever you have. 7 is okay.
7 French NBD.
Yeah. Because that will drain through the lumen of the stent. Why डाल दे, So we'll have a middle path of placing instead of a Ryle's tube, a nasocystic tube, which will be connected to the external saline irrigation purpose. Look, those are things in a larger group, what you have done and what was the outcome. Here we have now an index patient where we have to take a decision on a case-to-case basis. The decision of placing an NCT is very right. I agree with the surgical colleagues who are suggesting to place something to irrigate because the pus is so thick, it's not draining spontaneously. In spite of my sucking out, it's not coming out. I am placing an NBT, which is a NBT, a narrow-biliary tube which goes in the cyst, so it becomes a nasocystic tube. Fluoro, please. Fluoro. Screen, please. Can it go deeper down? Okay. Okay.
Hello.
Yes, please. Stay.
There's a question from the floor. Do you put something to make the pus or the debris loose enough?
Hydrogen peroxide is what you're talking about. I think I'll just limit to saline first. Hydrogen peroxide is a good thing. It's equivocal and which shows some positive response in some of the studies. And the purpose is to kind of make it loosen or disinfect the collection. But I would first limit to saline. If that does not improve on my next inspection, then I will probably think of hydrogen peroxide as an additional way of cleaning it up. Sutish, he's okay, na? So stent itself actually blocks some of these blood vessels, either collaterals or even the small vessels in the wall or the track of the entry point. They get tamponaded by the metal stent. But accessories that I require is a coab grasper if I see a blood leaking out from a major point, which can then be tackled Perforation is also very rare because these are fully covered stents, and I'm in a relatively closed cavity of the lesser sac, which is posterior. Screen fluoro, please. Continue. Okay, release. So this will help in irrigation, and I will now come out, sucking out the gastric content, so to prevent any post-procedure aspiration when he is recovering. Screen. Fluoro. तो स्कोप नीचे दिखाते रहो आप मुझे, स्कोप टिप सर बस नीचे वाला पार्ट, हाँ ठीक है, यहीं दिखाते रहना. पकड़िए. So this will now be rerouted through the nose and it will be connected externally to a saline bottle, where it can be flushed in more vigorously, and the contents will then expel in the gastric lumen. Okay, you agree? Utpal, Ashish.
So this NVD tube should be placed for 3 to 4 days? Or
I will keep at least for 3 to 4 days. And maybe on tomorrow is Monday, maybe 2 days later on Tuesday or so, I'll do an upper GI endoscopy. By that time the stent will be more expanded. I can go and inspect inside the cavity and see. Then I can use that pump, water pump, to irrigate if any adherent debris is there or loose debris is there, and also mechanically withdraw some of the content.
by using the snare?
By using a snare. But pump is very important. Without pump you should not go in. Okay, I think we'll. कहाँ डालना है? हाँ भाई, एक ही.
Yeah, Dr. Ashish Jha. Any more questions? Sir. Yeah.
सारे इसी में करने हैं. इधर ERCP कर दो, इधर EUS कर दो, काम हो जाएगा.
हाँ. कहाँ गए बाजी?
तो परफेक्ट इसको शिफ्ट करें तो इस रूम में. हाँ कॉटरी भी चलेगा. उसमें ERCP का कौन सा केस है जो उसमें ERCP करेंगे ना सर?
प्रियंका कुमारी यही है.
प्रियंका,
हाँ प्रियंका कुमारी.
सर ये नॉर्मल पैंक्रियाटिक एक्सप्लोशन और क्या इसमें यूएस लगे तो इसमें नहीं लगे?
नहीं यूएस नहीं लगे.
सर अभी लगा था. कौन सा करेंगे? अरे आराम से कंफर्म कीजिए. एंडोस्कोपी 2 ERCP. लेट हो जाएगा. मैं लेके जाना है. हाँ लेके हाँ सही बोल रहा है. लेट हो जाएगा. सेटअप होगा तब तक उधर. चलिए एक काम और करना होगा पहले से. इसमें काम चलता रहा तब तक दूसरा रेडी कर लेना होगा. वो रेडी है. कैमरा लगा. सारा कुछ है सर, कहीं कुछ नहीं.
who is a known case of chronic pancreatitis with history of multiple episodes of acute pancreatitis in past. She presented with again acute pancreatitis episode on 13th of July this month, and then she was evaluated and CCT of whole abdomen was done, which was suggestive of features of acute on chronic pancreatitis with dilated MPD of 9 mm and with multiple intraductal calculi. The largest one of them was 8.62 mm in head of the pancreas. So we are going to take up this case.
Can you repeat?
What's the plan in this case? Is it just a US imaging diagnosis or a therapeutic procedure?
No, no, we are planning for pancreatic endotherapy. Tick, tick. So now we are moving to that second case.
ये हाथ पकड़ना पड़ेगा इसको जरा सा. Sorry, thank you. ये गॉस भी जकड़ा पेटेंडी. करे जेली है क्या?
Mic on.
Hello, can you hear me? Ashish, can you?
Yeah, can you hear me?
Yes.
So I'm intubating this patient now with a duodenoscope. हो गया ठीक है. Flat कर दीजिए. This is a side wing endoscope. And I'm in the stomach now. I'll suck out the gastric content once again. ठीक और मत करना. The patient is lying prone. She's almost prone.
So is it actually you are intentionally keeping this prone in prone or it's
Yes, she is prone, so that the anteroposterior orientation is quite clear then. And I have now passed my scope into the duodenum. You can see this. This is minor papilla, which is very prominent, and a prominent minor papilla suggests it could be a divisum situation. Although MRCP was not suggestive. थोड़ा साइड हल्का सा साइड बढ़ाना. And that's a major papilla below. So you can see both the papillas now. The one on top of right of screen is a minor papilla, which is very prominent. So this is a pseudo divisum situation or a pure divisum situation. All the MRCP suggested that the stone is in the main pancreatic duct. So all the juice is probably getting diverted through the smaller gate of minor papilla. Can I have the fluoroscopy now?
So sir, question here again indicates sir, without ESW for up to 5 millimeter stone is easily retrievable. Here is a stone size is approximately 8.5 something.
Yeah, but I don't have ESW here, Ashish.
So should we try in these cases? Question
Yes, so one attempt should be made. At least I can decompress or reduce the ductal hypertension by placing a stent. Hold it, or I'll pass side of it. And if the stone happens to be not in the side branches also, the tentacles, then we can have some opportunity of removing it. So we have to work according to the circumstances available. You agree?
Yes, sir.
So what is the better method?
Fluoros-
ERCP,
can I have this fluoro once? I want to see the stone.
ESWL before ERCP or ESWL after ERCP?
Before ERCP. So that the fragments can be removed in one session itself. Just put the wire now. Screen, fluoroscopy please. Fluoro. And okay, you can see some stone fragments there, small stones in the head. Contrast डालें?
Sir, which wire you are
So I'm using a Teramo wire, an angle Teramo wire. I'll inject some contrast and outline the pancreatic duct. If the stone is completely blocking the duct, then the contrast will not go up, then my wire will also not go up. So that's the reason I'm using a contrast now. Inject. Fluoroscopy, inject. Nothing. Okay, it's all out. Let me. The pancreatic opening is usually on the 3 o'clock side. Inject. No? No? इसके छेद कर सकते हैं इसमें एयर निकल जा रहा है ना एनीवे screen गया क्या okay, that got filled up. Now you see that, but divisum actually, yeah. So you're right. So the side branches are visible, but the upstream duct is not opacified. So let's go back to the minor papilla. Although this information was not available, or I had seen the MRCP, it didn't show like that. So let's pull back and go to the minor papilla, which we initially thought, because the minor papilla is so prominent. So cannulating a minor papilla, you either have to be in a very long position, and you see the juice is coming. निकाल. एक मिनट. ये छेद नहीं है कैनुला में, स्फिंक्टोटोम इसमें ना. नया कैप है.
दोनों आता है.
So, sir, for minor, you use sphinctotome or you?
No, I use the same sphinctotome. I just pulled it back because the. एक को फिर से लगाना है.
नहीं, दूसरा क्या है?
Any advantage of, sir, using other accessories other than this sphinctotome, like cannula or?
Yeah, you can use a tapered cannula if the papilla is small, or a metal tip cannula, which are sometimes used for. Again. Okay. So there's a little bit of hindrance here because of the. I'll now go in. So I'm using the same sphinctotome, Ashish, which I used for cannulating the major papilla. I'll go through the minor papilla with the same, and Pele will use the same wire sheet. But I have my scope position is a little different. A fluoroscopy can show. Fluoro, please. You see my scope position not completely changed. This is a semi-long position. It has to be half as perpendicular entry I have to do. So bend, koncham bend. थोड़ा सा. Scope पकड़. आप पकड़ लेना हाँ scope को ऐसे. Why this better? Yes, push the wire. Screen. Gun. One. So my wire has gone in. It's gone and hit the stone and come back probably. Now I'm anchored inside. Fluoroscope. Okay. I think we will inject some contrast now and see. इसको ना थोड़ा सा. You could have scope position adjust. हाँ आप करो inject. So now you see the whole duct is opacified. So this is the stop. This is a pancreas divisum with a stone in the minor duct, and push the wire. So since the contrast has gone, wire is most likely going to go. So there goes the wire up. Plain fluoro. Okay, it's in the side. Let me go in now. So what I will do, I'll go inside and do a cut first. Sphincterotomy first. Can I have the foot paddle? So I'll do a minor papillary sphincterotomy. The wire has gone to the side branch. It has not gone to the main duct. Okay. Acha, theek hai. Oh, okay. It's not ready. So by the time the cautery gets ready, I'll just manipulate. Fluoro, please. Now this pull back. Screen, please. Bend karo. Take it back. Take a full sphinctotome bend. Fluoro, please. No. अब देखो जाएगा. Yes. So thank you, Srinivas. So he's done a wonderful job, and that's a very important role of a technician. So Srinivas is there with me, who's now passed the wire deep inside the main pancreatic duct through the minor papilla towards the tail now. Can you appreciate that?
Yes,
Ashish?
Yes, sir.
Okay. So now I'm waiting for the cautery machine to be set up. Meanwhile, the juice is draining out, and after that we'll use a 7.7 or a 7.5 single pigtail stent.
Meanwhile, can you demonstrate the stone?
Yeah. So can you have the fluoro back, the previous picture? No, not now. So the stone is not so well seen in this image, but I can imagine that it is. If I have the arrow, then I can show. Let me show. Foot pedal. You want to inject some contrast and see? I will not inject contrast. Let me just get my sphincterotomy right first. All set? Ready? Can I start?
Yeah,
Setting okay? Conclusion ज़्यादा icon दे. ఇది ఎఫెక్ట్ కూడా మన పెట్టండి. इफेक्ट 1 हाँ कम करो ओके ठीक. So it's a wire guided sphincterotomy I am doing, and we have a good length of the sphincter to be cut.
Sir, a question from audience कि when we are placing the wire, so wire must be crossed through the vertebra to the other side, right? I mean towards this cross or
बस ठीक.
just
There's some bleeding there. So wire is crossed. Can I see the fluoro please? There's some bleeding here. So coagulation. Okay. Now I'll. So you're seeing endoscopically some bleeding is happening. So let me just control that. I'll also keep some Madeline ready. I'll coagulate here. Flush कर सकते हैं ना? Flush saline flush. I'll just clean up my field of view. To see exactly where it's bleeding from. एक मिनट सक कर ले. It's a little more brisk than usual, but it should stop. No worries. It's on the top. Let me just coagulate that area. I'll use a blue paddle. Flush. Most of these bleed are self-limiting, and this one also should be. If not, then I will also inject some Adrenaline in the end. Okay, no problem. So let's reduce in intensity. That's okay. But I'll manage. So your point is quite right. This is the wire is in this one of the side branch. It's not in the main duct. Can I have the fluoro now ready? And the fluoro man can come back into show the other side as well on the left side of the patient. चला screen please. नहीं नीचे जाना है. Can patient का left में लेके जाएंगे थोड़ा सा अपनी तरफ खींचे. Stop screen fluoro. So it's like a bifid pancreas, but the lower one, the one duct which is on the spine is the one नीचे वाले में जाना. Screen. So let me go a little closer, and then withdraw the wire. Withdraw. नीचे वाले हाथ डालो, चला जाएगा. So now you are satisfied. I think somebody pointed it very rightly, and that I think I appreciate that. I'm still a little concerned about the bleeding which is happening, but I'll finish the job. Change the wire. Screen please, screen. कहते हैं हाँ okay. Change the wire. You can inject some more contrast and see what's happening. कोई का contrast पेट नहीं. It's not. It's upside down. I think. Is it? हाँ because look. उल्टा है क्या? Because the vertebral directions are the spine. Do you appreciate? हाँ ना आप सीधा करो. Lateral करो. Screen please. नहीं उल्टा आप वर्टिकली आप है ऊपर नीचे है नीचे रिवर्स कर देना. ऐसे रख दो ऐसे रख फ्लोरो प्लीज. ओके कॉन्ट्रास्ट डाला था हाँ थोड़ा डाल देना. अब ठीक है. थोड़ा अपने साइड पे हल्का सा खींचिए. अपनी साइड खींच ली ना हल्का सा. बस स्टॉप. अरे ये वर्टिकल क्यों चेंज हो रहा है. हाँ ऐसे रखिएगा. इंजेक्ट थोड़ा सा कॉन्ट्रास्ट हल्का सा डाल. स्क्रीन प्लीज. हिलाओ नहीं भाई आप. बस ठीक है. स्टॉप स्टैंड 7 ओके. वायर डीप. स्क्रीन प्लीज. हाँ ठीक. ऊपर चला गया। नहीं नहीं वायर बाहर, अच्छा अच्छा अब ठीक है। हाँ 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 एलिवेटर से पकड़ लिया। हाँ हाँ थैंक यू आशीष फॉर पॉइंटिंग आउट। फ्लोरो प्लीज वंस अगेन। हाँ ठीक है। So Ashish, I'm not focusing too much on the stone. My first attempt is place a stent, control the bleeding, and at a subsequent setting I will 2-3 months later I will look at the stone. Sometimes the stone is soft, with the stent friction itself it can become little smaller in size or smooth in outline.
So sir, in such situation, if you later on require, you will do the CRE dilatation of
That's a possibility. CRE and even spyglass, if you have, you can do a laser lithotripsy.
And if CRE, then what should be the maximum diameter? Usually you do.
So we go to the diameter of the pancreatic duct. If so, I'll measure the pancreatic duct on the screen, and only that much diameter I will go. Suppose if this diameter on the pancreatic duct is 6 millimeter, I will not use an 8 millimeter balloon. Okay, so I'm exchanging now. She's not the lady with CKD, na? But you see the briskness of bleed has stopped. It's just mild ooze, which will further stop on its own.
The papilla was inflamed, I guess maybe.
Maybe that's it. You are right. So they have more blood vessels, inflamed papilla, and the stent also will do a little bit of protection there. 7. Screen. I'll stay as close to the papilla as possible to prevent any buckling of the stent in the lumen, now in a better position. But this is a very long scope position. So a minor papilla we always use a long position.
So which diameter stent
So Ashish, I'm using a 7 French stent, which is 7 centimeter long with a single pigtail. So here comes the stent.
So sometimes sir, some opinion is if we start with the 7, so patient may have pain and so on.
No, 7 is okay. 7 is generally the starting point unless the duct is very thin or the stricture is very tight. In our practice, we always use 7 first. Very rarely we go up to 8.5 or 10. So that's some black mark which comes, which tell me the end point of the stent, which is also seen on fluoroscopy. And I will release the stent. Now pull back the wire, pull back. I'll push out the stent into the lumen. And you see the bleeding has stopped.
Yes, sir.
So there is no need of any injection also. I think with that, this procedure gets over. Now on X-ray, you can see a radio opaque a stone, a filling defect kind of a thing on the right of the screen, somewhere near the bend of the stent, and that's a stone. If the bleed had not happened, I would have probably attempted a balloon sweep or a basket to take it out, but I can do it next time also. This is single stone, it would be easy to handle and likely to come out.
Thank you sir for nice demonstration.
Thank you. हाँ इसको निकाल दे माइक को.
Dr. Ashish Jha, sir. Yeah, any more questions? Okay. So now we are moving to the third case. Can you hear me? Hello? Yeah, can you hear me? Yeah, now we are moving to the third case. Dr. Amit will present the third case.
So we have the third case, which is a case of 39-year-old male who had dyspeptic symptoms in the form of nausea, vomiting for the last 1 year, and he was evaluated, and there was a gastric cyst which was present on the anterior antrum, which was exophytic, and it was 8.5 into 2.5 centimeter. It was likely cyst. We have planned for US guided biopsy.
Sir, hello.
अभी तो टाइम लगेगा.
Now we are moving to the third case, sir. Okay, okay. Audio, video.
ठीक है, रेडी? दिया है देखिए, मंगा लो जरा सा, इसके बाद ले लेता हूँ. रेडी? Can you hear me? Yes, sir. Okay. So then you got the history of the next patient?
We have 2 images, so better to keep one image only because
No.
US image is small. So
No, we will do that.
Yeah, now we are adjusting.
So we
No
just,
issue.
so this is a patient with a young man with a dyspeptic symptom, incidentally found to have a subepithelial lesion in the stomach, and imaging is suggestive of possible GIST. So we'll just try to interrogate and see what's happening, and if need be, we'll take a core biopsy also.
Sir, what is your differential diagnosis? Are you thinking gastric cancer also? Because this is very characteristic in CT scan.
I didn't see the CT. You had the, I think, more.
What is the indication of EUS in this patient if it is resectable?
Have you got the histology? I'm not sure. Gastric cancer means histology should be there, na? Endoscopically. Was endoscopy done?
Yeah, endoscopy done. Mucosa is absolutely normal, sir.
So
Probably it is GIST.
yeah.
If it is resectable and not planning for imagining or something like that, then what is the indication of EUS in this patient? No, just sir, ask for knowledge purposes.
Okay. Chala, I'm not doing biopsy straight away. Let me just see what's going on. I totally agree. A small GIST should directly go for surgery, but a larger GIST, we can think about an alternate options also. Surgery followed by imatinib and so on and so forth. Whether metastasis is there or not, liver is there involved.
So with imaging, can we 100% sure it is GIST or something like?
No. First, we need, the first thing is histology. Whether we want to get histology by EUS or by surgery, correct? Yeah, then surgery. Then surgery directly. I agree with you.
But anyway, sir, US is required sometimes because sometimes GIST and other vascular lesion and anything.
So yes, so differentiate. That's why I think Utpal was asking about the differential diagnosis, and so we should always go with the differential in mind. I'm sorry I did not see the image before, the CT image, so that's why I always see the CTs before going in. It's always better. So I'm in the second part. I'll withdraw back slowly. So the equipment that we're using is Olympus ME3, which is the latest model of Olympus EUS equipment, and which is very good. It is much better than the previous two generations, the ME1 and the ME2. We can define the lesions better. We can do elastography. We can do fibro type scan, RF scan from inside. I'm looking at the pancreas, which looks very heterogeneous. So this is the pancreas, which is not normal looking. This is the body of the pancreas. I'm withdrawing back. I still haven't seen the subepithelial lesion, but the pancreas is quite heterogeneous. And if I had not taken a history, whether he has pancreatitis or smoking history or alcohol history or family history, those kind of things. I'm still looking around. This is the liver, left lobe of the liver. Looking around. It's in the antrum, right, the lesion? Okay, let's go back to the antrum in a long position now. I saw something there. Yeah, that's a lesion. So this is a very complex lesion. It's quite big and has several cystic spaces inside. And
for lesion of this size, concerns are here. So can we go straight for the surgery or should we?
I will take a biopsy in this case. This is not classical, and maybe something else happening here. I don't want surgery to be done on a patient where the diagnosis is not clearly established. And doing a biopsy will not add any problem to this patient. This is 6 centimeters, in one dimension, and other
Can we demonstrate the origin of this?
I'll try that. Just a minute. Let me just take the dimensions once. So this is almost 59 in one dimension, and
We have radiologists in our room. Can you comment? What is that?
this is a malignant gist, and with so much cystic spaces which are irregular, it is beyond the stomach wall. It may be arising from, let me see the edge of it, or it's something else. The sarcomas also, retroperitoneal sarcomas. Let me look around more. So Utpal, now will you operate straight away?
No, sir. In this case, we may require discipline.
Thank you.
Initial question was on CT scan, what is the specificity of the diagnosis?
Yeah, so you have a radiologist there, he can answer it.
Dr. Rajiv, can you comment on CT scan, how much you are confident? This is EUS and nice work. It's very well.
This is not so easy. Here it is. Here it is.
So it appears the margin here.
So yeah, higher it like, yes, Ashish, I saw that. So now the margin is looking from the fourth layer. This is the fourth layer of the stomach.
But it is not looking like this to me.
This is very malignant looking lesion.
Malignant looking lesion. The only thing I can say is a malignant appearing mass.
And I think it's outside the stomach. It's not from the wall, Ashish. Maybe this layer it looks like it's an exophytic gist is one differential, but I'll not be dogmatic about it. And I think that's why the importance of taking a gastric biopsy, and I'll ask for a core biopsy. So pancreas, we saw it looks different, and it's away from the mass. This is not pancreatic cyst. So I'll use the Boston Scientific Acquire needle 22 core. That's fine, good. I'll also put Doppler on it. That's important, and it's very vascular. So again, this is a feature of gist. So two very vascular lesions are neuroendocrine tumors and the gist. And large gist will have metastasis to the liver, do not have lymph nodes often, or rarely have lymph nodes. If lymph nodes are seen, then you have to look for alternate diagnosis.
Sir, it's beyond, it's around posterior wall, no, sir?
Yes, it's in this wall, posterior wall.
Multiple cyst and heterogeneous enhancement.
So maybe, so this is the muscularis propria of the stomach, and here there is a breach. So maybe it's coming from the muscularis propria. It could be a gastric G's exophytic type, but I'll not be dogmatic. The smaller lesions are better or easily defined. Larger lesions are difficult to say, but nevertheless I'll take core first. And it's a very vascular lesion, so it will be, I'll not apply any suction to this.
Sir, any US criteria for diagnosing this, like any specific relative statistic?
So they will be uniformly hypoechoic in the smaller varieties, but as they become bigger or more malignant, they'll have cystic spaces, calcifications, atypical features develop.
Large cysts may have central necrosis.
Yes. So this also has these cysts are actually necrosis only, where they outlive the blood supply, outgrow their blood supply.
But looking at the overall appearance of the lesion, it looks like resectable, well resectable by the surgery.
So I'll take out my needle.
So, sir, you are using the Acquire 19.
I'm using Acquire 22 FNB needle, yes, and I'll.
It's a 22, sir.
It's 22. I don't have 19 here, but 22 I need a core needle basically. So that's what I'm doing. I'm avoiding the bigger vessels and go to the edge of the tumor.
So, sir, what are the other options of avoiding needles, sir? FNB needles are level now other than acquired, sir. And it is good
So FNBs, there are a few other needles available now from. Ek minute. Just Cook also has a side hole needle. So you saw the needle inside, right?
Yes, sir.
And I will just style it remove cheyandi. Purtiga. Full, no suction, no suction. Nika తీసేయండి. I'll stay within the lesion and go in different directions to sample as much as I can.
So, how many number of passes?
So, I did about 8 to 10 passes in different directions, actuations we call it. This is one pass with 8 actuations. Actuations is moving it to and fro. If it's very vascular, we avoid suction. In the core bottle, no slides.
And sir, what you can actually do for training, sir, and if the camera can zoom on your hand.
Acha, let me do the next part. Let me expel the material first. And flush cheyandi. Salad dal do. Just 1 minute. Ashish, let me see how the first pass looks like. And based on that, we will decide. If first pass is good enough, probably we don't require a second one. Dala. Is any white core? We'll look. इनका ఒకటి पास है. No still it. So if the cameraman can focus here, so we use up down knob and little bit of elevator to go in different directions. But this is the case where I will not use any cytology. I will only rely on core biopsy because I wanted also IHC in this patient. Immunohistochemistry is very important, and that comes from the core biopsy and not from the cytology. There's a little bit of fluid which has come around. I will not do more. I think I just different directions. The core. Only core. Same bottle. Okay, I think this should be okay.
How is that tissue, sir?
I'm just looking at that. Is very important, yes. So this is a solid lesion with small cystic spaces. It's Uchara? Okay. So it's saying good white tissue. If you can show to the audience, I'll pull it out. I think the job is done this patient. Show the bottle. गिरना नहीं, इसको बंद कर देते हैं. I don't know. ढक्कन का है? That's गिरना नहीं चाहिए ऐसा. So yeah, there are several cores there. I don't know whether we can show it. White cores are there. Several white cores are there. There are good long white cores, which is fantastic. You see that white cores?
So it's approximately 2-3 centimeter long.
Yeah. Correct. You saw that. I'm impressed with your eye view. Okay.
Thank you again, sir, for that demonstration.
किसमें डालना ये ना?
Yeah,
We'll
thank
just
you
wait
so
here.
much.
Yeah. ये खोल देता है इसका.
Hello. So we are going to take our fourth case, which is a case of 16-year-old male who presented with acute pancreatitis in November 2022 and with a CT severity index of 10/10. He had a follow-up. He didn't have any symptom, but after 5 months he came just for follow-up of the follow-up case of acute pancreatitis, and then ultrasonography was done. There was a collection of 330 ml, and in March, in April 2023 this year, there was a 533 ml collection, and the finding for suggestive of pseudocyst in body and tail. So this case will be taken up for cystogastrostomy.
Yeah, can you hear me? Yes. Yeah. Now we are moving to the fourth case.
So you heard the story, Ashish?
Yes, sir. So actually question before you start, so some question is here, what actually do we need to drain this patient at present is asymptomatic?
When was the last pain? I'm not sure about that.
One and a half month back.
Okay. And when was the onset of pancreatitis?
Almost more than 3 months.
3 months back. So same thing we were discussing with Dr. Khandel was asking, when patient is having a collection, how long to wait, should we drain? Let's see the cyst. अपने आप पिचक तो नहीं क्या? The patient is nicely sedated. Thank you, Stuti. Dr. Stuti and her team are very nicely managing the patients. So let me see now what's the EUS image there. Make it bigger. It's quite big. Yeah. This is a nice and also has significant debris below. All this. So this is what I was saying. The previous case was more of pus inside. This will be little turbid fluid, but not so thick. But the lower part is debris. Yeah, so this is a classical WOPN. Even the previous one was WOPN, but that was infected. Here this is non-infected, and would we end up doing more than what is worsening him? So in this view, I can say it is about 25% debris. But if I torque around, then we get more estimate. This way it is about 40%, and this way even so it would be about 30-odd%. Ideally, would be a metal stent in this patient. So how we were draining before the metal stents came was plastic stents.
But there is a financial issues with this
Yes,
patient.
so that's the important thing. We have to look at other things. We can't ask him to. So we'll drain with plastic stent, which are also not bad. But in my personal opinion, I would have preferred to use a metal. But nevertheless, we will drain it. And these are the ones which may get infected after we drain. In that case, we can dilate and go inside and do a necrosectomy and do it.
That once we put a very small caliber stent, there is a very high chance that it might get infected.
That's true. And has a bulge also, as you can see endoscopically. There's a gallbladder we're seeing which is normal. So I'm trying to investigate. So whenever we do these procedures, get the maximum out of your procedure. It should not be just doing a drainage. If you find a stone which was missed out earlier, maybe the decision would change and a lab chole and the drainage couldn't be done the same sitting then. And there are multiple collaterals too. You see this? He has portal vein thrombosis too. He has portal vein thrombosis. So one has to be aware of that. Increases the risk of adverse event because some of these collaterals. Let me see the other pancreas, the head. So this pancreas part is okay. Head is reasonably okay. So let me show to the audience. This is the duodenal C loop. This is the duodenal C, and this is the head of the pancreas. The lowermost part is the uncinate, which is in front of the superior mesenteric artery and vein. See the kidney on the other side, and I'll pull back slowly. So the collection is almost coming up to this part. So whole of the pancreas is replaced, and debris, as you can see it here as well. The vessel there. And many collaterals are peeping on the left upper quadrant of the screen. If I put a Doppler on that, you will see. So these are all collaterals. So I have to be very careful at the point of entry, should be completely avascular, because here the intent is to do a plastic stenting.
Can we demonstrate
demonstrate communication, PD communication with the US?
It is very difficult. The person is asking, because if the collection is very big, you cannot see where the duct is starting or finishing. We could only see a little bit of in the duct in the head, but this collection is so huge that I think it's replaced. Rest of the pancreas is atrophic, and the collaterals in the tail as well. Now you see the splenic hilum. You see these collaterals in the splenic hilum? So whole of the pancreas is gone.
So in such case, we should go for MRCP all patients before.
So MRCP also will be suboptimal when the collection is big. It will not be able to demonstrate. It is better to do MRCP later on when the collection is resolved, and then you will get the entire anatomy right of the pancreatic duct. How is it? Is a disconnected duct, and so on and so forth.
If it's a communicating cyst, then we should go for the cystogastrectomy as well as PD stenting, or cystogastrectomy will be enough.
So cystogastrostomy is the first thing. PD stenting will be considered at a later date, 4 weeks at least from the index drainage, if there is a possibility of reconnecting the upstream duct. But here I feel the only remnant pancreas is only in the head part of it, and that's also anything beyond the genu is all necrosed and become a collection. So there will be no extra advantage of doing a PD stenting. Even if suppose there is remnant duct available, that will be very small in the tail, which is not visible now currently. So that part is not to be considered at all. Transpapillary stent should never be done in this scenario, because if I do it now today at the time of drainage, then if it's communicating, I'll infect this collection. Our aim is to reduce the infection and not add more to it. So this is 110 mm almost in one dimension, and the other dimension is almost 90. So 90 by 110. Okay, and I'm also trying to see the point of entry where there should be no blood vessels. That's very important, because
Sir, sometimes around 4 weeks, the capsule is not well appreciable during the puncture. So in that case, usually you take the time frame only, or capsule must be demonstrated before puncture.
presence of capsule makes the job easier, and capsule need not always form on exact 4 weeks. Sometimes they form at 3 weeks, sometimes they may not form at 6 weeks also. But this is a very mature capsule. Can you see that?
Yes, sir. Very mature, well defined.
So I'm using a 19 gauge needle now from Olympus to go to the 4 steps which I mentioned in the morning. And can the fluoroscopy be set on the tip of my scope? See, can the fluoroscopy? Okay. Bring it little up. Scope. No, थोड़ा बस ठीक इतना ही रखेंगे. थोड़ा साइज छोटा कर सकते हैं इसको, बिकॉज सिस्ट बहुत बड़ा है, हमारा वायर बाहर निकल जाएगा फ्रेम के, फ्लोरोस्कोपी फ्रेम के. So I'm setting the sheath and the needle of the 19 gauge needle, and this is a reasonably avascular area. Although sometimes the vessels also can be compressed when a cyst is in high pressure and may not be obvious on flow. So one should, and that's why the metal stent scores. So whatever people say that plastic is that good and metal gives us lot of extra advantages. It is not the efficiency of drainage, but also reducing the risk of complication, which should be counted. I withdraw the stylet, and now puncture. So it went in. Now I remove the stylet. I'll aspirate this fluid for analysis. As rightly pointed out by Utpal in the previous case, that should have taken a culture. But that's the only problem of lamps, hot lamps. When can you hear me? Hello? Okay. So this is a little brownish, but not very turbid fluid. That time it could not aspirate also. Now we are aspirating very freely. Should be okay. So this can go for culture and amylase. So for that, a trick for a very important part for the EUS interventionist is to look at the needle now. Never lose this view on the EUS image. Always keep looking, because through this needle the guide wire will come, which Srinivas is now passing. So it will go through the hollow of needle. So it's not, so this debris is very loose and floating. So that's a good thing. And because they can also spontaneously drain out when the fistula is made and the acid from the stomach goes inside. I have now withdrawn my needle and I am pulling back the needle back, leaving the guide wire inside, and I'll keep a watch on the guide wire. You see the guide wire there? So that should always be visible on my EUS view. So that's a guide wire. Okay. A fluoroscopy. So it's a big cyst, as you can see on the screen. It's gone beyond the you have the fluoro image there? It's a big loop. So we don't have to make 2-3 loops. This much is good enough. My wire will not come out. Cap laga dena. So I'm just checking any vessel is there again, because now I will burn my vein. Settings are there, cautery settings, standard.
So you will use just a 6.
I'm using a 6 French cystotome, a very important device, which are same as the ERCP setting.
Sometimes it's difficult to burn with the ERCP setting. Then in that case, you actually increase the current.
That's right, Ashish. Fantastic. That's a very good point that you raised, which may happen in this case because the cyst is little thicker wall. When I punctured, the needle did not go very easy, so which tells me that this may be a little bit fibrosis. As my surgical colleague also pointed out, that looks like a very mature one, but the mature ones are more thicker and more firm to burn. Tight, wire tight, I'll pull. So here comes a cystotome. The fluoroscopy can show that for the people to reconfirm it. The tip of the scope to be seen fluoroscopically. Yeah, I can see that. And now burn my vein. After this, we'll use a balloon, 15 mm. चला गया तो बिना burn के चला गया, which means the wall is so thin. So the reverse हो गया. कोई बात नहीं. But I think these are small things. We don't have to be dogmatic for everything. Very easily, yes.
So, sir, up to what level you increase your current settings?
So if it was not going inside on my burn, I would have increased the wattage, the current setting on the cutting side by 10 or 20. We can go up to 90, 100 also, but one should be aware that the wire also gets burnt in that case, and sometimes the shearing of wire or the cutting of wire can happen. Now seeing it more and more, I am reasonably sure that this debris will come out. क्या हो गया? और नहीं आया? अच्छा, पुल करें? आ गया? I'm pulling back. आ गया? So the wire was so much inside that it did not come the other end to the balloon. So now I'm doing the third step as we discussed in the morning of passing this balloon. This is a CRE balloon, 15 mm from Boston Scientific. Want to inject contrast or balloon? चला गया? Tight. No contrast. Tight. Yeah? I think चला गया. अब आया. Okay, it's now going inside. So everything I'm seeing under EUS now, I still haven't resorted to my endoscopy view. intermittently, now it's very thick here, so let me just see if it can go in. Gaya. Okay, gaya. Or buccal wall. Let me check endoscopically now.
Yes, sir, it seems.
Where did you see? I didn't see.
Yes, sir, it was in and then it's a compact.
I think it is. Fluoro? I'm also going by my feel, so I'll just see by endoscopy also. Reconfirm, because this CRE balloon does not have the radiopaque.
Sir, you were in and then it's just pulled. It was pulled again.
Arey yaar, is brilliant.
But I think it should be best confirmed in fluoroscopy.
Fluoro by, if I'm using contrast, but I'll use endoscopy view. Now it's, you see the endoscopy view? I made it big and endosonar is small. So best view is now endoscopy. I was not very sure it went in easily, so I have pulled back little bit. Now you inflate.
So now again question is, you are comfortable in endoscopy, final stent deployment and dilatation in endoscopy view or in
So I move from one view to the other. I'm not very fixed key. I will only see in fluoroscopy. I will not use endoscopy. So because I was not very sure that I had gone in, although you observed, which is equally important, and that's why the room partner is equally important. There are several small cues which will be told by your technician. Stop. So I have kitna kiya? That's why working in a team is important. He'll have a gush of fluid, keep the suction ready. So I'm sucking out also the gastric content. So he's done up to 15. 15 ho gaya, Shinu? Okay. So we'll take a, because the large cyst will have at least 500 or more fluid coming out. I can now also cross check on the EUS image. So you see this is a balloon there. Okay. And now I can actually measure the diameter of the balloon also, whether it's gone actually 15 or Srinivas is pulling a fast one. So this is 14.2, which is quite good. You can see the guide wire also inside.
Sir, inflating the CRE with the contrast is better or without contrast?
Look, we have to be cognizant of our Indian settings. We reuse our balloons, and if we put contrast, the balloon life becomes compromised. So use saline and we can reuse the balloon.
Its visibility on the fluoroscopy is compromised when we are not using.
So yes, I'm not using. So I'm sure that the balloon is inside the cyst and half is in the lumen, because I'm seeing endoscopically also. So that compromise I've taken care. So I have a triple vision. I have fluoroscopy, I have endoscopy and EUS. I will use one of them or two of them and use the third one only to confirm if I'm not sure of the other two vision. So now on endoscopy you are sure that we are inside, right? Can you? I'm not descending too much. That's the reason you will probably be not seeing it. But now ready? I want the second wire ready with the, because I want two wires to be placed, and that has to be done very quickly because there will be gush of fluid the moment I decompress. Now through the lumen I'm also peeping inside. Okay, that's okay now? Voice is fine. So now the fluid is coming, gush. So I'll keep sucking out. So while changing, the jar was empty. The suction jar empty है, यही है ना? इसमें जा रहा. शुरू खाली था? नहीं था, पुराने वाले पेशेंट का था. Okay. So that would have told me also कि कितना निकला. कोई बात नहीं. अभी कितने तक है मार्क? 1000 हो गया? तो इसमें से कुछ तो पुराने पेशेंट का भी होगा ना. ठीक है, कोई बात नहीं. But I'll keep sucking out. You see the gush of fluid endoscopically, but I try not to see that. I just keep sucking. Okay. I'll also keep my endosono view. Deflate हो गया? Okay. I'll withdraw now. Again, I back to my guide wire view. I don't want to lose that. Let me get the guide wire view right. And that's the, you see, this is the opening that I have created. Just to show you, this is the opening that I have created between the stomach and the cyst cavity, from which the fluid is coming out. Yes, yes, yes. I have not completed the job. I have not sucked out. So whatever was under high pressure drained out. Now it's probably equal pressure on both the sides. It will drain out slowly. Wire अंदर है? I'm not seeing the wire. फ्लोरो वायर दिखा है, वायर अंदर ही है, क्यों नहीं दिख रहा? हाँ इधर ओके नीचे वायर है, but I want the exact exit point is more important, not the lower end. I want the here it should be here. This is a fistula which here it is. Okay, this wire point is more important, not so for Ashish, if you can, where is it gone? Wire in this point. So this wire is more important than this wire. I'll unfreeze now. Okay. अब तो आधे से भी कम हो गया पानी. अभी भी है ओके. उस एंगल में था.
Instead of waiting and suctioning, can you put the stent immediately after dilatation?
So here we are using a plastic stent, and we have to place 2 plastic stents. So 2 plastic stents, we need 2 wires up front. So that's why we have to wait. If it was a metal, I would have done it straight away, and which I have drained all the fluid also by now. No, I'm using a plastic stent in this case. I'm using a 7 French 2 plastic stents, and I'm using a catheter which can allow 2 wires to go inside. I'm pushing that catheter, the 10 French pusher tube. Wire tight. Again, I think it's come. Here it comes. Okay, you saw that? It's like a stent only. So push the wire now. The second wire will now go inside. So this bigger channel catheter will take 2 wires. Already the second wire will go over the first wire. Flora? You saw the second wire going in now fluoroscopically? Flora, please, once. So 2 wires are there inside. Agreed?
Yes, sir.
Okay, stop. So I'll pull it out, leave both the wires inside. I'm not losing the wire on EUS all the time. I'm keeping that view, and I can see the 2 wires now coming out from the EUS view. So now we'll have the stent 7.4 क्या है 7.5 okay. So 7 French 5 centimeter long double pigtail stent with a mark in the center of the stent. Okay, marked by the ink.
This step is actually not clear. How you did this second wire? Actually, with the same opening or separate puncture?
No. So you saw everything I did. We made the first puncture, passed the wire, cystotome, dilated with the balloon. My first wire is still in, it's not come out. Okay, तो कौन सा बीच में ये blue wire, white ये वाला ना. So the second wire was placed by passing a 10 French pusher tube over the first wire, and the tip of the pusher tube went inside the catheter cavity, into the cavity, which I confirmed on the EUS image only, because it's not radio opaque, so I will not be able to see on fluoroscopy, but I confirmed when the second wire passed in. So I use my EUS view there. So त्रिदेव रहता ना, त्रिनेत्र. शिव जी के 3 आँख हैं, एक आँख से वो भी देख लेते ना. 10 French. Through the 10 French pusher tube, it can allow actually 3 wires to go in. If I wanted a third wire also, I could have placed that. Now I'm pushing the stent, which will come now. It's going in the channel. I would like to see it. Now this is a very crucial part. If I push very hard, whole stent can go inside the cyst cavity. So I want to be, now it's come. It's come. I can feel that. Here it goes. Fluoro. So there comes the stent. Fluoro continues. दिखा दीजिए थोड़ा सा. So I'll go to endoscopy view and keep the EUS view small. Come back little bit so that I can see the marker. There's a marking by pen in the center of the stent. But I have to distend more. So fluoro please. Andar hai? Local na? 7.5 hai? I think we can leave it now because I'm not seeing it. It's not distending so well. Still some fluid in the stomach. Let me suck it out. There's no hurry. I'll suck out the gastric content and then I will try to distend with CO2. CO2 hai na?
Yes.
Okay. I just saw a glimpse of the stent. Okay, now we see the stent better in the water submerged. Mark somewhere. Screen. हाँ okay. Not. नहीं stent हाथ हटाइए पेशेंट का. Stent दिख रहा है? नहीं दिख रहा. एक मिनट रुको. Let's not hurry it up. एक बार अंदर चला जाएगा तो और मुश्किल हो जाती है. अगर निकालना पड़ता है उसको फिर. मार्क बहुत अच्छा नहीं है ना, डार्क मार्क नहीं है. కనపడలేదండి. ఐ థింక్ రిలీజ్ చేయండి. రిలీజ్ करो. फ्लोरो दिखाइए. फ्लोरो प्लीज. हाँ ओके. फ्लोरो कंटिन्यूस. हाँ ओके. वायर निकाल दे पूरा. वायर निकालो. रिलीज द स्टेंट. ओके. सो यू सी द इनर फ्लैंज, द डबल पिगटेल इन द फ्लोरो. You see that na? So that means it is inside. बहुत ज़्यादा इसको छोटा कर सकते हैं. And I'll withdraw the scope and release the stent. Yes. Okay, हो गया release. Screen. Okay. There's a lot of fluid in the stomach. Let me suck it out first. इसका साइज छोटा कर सकते. बहुत मैग्नीफाइड व्यू है फ्लोरो का. कितना आ गया मैडम पानी? सो गए आप तो. सोना नहीं है. सोना मना है. हाँ ये रेडियो पे क्या है. ओके ठीक. ओके ठीक है. So first read. So I am putting the second stent now. This is also 7.5 huh? Yes. Okay. This is soft है. चलो. स्क्रीन फ्लोरो. नहीं हाथ नहीं कुछ है. अभी दिखाइए. स्क्रीन दिखाइए. ओके. Let me go endoscopy big. है क्या बना दिया? पैसा समझा नहीं मैं. नहीं है हो रहा है. So I am just getting back to the wire again. So now you see again the fluid is coming out from that hole which I have created.
Now it looks like that we have drained more than 50% of the.
It's very difficult to convince surgeons. Thank you. नहीं? Ashish, what do you feel? चलो. गया अंदर. फ्लोरो सेकंड मार्क है. चला गया अंदर. हाँ. I think endoscopy better.
Stent already under, I guess.
अंदर चला गया, पूरा चला गया.
नहीं पूरा नहीं सर, partially.
हाँ. This is a different stent which is a radiopaque marker. दिखाना इसमें radiopaque marker दिख रहा हमको? नहीं दिख रहा ना? हैं? प्लास्टिक है, रेडियोपेक नहीं है? ओह अच्छा अच्छा. अंदर तो नहीं चलाया ना, बस वो सबसे इम्पोर्टेंट है. So I am sucking out fluid again to get my vision right. नहीं तो टर्बिड फ्लूइड के नीचे देखना मुश्किल हो जाता है ना.
And when sir stent just is deployed inside the cavity, it must happen sometimes with everybody. So then what should we do, sir?
हाँ वो बड़ा मुश्किल हो जाता है. अभी बात करते हैं. लेट मी फिनिश दिस, नहीं तो बिफोर आई पुश दिस वन इनसाइड. चला गया कितना है अंदर? और कर सकते हैं? नहीं आई थिंक कुछ नहीं पुश करना. नहीं रुको रुको रुको. हाँ फ्लूइड ज़्यादा है ना, इसीलिए वेस्टर्न वर्ल्ड में दे यूज इंट्यूबेशन. दे इंट्यूबेट द पेशेंट सो द रिस्क ऑफ एस्पिरेशन इज गॉन डाउन. भर गया जार, भर गया पूरा? नहीं भरा, अभी 1500 पहुँचा तो 500 तो आ ही गया ना इसमें से. चलिए आप मान तो गए. चलो इसमें गया ना, मार्क आ गया, ब्लू मार्क दिख रहा है. नाउ आई थिंक वी आर क्लोज. लेट मी कम क्लोज. हाँ ओके ओके, रिलीज रिलीज नाउ. वेयर इज द फर्स्ट स्टेंट? आई एम नॉट सी. अच्छा उधर है, ओके इधर है. ओके रिलीज 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 रिलीज. निकाल दिया? इट हैज टू कम. या so both the stents have been deployed now. I'll spend now some time in sucking out the fluid first, which is the primary aim. I will answer a question, Ashish, just a minute. Let me concentrate fully on this case first. So fluid in the fundus, which has to be sucked out. And now the collaterals are becoming more prominent in the fundus of the stomach, which means splenic vein, portal vein thrombosis. Now this you see the cavity, which is still big, but it was probably under too much pressure if the fluid came out. Still substantial amount is there. So let me spend some time sucking out. But the good part is there is no bleeding, which I was concerned because of the, and one stent is seen. Other stent कहाँ गया? अरे दूसरा कहाँ है? ये रहा, fold के पीछे है. नहीं नहीं migrate नहीं है. But this is a little bit deeper तो नहीं चला गया अंदर. Let me insert some air after decompressing. Shinu? हाँ फ्लोरो में दिख जाएगा. फ्लोरो देखिए जरा. Let me distend well now and see. अब तो अच्छा कर सकते हैं distend ना. अगर ज़्यादा है तो if it is deeper I can pull it back also because it's still visible. नहीं नहीं pull नहीं पूरा pigtail तो बाहर ही है ना. It is so boggy here, that's why it's looking like. So this is the end hole and that's the entry point. So it's okay. I think the two stents are fine. So I think the job is done, and this fluid, rest of the fluid will drain out slowly. Give it time. In a day or so it should come down. This is the stent that we are opening now. You see that stent there? EUS view pe? If need be, I will 2-3 days later, if the patient has symptoms, I will dilate it and go inside and then clean up the muck. But I have a feeling that this will actually come down. This is a very loose debris which is floating around, and some.
The main problem in this patient, unless we are not completely evacuating all those solid components, the patient will always.
So give it time. Give it time. Utpal.
So
So for cleaning, we have to again remove this plastic stent and.
No, so what we will do is, now I'll come out. I think I've done. So, kitna nikla total fluid, amma? So, when we, so suppose we have to do a necrosectomy 3 days later, then we will go with a simple cannula with a guide wire beside these two stents with a forward wing endoscopy under fluoroscopy. So, the wire then coils inside. We'll dilate that path with a balloon, a 15 balloon, and then as we collapse the balloon, we'll take the scope, push it inside the cavity, and then take out the balloon. You will see the cavity better. You can irrigate it also and use a snare to take things out. But go beside the stent. Unless stent is hindering with a necrosectomy, then only remove it off. If it's not hindering, you can complete the job. You can also place a nasocystic tube. Suppose he happens to develop infection, and we want to avoid surgery, which is our primary aim. Then we can place a nasocystic tube like the previous case and irrigate. Yes, please.
Yeah. Sir, would you like to put a nasogastric tube for evacuation of the fluid?
So I have sucked out the content now. The pressure now the cyst is partially collapsed, but not in very high pressure. So I don't expect it to drain out so instantaneously and aggressively to cause a risk of aspiration subsequently. But I will keep a watch on him by my colleagues so that they can keep him on left lateral so that the aspiration does not happen. That's absolutely that's a fair point. I agree with you. We can put a Riles tube also, keep it continuous drainage. Okay.
Thank you, sir.
Thank you.
Well done. एक शेर सुनाता हूँ आपको.
सुनाइए इरशाद. अरे मैं सुनने को तैयार हूँ. ऊपर से अच्छा चलिए. हाँ ठीक ठीक. अच्छा ठीक ठीक. हाँ हाँ फरमाइए.
अगर मैं मुमतहिन होता, मुमतहिन means examiner. I cannot be.
क्यों?
पर अगर भगवान ने कभी बनाया होता, अगर मैं मुमतहिन होता, तो नंबर 100 के 100 देता. लियाकत के अलग देता. मेरिट, लियाकत is talent, your skill. लियाकत के अलग देता और नजाकत के अलग देता.
बहुत खूब. थैंक यू. ये हटा दे.
4 केस हमने दिखाया है और आफ्टरनून में भी कुछ केसेस दिखाएंगे, इसके बारे में डिटेल जानकारी अपनी नोट्स में लीजिए।
ओके अच्छा, तो आज थैंक यू वेरी मच आपको जानने की वजह से इस मीटिंग के 4 चांद लग जाते हैं, बिकॉज नाउ वी कैन कन्वे टू नॉर्मल ऑडियंस आपके ज़रिए से। तो जो हमने आज केसेस दिखाए थे ये एडवांस्ड एंडोस्कोपी प्रोसीजर्स थे, जिसमें पहला केस जो हमने किया था वो पैनक्रेटिक फ्लूइड कलेक्शन, मतलब पैनक्रेटाइटिस अटैक के बाद पैनक्रियास थोड़ा सड़ जाता है, उसके आसपास पानी इकट्ठा हो जाता है, उसमें इन्फेक्शन आने का चांस होता है। उस पेशेंट को था, उसमें एक स्पेशल तरह का एक स्टेंट लगाया, मेटल का एक स्टेंट, जिसको हम हॉट एक्सियोस बोलते हैं। जो होता तो महंगा है लेकिन बहुत इफेक्टिव स्टेंट होता है। अभी सुनाई दे रहा है? अब बेहतर है। तो पहले केस में इन्फेक्टेड वॉल्ड ऑफ नेक्रोसिस करके बीमारी थी इस मरीज को, जो सीवियर एक्यूट पैंक्रेटाइटिस के बाद में कभी गंभीर रूप का पैंक्रेटाइटिस होता है, जो कई बार जानलेवा हो सकता है। जैसे जैसे मरीज इम्प्रूव करता है, ये पानी जो इकट्ठा होता है पैनक्रियास के आसपास में, इंक्लूडिंग पैनक्रियास को भी लेके रखता है, उसमें डेड पैनक्रियास टिश्यू होता है। अगर उसको नहीं निकालते हैं तो आगे चल के ये इन्फेक्शन पूरे बॉडी में फैल सकता है और जानलेवा हो सकता है। तो उसको निकालने का तरीका पहले ज़माने में हम सर्जरी से इस्तेमाल करते हैं, और अभी भी कई बार यूज़ करते हैं, पर अगर वो फेवरेबल एनाटमी रहता है, मतलब कि ऐसी पोजीशन में है जो बिना सर्जरी के हम अंदर से माइक्रो सर्जरी एंडोस्कोपी से कर सकते हैं, तो वो कर लेना चाहिए, जिसमें ऊपर से काटा पीटी नहीं होता, अंदर से ही इन्फेक्शन निकल सकता है। और इसमें हमने एक स्पेशल तरह का स्टेंट इस्तेमाल किया, इसको हॉट एक्सिस बोलते हैं, और उसके ज़रिए से काफ़ी सारा पस निकल गया। बाकी धीमे धीमे पेशेंट मरीज जैसे जैसे इम्प्रूव करेगा, इस स्टेंट को कम से कम 3-4 हफ्ते के बाद में हम निकाल सकते हैं, वो ठीक रहेगा फिर। तो एक सर्जरी बच जाती है, जो जहाँ तक अवॉइड इसका सर्जरी अवॉइड ही करना चाहिए। ठीक है। दूसरा केस जो हमने किया वो एक पिक्यूलियर बीमारी है, जो ज़्यादातर इंडिया के ईस्टर्न पार्ट या साउदर्न पार्ट में मिलती है, साउथ में और ईस्ट में मिलती है, खासकर बिहार, बंगाल, असम, तेलंगाना, आंध्रा, केरला। इसको क्रॉनिक पैंक्रेटाइटिस बोलते हैं। क्रॉनिक पैंक्रेटाइटिस में पैंक्रियास सिकुड़ जाता है, उसकी नाली के सिकुड़ने की वजह से उसमें कभी कभी स्टोन बन जाते हैं, और वो स्टोन नाली को ब्लॉक करते हैं। तो इसको निकालने का तरीका 2 मेन रहता है, या तो सर्जरी करके पूरा बड़ा ऑपरेशन करके उसको निकाला जाए, या दूसरा तरीका होता है कि उसको स्टोन को अंदर से ही हम तोड़ सकें मशीन के द्वारा, जिसको लिथोट्रिप्सी बोलते हैं, और उसके बाद एंडोस्कोपी से उस चूरे को पैनक्रियास की नाली से निकाल सकते हैं। लकीली इस पेशेंट को जो स्टोन था वो छोटा स्टोन था, बहुत बड़ा नहीं था, और नाली में बहुत टाइट नहीं फंसा था। हल्का फंसने की वजह से उसमें हम पैनक्रियास की नाली का जो नॉर्मल मुंह होता है वो 1 मिलीमीटर करीब होता है, उसको हमने चौड़ा करके करीब 5 मिलीमीटर माइक्रो सर्जरी से किया, और उसके अंदर उसका जब जूस निकलने लग जाता है आराम से, तो उसको पेन में आराम मिलेगा फ्यूचर में। और एक हमने पतला सा प्लास्टिक पाइप भी लगाया जो अलाउ करता है ये जूस को ड्रेन करने के लिए। जो तीसरा केस किया वो बहुत ही पिक्यूलियर केस था, जो एक तरह का रेयर ट्यूमर है जिसको हम जिस्ट बोलते हैं, गैस्ट्रोइंटेस्टाइनल स्ट्रोमल ट्यूमर, जो सीटी स्कैन में इतना बड़ा नहीं दिख रहा था। और हमारे सर्जन कोलीग जब देख रहे थे, रेडियोलॉजी कोलीग देख रहे थे, तो उनका ओपिनियन था कि इसकी हम डायरेक्ट सर्जरी कर दे तो बेहतर रहेगा। तो ये डिस्कशन होने के बाद हमने कहा कि चलो अंदर से देखते हैं, और अंदर से एंडोस्कोपिक अल्ट्रासाउंड के द्वारा हमने चेक किया कि ये जो ट्यूमर दिख रहा था वो उतना ही छोटा नहीं था, बड़ा था और गंभीर रूप वाला था। तो जब गंभीर रूप वाला ट्यूमर होता है जिसमें कैंसर की संभावना ज़्यादा बढ़ जाती है, उसमें सर्जरी कर सकते हैं, लेकिन कभी कभी सर्जरी इनकम्प्लीट रह जाती है। तो उसको हमने अंदर से ही बायोप्सी ली है उस ट्यूमर की, और इस बायोप्सी की रिपोर्ट के हिसाब से हम डिसाइड कर सकते हैं आगे कि क्या पहले हम दवाई दे के ट्यूमर को श्रिंक करके फिर सर्जरी करें तो मरीज के लिए ज़्यादा लाभदायक होगा। शायद अगर हम डायरेक्ट सर्जरी करते हैं तो और इनकम्प्लीट सर्जरी होती तो हो सकता है उस मरीज को 2 सर्जरी की आवश्यकता पड़ सकती थी फ्यूचर में। तो वो आज वो डिस्कशन से निकला, और मुझे उम्मीद है, अभिजीत यू वुड एग्री टू दैट, कि दैट वाज अ लार्ज जिस्ट विथ मेलिग्नेंट ट्रांसफॉर्मेशन टाइप चेंजेस, तो उसको बायोप्सी की रिपोर्ट हमको 4-5 दिन में उपलब्ध हो जाएगी। और उसके बाद वो इसके लिए दवाइयाँ काफ़ी अच्छी आपको उपलब्ध हो गई हैं, और ये आमतौर से 3 से 6 महीने में काफ़ी हद तक ट्यूमर श्रिंक हो जाता है। तो अगर 6 सेंटीमीटर का ट्यूमर 2 या 3 सेंटीमीटर के साइज़ में आ जाए तो सर्जरी भी आसान हो जाती है और एक बार में कंप्लीट क्योर हो जाता है। चौथा केस जो हमने किया वो एक मरीज को वही पैनक्रियास फ्लूइड कलेक्शन था, लेकिन काफ़ी बड़ा कलेक्शन था, ऑलमोस्ट 1 लीटर पानी उसके अंदर था, और इस पानी के साथ साथ कचरा भी था। और इसको निकालने के लिए इस बार हमने मेटल स्टेंट की बजाय ट्रेडिशनल प्लास्टिक स्टेंट इस्तेमाल किया है, जो सस्ता भी रहता है और इफ़ेक्टिव भी रहता है। और इससे पानी तो पूरा निकल गया, जो कचरा वाला पार्ट, जो सॉलिड पार्ट, जो काई जैसा रहता है, वो धीमे धीमे उम्मीद है कि नेक्स्ट 2-4-5 दिन में और कम हो जाएगा। अगर वो नहीं कम होता और फिर भी ज़रूरत पड़ती कि उसको भी निकालने की आवश्यकता पड़ती, तो उसको भी हम बिना सर्जरी के एंडोस्कोपी के द्वारा ही जिस रास्ते से हमने स्टेंट लगाया उसी रास्ते से जाके अंदर से उस काई को निकाल सकते हैं। तो यहाँ पे भी हम सर्जरी अवॉइड कर सकते हैं इन फेयर प्रोपोर्शन ऑफ केसेस। ऐसा नहीं होता है कि सारी चीज़ें हम एंडोस्कोपी से ही ठीक कर सकते हैं, इसीलिए हर बड़े इंस्टीट्यूशन में टीम का इम्पोर्टेंस बहुत इम्पोर्टेंट है। और इस टीम में सिर्फ एंडोस्कोपिस्ट नहीं, गैस्ट्रोएंटरोलॉजिस्ट भी रहते हैं, सर्जन भी रहते हैं, रेडियोलॉजिस्ट भी रहते हैं, और सब 4-5 लोग मिल के निष्कर्ष करते हैं कि किस तरीके से हमको अप्रोच करना है। अगर सबको लगता है कि नहीं ये सर्जरी से बेटर ट्रीटमेंट होगा, जब कई सारे पॉकेट्स होते हैं, ज़्यादा इन्फेक्शन होता है और एक बार में हमें कंप्लीट काम करना होता है, तो हम कई बार स्टार्ट ही सर्जरी से करते हैं। और कई बार पेशेंट की कंडीशन अगर स्टेबल है या बहुत क्रिटिकल है कि सर्जरी भी नहीं कर सकते, तो हम या तो इंटरवेंशन रेडियोलॉजी से पाइप लगाते हैं ऊपर स्किन के द्वारा, या एंडोस्कोपी के जरिए से पाइप लगाते हैं अंदर से।
इस तरह का सर जो बीमारी है इससे बचने का क्या उपाय है? नहीं, तो सर्जरी तो लास्ट चॉइस से बचने वाले किसी को ना हो।
ये बड़ा सही सवाल पूछा आपने, पर ये प्रिवेंटिव सवाल है। ये है कि बीमारी होने के बाद हमारे पास आया, किसी को नहीं हो, आपका सवाल वो वाला है ना। तो उसमें तो खान पान तो इम्पोर्टेंट रहता है। दूसरी चीज़ होती है, कई बार गॉल ब्लैडर में पथरी रहती है और वो स्टोन अगर सड़क के पित्त की नाली में फंस जाता है तो उससे ना जॉन्डिस होता है बल्कि पैनक्रेटाइटिस भी हो जाता है। तो बहुत डेंजरस सिचुएशन है। इस डेंजरस सिचुएशन से दूर होने ना पहुंचने के लिए हमको, अगर किसी मरीज में स्टोन पहले से ही मालूम पड़ जाता है कि उसको हल्का दर्द हुआ, कभी अल्ट्रासाउंड में स्टोन पकड़ में आ गया, तो सीधे सर्जरी करके, सिंपल लैप्रोस्कोपी सर्जरी करके हम गॉल ब्लैडर को पहले निकाल सकते हैं, जिससे कि ये स्थिति नहीं आए। इसलिए किसी को भी अगर गॉल ब्लैडर स्टोन है और वो तंग कर रहा है दर्द से, तो उसको पाल के नहीं रखना चाहिए, जितनी जल्दी हो सके ऑपरेशन करके निकलवा लेना चाहिए। और ये बड़ा आसान सर्जरी, आजकल एक्सपर्ट सर्जन हर जगह
से बच जाएगा। और ये काफ़ी कम समय में हो जाता है। जैसे कि हम लोग यदि पेट का पानी को ड्रेन करते हैं इंडोस्कोपिकली तो मैक्सिमम 15-20 मिनट में काम हो जाती है। सर्जरी वही पेशेंट में 2 घंटे की सर्जरी शायद होगी।
जैसा कि डॉक्टर संदीप ने बताया, डॉक्टर रमेश ने बताया, आजकल ये हम लोग मरीज़ के हित में करते हैं कि कम से कम प्रोसीजर पेशेंट को हो। तो ये तो हम नहीं कहेंगे कि सर्जरी नहीं होती, दोनों को साथ साथ चलना होता है। और पहले हम लोग कोशिश ये करते हैं कि एंडोस्कोपी से, जो कि एक मिनिमली इन्वेजिव प्रोसीजर है, सर्जरी थोड़ा सा, हालांकि सर्जरी भी लैप्रोस्कोपिक सर्जरी भी मिनिमल इन्वेजिव है, लेकिन पैंक्रेटाइटिस में खास तौर से कम से हम लोग शुरू करते हैं, फिर ज़्यादातर जाते हैं। तो इसमें एंडोस्कोपी पहले कोशिश करते हैं, रेडियोलॉजी पहले कोशिश करते हैं। अगर उससे कामयाबी नहीं मिलती है तो फिर आखिरी में सर्जरी, मरीज़ को सर्जरी ऑफर करते हैं। और हमारा ये भी मानना है कि सर्जरी एक वन टाइम प्रोसीजर है, और एंडोस्कोपी हर जगह, स्पेशली बिहार में, उत्तर प्रदेश में, जहाँ इतना विकास अभी नहीं हुआ है, एक्सपर्ट से नहीं है, और एंडोस्कोपी थोड़ी सी एक्सपेंसिव भी है, जो जनरल पब्लिक के लिए उतना अवेलेबल नहीं है। लेकिन जैसे यहाँ के बिग हॉस्पिटल का बहुत अच्छा सेंटर है, यहाँ पे सारी सुविधाएं हैं, तो मरीज़ के हित में आज के आधुनिक युग में ये अनिवार्य है कि आप पहले उसको जो बेस्ट प्रोसीजर है, जो मिनिमली इन्वेजिव प्रोसीजर है, जो मरीज़ टॉलरेट कर ले, खासकर पैंक्रेटाइटिस में, घातक बीमारी जो है पैंक्रेटाइटिस है, उसमें हम लोग स्टेप बाय स्टेप चलते हैं, इसको स्टेप अप अप्रोच भी बोलते हैं। और एंडोस्कोपी और रेडियोलॉजी को पहले हम लोग चूज़ करते हैं यूजुअली, और फिर सर्जरी को आखिरी में रिजर्व करते हैं। तो सबको साथ साथ चलना है, और हमें लगता है कि जैसे कि एक टीम अप्रोच जो कि उपलब्ध है यहाँ पे बिग हॉस्पिटल में, उससे मरीज़ का हित होता है।
सर, लास्ट एक डे टू डे लाइफ में क्या कुछ पेशेंट को, एक कोई भी पर्सन को क्या कुछ प्रिकॉशन बरतना चाहिए जिससे ये सब चीज़ बीमारी से बचा जा सके?
तो प्रिकॉशन जैसे कि आप बताएं, प्रिवेंशन के लिए जैसे डॉक्टर संदीप ने बताया, गॉल स्टोन्स हैं, ये फीमेल में ज़्यादा कॉमन है, और अल्कोहल वगैरह मेल में ज़्यादा कॉमन है। और भी कंडीशन है, कुछ दवाएं हैं जिससे पैंक्रेटाइटिस होती है, कुछ मेडिकल कंडीशन होती हैं जिसमें कि लिपिड का ज़्यादा है, हार्मोनल प्रॉब्लम्स होती है, तो उन सब की वजह से पैंक्रेटाइटिस होती है। और करीब 30% लोगों में पता भी नहीं चलता है कि क्यों हुई, कॉज क्या है, इसको इडियोपैथिक पैंक्रेटाइटिस बोलते हैं। तो इसकी अवेयरनेस होनी चाहिए, इसके बारे में पता होना चाहिए। और क्रॉनिक पैंक्रेटाइटिस ऐसे बताया कि हिंदुस्तान में, साउथ में, ईस्ट में कॉमन ट्रॉपिकल पैंक्रेटाइटिस उसको बोलते हैं, लेकिन उसका भी कारण आजकल ठीक से पता नहीं चल पाता। पहले मानते थे कि कोई जन्मजात कोई जेनेटिक म्यूटेशन होगा, लेकिन ऐसा नहीं है। इंडिया स्पेसिफिक है ट्रॉपिकल पैंक्रेटाइटिस, और ये हमने देखा है कि यंग लोगों में होता है। और इसको भी हम लोग को प्रिवेंशन का तो इसमें कोई सवाल नहीं, क्योंकि कोई कारण नहीं मिलता कई बार इसमें। और इसका बस ये है कि अर्ली ट्रीटमेंट होना चाहिए, ताकि और पैनक्रियास डिस्ट्रॉय ना हो आगे उसमें, और जो उसका इंसुलिन बनाना काम होता है और डाइजेशन में काम होता है, तो वो आगे पैनक्रियास बच जाए। और इन बच्चों में स्पेशली एंडोस्कोपी, जैसे आपने देखा कि करके स्टोन निकालना, लिथोट्रिप्सी से स्टोन तोड़ना, तो उससे पैनक्रियास आगे डैमेज से बच सकता है। थैंक यू।
जैसे जैसे हमारा मेडिकल साइंस डेवलप कर रहा है, वैसे वैसे हम लोग सर्जरी का रोल कम होता जा रहा है। तो पहले जो बीमारी पेट, मतलब ऑपरेशन पेट का करके ही संभव था, अब वो दूरबीन से होने लगा, लैप्रोस्कोपी से होने लगा। और अब उसका नेक्स्ट स्टेज ये है कि अब लैप्रोस्कोपी भी करने की ज़रूरत नहीं है, पेशेंट को सिर्फ बेहोश करने की भी ज़रूरत नहीं है, सिडेट करके। और एंडोस्कोपिक से, एंडोस्कोपी तो आप लोग सब जानते ही हैं, तो एंडोस्कोपी से बहुत सी बीमारियों का अब इलाज संभव हो गया है। जो कॉम्प्लेक्स बीमारियां हैं उनका भी इलाज अब एंडोस्कोपी से हो गया है। ये तो आज हम लोग पैंक्रियास के बारे में चर्चा कर रहे हैं। बहुत से कैंसर का इलाज अर्ली स्टेज, अब पहले अब डायग्नोसिस में भी देर होता था, अब जल्दी डायग्नोसिस हो जाता है। तो बहुत से कैंसर का इलाज भी अब एंडोस्कोपी से हो रहा है। तो जैसे जैसे साइंस डेवलप करेगा, मेडिकल साइंस डेवलप करेगा, सर्जरी का रोल कम होता जाएगा और मरीज को कम से कम सर्जरी या चीर फाड़ से बचाया जा सकेगा। तो निष्कर्ष यही है कि अब हम लोग जैसे जैसे साइंस डेवलप कर रहा है, इन्वेजिव प्रोसीजर्स कम होते जा रहे हैं।
एक मिनट डॉक्टर संदीप और बताएंगे, क्रॉनिक पैंक्रेटाइटिस में आप जेनेटिकली प्रीडिस्पोज रहते हैं, उसके लिए क्या किया जा सकता है, और डॉक्टर पंकज जिन्होंने सारा ऑर्गेनाइज किया है वो लास्ट में 1 मिनट।
तो एक चीज़ मैं एलैबोरेट करूँगा। आज से 5-10 साल पहले हम ज़्यादातर पैंक्रेटाइटिस या क्रॉनिक पैंक्रेटाइटिस जो होता था, हम बोलते थे कि कोई रीज़न नहीं मिल रहा है, इडियोपैथिक पैंक्रेटाइटिस बोलते हैं। कुछ सेंटर्स में हम लोग ने रिसर्च ज़्यादा की है और उसमें मालूम पड़ा है कि अगर हम इसमें जेनेटिक टेस्टिंग करें तो कुछ म्यूटेशंस मिलते हैं, जिसमें खासकर एक PRSS1 और SPINK1 करके 2 जीन्स हैं जो बहुत इम्पॉर्टेंट हैं, जो इंडिया स्पेसिफिक है। इंडियन सब कॉन्टिनेंट में जो पैंक्रेटाइटिस ज़्यादा है, ये छोटे बच्चों में पैंक्रेटाइटिस आ जाता है और ये बहुत जल्दी स्टोन फॉर्मेशन या सीवियर बीमारी रूप लेना शुरू कर देता है। तो हमें जेनेटिक टेस्टिंग करना चाहिए, खासकर जब और कोई कारण, क्योंकि छोटे बच्चों में स्टोन भी नहीं होता और ड्रिंक की संभावना भी नहीं होती, और अगर मेटाबॉलिक कॉज जैसे कैल्शियम बढ़ना या ट्राइग्लिसराइड बढ़ना नहीं है तो जेनेटिक टेस्टिंग कर लेना चाहिए। और कई बार उससे हमको ये आइडिया लग जाता है कि बीमारी किस तेज़ी से या किस स्पीड से बढ़ने वाली है।
थैंक यू सो मच आप लोगों का, आप लोग यहाँ पे आए और इस प्रोग्राम को सक्सेसफुल बनाने में अपना योगदान दिए। विजय प्रकाश सर को भी धन्यवाद, संदीप लखतकिया सर को धन्यवाद, अभिजीत सर को, विजय मित्तल सर को एंड रमेश सर को इस प्रोग्राम को सक्सेसफुल बनाने के लिए। थैंक यू सो मच।
कितना दिन तक रह सकता है और मरीज को कितना दिन में आराम मिल जाएगा?
ये मेरे हिसाब से 3 से 5 दिन में उसको और लाभ मिलेगा। फर्स्ट 24 आवर्स में तो मैक्सिमम लाभ मिलेगा।
क्या तकलीफ हो तो मरीज हॉस्पिटल में पहुंचे, जैसे आम आदमी को हमको बताना है मरीज की क्या तकलीफ, किस तरह का सिम्टम होता है, लोग को अस्पताल में आना चाहिए उस समय।
अगर दर्द बना हुआ है और आराम नहीं मिल रहा रूटीन दवाई से, तब इसको इन्वेस्टिगेट करना चाहिए कि दर्द क्यों नहीं कम हो रहा है। और अगर टेस्टिंग से मालूम पड़ता है, जिसमें अल्ट्रासाउंड या CT स्कैन या MRI करने से मालूम पड़ता है कि पानी का थैली बन गया है और वो बढ़ता चला जा रहा है साइज में, तो या तो फटेगा या वो ब्लीडिंग होने का एक चांस है। तो उससे पहले कि ये कॉम्प्लिकेशन आए, अगर हम उसको एंडोस्कोपी से उसको डिफ्यूज़ कर सकें, अगर मैं उस वर्ड यूज़ कर सकता हूँ कि एंडोस्कोपी से उसको डिफ्यूज़ कर सकें, तो एक तो उसको आराम मिलेगा, दूसरा कॉम्प्लिकेशन की तरफ नहीं जाएगा।
एक ये बताइए कि किन बीमारियों का आपने इलाज किया था?
मैंने 2 एक्यूट पैनक्रेटाइटिस, जिनको पैनक्रेटिक फ्लूइड कलेक्शन मतलब पानी का बड़ा थैली बन गया था, जिसके अंदर करीब 1 लीटर फ्लूइड एक मरीज में था, दूसरे में करीब 700 ml फ्लूइड था, एक में पस था जिसका आमतौर पे चीरा दे के बड़ा ऑपरेशन करके निकालते थे आज से हम लोग कुछ साल पहले। पर अब ये नए स्टेंट की वजह से हम बिना सर्जरी के अंदर से ही उसको ड्रेन कर सकते हैं, चीरा देके, छोटा चीरा करके स्टमक से कलेक्शन में ड्रेन करके निकाल सकते हैं। तो चारों का हमने एंडोस्कोपी से इलाज किया। एक मरीज का इलाज हमने सर्जरी और ऑन्कोलॉजी वालों को मदद करने के लिए किया कि हमने अंदर से बायोप्सी लिए, नहीं तो कई बार ओपन करके बायोप्सी लेना पड़ता था या स्किन के जरिए से पूरा टिश्यू नहीं आता था। तो वो एक रेयर टाइप का ट्यूमर है जो हमने बायोप्सी लिया। उसकी उम्मीद है कि अगले 3-4 दिन में बायोप्सी की रिपोर्ट उपलब्ध हो जाएगी और उससे क्लियर मालूम पड़ जाएगा, जिसमें हम दवाई से उसको श्रिंक कर सकते हैं।
दूसरा विजय सर, अब दोबारा
1 मिनट, आज के कॉन्फ्रेंस का थीम ही है पैंक्रियाटिक डिजीजेस में एंडोस्कोपी से हम लोग कैसे कैसे मदद कर सकते हैं विभिन्न तरीके से। एक दूसरा, जो पूरे इंडिया में गैस्ट्रोएंटरोलॉजी का मक्का माना जाता है, वो इनका इंस्टीट्यूट है। यही नहीं, इंटरनेशनल रिकॉग्निशन भी इन्हीं के इंस्टीट्यूट का है। वो सारे इंटरनेशनल जो ग्रुप बनते हैं लोग सब में पार्टिसिपेटिव होते हैं। तो AIG हैदराबाद, एशियन इंस्टीट्यूट ऑफ गैस्ट्रोएंटरोलॉजी हैदराबाद।
जैसे BIG हमारा AIG,
संदीप लखतकिया इनका नाम है। इलाहाबाद के आप हैं और
अब हैदराबाद में बसे हुए मैं अपने आप को पूरा भारतीय मानता हूँ।
मैमसी में पढ़े, मौलाना आज़ाद में, फिर पीजीआई चंडीगढ़ में पढ़े, फिर लखनऊ में पढ़े और जाके हैदराबाद में बस गए, एआईजी में है।
अब सर ये तो जैसे ये चारों पेशेंट का इलाज किए, अब इनको आगे बेटर कैसे रखें, उनके लिए क्या करते हैं?
ये भी एक पेशेंट है
बाकी जैसे बहुत सारा होता है कि ठीक है सर्जरी करा लिया अब घर चले गए, लेकिन उनके लिए कुछ बचाव के लिए या लंबा ठीक ठाक चले?
मेरे हिसाब से 2 मरीज जिनका हमने ड्रेन किया है, अब जैसे जैसे वो अगले 2-4 दिन में ठीक हो जाएंगे, इनका आगे फर्दर और कुछ इलाज की आवश्यकता नहीं है। दे शुड बी नॉर्मल। हालांकि कई बार समय के साथ पैनक्रियास थोड़ा वीक रह जाता है, साइज छोटा हो जाता है, तो कई बार डायबिटीज़ आने की संभावना रहती है। तो इनको थोड़ा डाइजेशन का ध्यान रखना पड़ता है कि एक साथ बहुत ज़्यादा नहीं खाना, जिससे क्योंकि पैनक्रियास वीक है, पैनक्रियास का मेन काम खाने को डाइजेस्ट करना होता है। तो थोड़ा थोड़ा करके कई बार में खाना, एक प्रिकॉशन। दूसरा, जो लोग ड्रिंक करते हैं ड्रिंक नहीं करना। तीसरा, कोई स्मोक करता है स्मोक नहीं करना, क्योंकि ये दोनों चीज़ें पैनक्रियाटाइटिस करती है। ना कि पैनक्रियाटाइटिस करती है, बल्कि स्मोकिंग तो कई बार पैनक्रियाटिक कैंसर तक पहुंचा देती है। ठीक है। और अगर स्टोन है तो स्टोन का दूर रखना। अगर किसी को डायबिटीज़ नहीं है अभी, पर इनकी संभावना है कि अगले 6 महीना, साल, 2 साल में डायबिटीज़ आ सकता है, तो शुगर का हमें खास ध्यान रखना चाहिए कि मीठे से दूर रहना और पूरा प्रिकॉशन, हेल्दी लाइफस्टाइल बहुत ज़रूरी है अगर शुगर ना आए। रमेश, आप कुछ ऐड करना चाहेंगे?
सर, इसमें एक सवाल ये था कि जैसे बिहार हुआ या फिर पूरा इंडिया देखा जाए तो पैंक्रियाटिक डिजीज जो है बच्चों में और एडल्ट्स में काफ़ी रेशियो से बढ़ रही है, क्यों?
बड़ा अच्छा सवाल है आपका। तो जो बड़ों में है उसमें अल्कोहल और गॉल ब्लैडर स्टोन्स मेजर कारण है। अगर 100 लोग को है तो 70-75 लोगों को ये दोनों रीज़न मिलता है। बिहार तो बचा हुआ है क्योंकि अल्कोहल नहीं है यहाँ पे, उम्मीद है मुझे ऐसा। और गॉल ब्लैडर स्टोन्स ज़्यादा है और उसकी वजह से होता है। 30% में, जैसे डॉक्टर अपने बताया कि अभिजीत ने बताया कि कॉज नहीं मालूम पड़ता, उसमें रेयर कॉज ढूंढना पड़ता है, जो कि या तो ट्राइग्लिसराइड या कोलेस्ट्रॉल बहुत हाई रहने से हो जाता है। कुछ दवाइयाँ हैं जो पैनक्रियाटाइटिस कर सकती हैं। किसी का कैल्शियम बहुत ज़्यादा तो कर सकता है। और लास्ट बट नॉट द लीस्ट, कभी कभी ट्यूमर्स भी कर सकते हैं। पैनक्रियाटिक ट्यूमर्स भी फर्स्ट टाइम प्रेजेंट कर सकते हैं पैनक्रियाटाइटिस की वजह से। बच्चों में ना स्टोन बहुत कॉमन है और अल्कोहल और स्मोकिंग का सवाल ही नहीं होना चाहिए, तो वहाँ पे जेनेटिक कॉज बहुत ज़्यादा है। और हमको खासकर इस चीज़ में बहुत ध्यान से जाना चाहिए कि किस में कौन कौन से जीन्स में म्यूटेशंस हो चुका है। उस हिसाब से हम बता सकते हैं कि आगे चल के क्या स्थिति रहेगी। और अगर हम उनके पिता और माता जी का चेक करें और बाकी फैमिली में डिटेल में जाएं, तो कभी कभी उस फैमिली में भी किसी न किसी को पैनक्रियाटाइटिस की बीमारी आ चुकी होती है, जेनेटिक कॉज में। सो वन शुड बी अलर्ट अबाउट इट कि ऐसा हो सकता है और फ्यूचर में कैसे उसको अवॉइड करना है।
खाने चले सबको बहुत बहुत धन्यवाद। half an hour.
Good afternoon, everyone. First of all, my thanks to Dr. Vijay Prakash, Dr. Saket, Dr. Nitin is here, who are all with me in KGMU, for inviting me. And basically, I'll be discussing about the surgical aspects of chronic pancreatitis. I don't know, many of you, I presume, are gastroenterologists here, but I would like to emphasize that surgery is still not obsolete, especially in reference to chronic pancreatitis. And just briefly what we've been doing here, what are the relevant procedures which are still very much in vogue today, and how in the long term surgery can outspace endotherapy, especially in our setting in North India. And if time permits, Saket mentioned, I can show you a little bit of laparoscopic surgical work in chronic pancreatitis, which we've been doing for the last few years. Dr. Saket and Nitin were part of it. So I'll just quickly begin. I'm fine with that. Yeah. Okay, fine. So I can, yeah. So I'll just begin by what we actually mean by chronic pancreatitis in reference to surgery. What is the etiology of this briefly, diagnosis, and surgical treatment, what are the indications of surgery, methods of surgery, and what are the evidences in favor of one procedure, one surgical procedure over the other, and what are the evidences as compared to endotherapy, and finally, how do we manage complications surgically. Now, we all know chronic pancreatitis is recurrent, persistent abdominal pain, and it leads to exocrine and endocrine insufficiency. And pathologically, as you can see here, what is normal pancreas and what happens in chronic pancreatitis is loss of SNS cells, fibrosis, calcification, and global stricturing of the parenchymal ducts. I'll just skip this. We all know, we've been discussing this, what are the etiological aspects of chronic pancreatitis. And we all know how to diagnose chronic pancreatitis, pretty straightforward in terms of clinical presentation. We all know how it presents clinically: pain, back pain, exocrine, endocrine insufficiency, and it is really confirmed on cross-sectional imaging, CT, MRI, and not really ERCP to diagnose, but also to treat. You can see there's a gross dilatation of pancreatic duct with general atrophy of the gland, as well as generalized calcification in the duct as well as in the parenchyma. Now, we all know when do we need surgery. Of course, there has to be failure of medical treatment. We are all aware about the dependence of narcotics and failure of medical therapy, enzyme supplementation, and different analgesic methods. And then failure of endotherapy. These days, especially for early disease, we are doing sphincterotomy and PD stenting. We all saw in the morning. But when this doesn't work, we resort to surgery, which comprises of either decompressing the entire pancreatic parenchyma, resecting part of it, or combination of these procedures. Now, indications of surgery include intractable pain, which of course is opioid dependence and which hampers the actual day-to-day quality of life, local complications, which means primarily pseudocyst, and compression of adjacent numeral organs like bile duct and duodenum, and then of course bleed within the cyst or due to a pseudoaneurysm. And of course failed endotherapy management, which also, and then one of the most important indications of surgery is suspicion of malignancy, which is occultly common in chronic pancreatitis in the long term. Now, in terms of methods, I'm just rushing through it. We have resectional procedures, decompression procedures, combination of both, and modified hybrid procedures, that we'll say, which are really common now. Now, what is the rationale of surgery? We all know that intraductal and interstitial hypertension leads to pain in chronic pancreatitis, and this decompression, which is done by surgical methods, leads to relief of pain. One of the important things is that half of these patients have an enlarged pancreatic head, and pancreatic head, especially with ongoing inflammation is regarded to pacemaker of pain in chronic pancreatitis, which somehow is not addressed to by endotherapy procedures. And therefore, when you have a head mass and ongoing pain not responding to conservative measures, we can resort to resectional procedures, which is superior in the long term in management of pain and overall outcomes of chronic pancreatitis. Now, what is important these days is that we should do early surgery. Why? Because there's better pain relief, and this early surgeries or decompression of the pancreas results in delayed onset of pancreatic insufficiency. It slows down the ongoing inflammatory process, and therefore one should intervene before irreversible and permanent damage to pancreas occurs. And this can be done by various surgical procedures, and it really improves long-term outcomes more than 5 years. Now, this is the evidence, or recent evidence, systematic review, which clearly says that early surgery is associated with increased likelihood of complete post-operative pancreatic pain relief, and this is on average of 10 years, which very few endotherapical series claim. And therefore, early surgery is not only causes relief of pain, but it also reduces the risk of pancreatic insufficiency and low reintervention rates, fairly common in endotherapy procedures. And therefore, we should all convince our patients to go for early surgery in chronic pancreatitis. This is just a classification of primary procedures done surgically. Major resections involve Whipple's procedure and distal pancreatectomy, and nowadays for end-stage chronic pancreatitis you can do total pancreatectomy with auto islet cell transplantation, which has surprisingly very good long-term results, especially in the West. We have drainage procedures, primarily the Pusto's procedure, which is done nowadays, and then certain hybrid procedures which usually avoid the morbidity of classical Whipple's, which essentially a Beger's procedure, which are known as duodenal preserving head resections, and then combination of all these, primarily combination of head coring and drainage, which is popularly known as the Fraze procedure, and then different modifications like Isbeki's modification, Burns modification, depending on the extent and the site of stone burden as well as ductal dilatation. Whipple's, classical Whipple's procedure and pylorus preserving Whipple's procedure are the mainstay of surgical resectional procedures, and this is especially done when you have right-sided pancreatitis and suspicion of malignancy. However, the disadvantage, as I mentioned before, is loss of exocrine and endocrine functions in the long term for a benign disease. Morbidity is also high, and the mortality, of course, is roughly about 2 to 5% in high volume centers. But the advantage of these resectional procedures is long-term pain relief to the tune of about 85%. This is one of our patients of chronic pancreatitis. We've not done much resectional procedures for chronic pancreatitis, but we do have our own small series, and we also confirm that the long-term pain relief is fairly adequate. Left-sided pancreatectomy is not very common, just about 15% of patients, but this is less morbid than a formal pancreatectomy or a total pancreatectomy. And this can be performed now laparoscopically, and we can preserve the spleen as well. And this has the advantage that it leaves a significant portion of pancreatic parenchyma which is not resected, and therefore it has less morbidity. But then the complete pain relief is just to the tune of about 50% in the long term. So long-term pain relief might not be as good, but it is restricted to just about 5 to 15% of patients who have a distal limited disease. Total pancreatectomy is one of the last resort in terms of resectional procedures is concerned, and this has a very good rate of pain relief. But however, the disadvantage of this about 15 years back was development of brittle diabetes, which has now been offset by concomitant use of auto islet cell transplant, which, as you can see here, has been done in West, commonly in University of Pennsylvania, where it was first done. And this actually involves digestion of the pancreas, which can be harvested from the same patient, or it can also be added on to the preserved islet cells following a cadaveric retrieval, and then you can sort of isolate and purify these islet cells, which are injected into the portal vein and which get lodged in the hepatic sinusoids, and then they start producing insulin. And therefore, the long-term results of this are much better, and the brittle diabetes can be offset. So this, I mentioned before, was first done in University of Pennsylvania by Pritzley, and then you know that this is the last or the final, so to say, procedure for end-stage pancreatic disease. And this, of course, has its morbidity on its own, but then the dependence on insulin, as was done about 15 years back, is now not there. And in terms of pain relief, if you see, the results are really astonishing. 73% achieve narcotic independence to the tune of about 10 years. The longest follow-up following total pancreatectomy and auto-transplantation of islet cells about 14 years, and you can see still there is a 73% decrease in the incidence of pain, and the glycemic control is still about 27%, which is astonishing. In terms of decompression procedures, which is commonly done by us, the main indication when the ductal dilatation is about more than 7 millimeters, with or without inflammatory mass. These are all historical procedures which are obsolete now, because they didn't really decompress the whole of pancreatic ductal system, and then this gradually developed into lateral pancreatitis, described by Piosto and Rochelle. And then if you see, this has the advantage of preserving the endocrine and exocrine functions of the pancreas, because it doesn't resect any pancreatic parenchyma. However, if you see, the long-term results in terms of pain relief are just about 50% at 5 years, although it has low morbidity and is usually user-friendly, so-called easy to do, but still the long-term pain relief is lacking. Now coming to hybrid procedures, we are running out of time. The most important and the most commonly done, especially in Europe, is the Beger's procedure, which is duodenum preserving pancreatic head resection, described by Henry Beger. And this involves resecting the whole pancreatic head mass, just preserving a rim of the pancreatic tissue along the C loop of the duodenum, and then the entire pancreas, especially the head part, is resected. And the importance of this is that it not only maintains a lot of pancreatic parenchyma, it has a very good pain relief rate. Also, it decompresses the biliary and the duodenal compression, and even the vasculature if there is compression. Most important thing is it preserves the anteroduodenal axis, and there are not many hormonal disturbances. This is a diagrammatic representation of Beger's procedure. We can see the head being resected and a rule loop being used to drain the distal pancreas as well as the rim of the pancreatic tissue along the C loop of the duodenum. This is one of a few procedures which we did. Not many Beger's procedures are being done in our country, but then this is the first of our procedure. We can see a real-time picture of this, coring the head and draining the distal pancreas as well as the rim of the duodenum. Now, the problem with Beger's procedure is it has its own share of complications in terms of anastomotic disruptions, hemorrhage, abscesses, surgical site infections, and then even all general pulmonary complications are more, because the length of the procedure is a little more than the actual drainage procedures. Mortality is not very high, and as I mentioned before, the pain-free rate is to the tune of 90%, about 5.7 years. There is 20% diabetes, that is the offset point, that it has its own share of little inducing endocrine insufficiency. And there are different modifications of the Beger's procedure to basically decrease the morbidity and the endocrine insufficiency rate. First described by Bern in Switzerland, then Isbeki's modification, which is the German modification of the Bern's procedure, and the Japanese modification is the Imiyazumi procedure. Now, all of these procedures are sort of mixture of resection as well as drainage. Burn modification is a technical simplified beakers, which actually involves head coring and a single anastomosis. So you do not resect the head of the pancreas, and you just drain it into a rulum of the duodenum seen here diagrammatically. This is a burn modification of the Beaker's procedure. You can see not much of pancreatic parenchyma is again resected, and you can drain the cord head into the single rulum of the duodenum. Then the other, as I mentioned before, this has better overall morbidity. It has less endocrine insufficiency rate, but the overall pain relief is little inferior to the classical burns procedure. Isbecki's modification, known as the Hamburg's modification, described in Germany. This was actually more for patients who had small duct disease, where the ducts were not really dilated. So it involves a V-shaped, inverted V-shaped incision beginning from the C-loop of the duodenum to the pancreatic neck, and the aim is to expose the pancreatic duct, which is not done classically because it is not really dilated. And in this, again, the pain relief is to the tune of about 75%, and there are not really much change in the pancreatic exocrine and endocrine functions because the parenchyma of pancreas is preserved. Izazumi modification is a Japanese modification, I think quite similar to the Burns procedure, but here you open the bile duct and the coring is much deeper, and this releases so-called biliary stricture if it is present in chronic pancreatitis, which is a local complication, and then this again is drained into a loop. Now, commonly done procedure is the Fraze procedure. This is reserved for patients who have pancreatic head mass as well as a dilated pancreatic duct. Now, as you all know, more than 1/3 of patients have an inflammatory pancreatic head mass, and this could be one of the causes of pain in chronic pancreatitis, which is not addressed by endotherapy or other means, and therefore this involves coring of the head as well as drainage of the entire main pancreatic duct as well as duct of uncinate process as well. And one of the problems with failed LPG was that it failed to address the problem of inflammatory mass of the pancreas, and therefore the pain relief was not adequate. So you can see here, this is a predominantly pancreatic head disease with the dilated pancreatic duct in its entire length. The body and the tail of the pancreas, you can see the entire length of the pancreatic duct is dilated, as well as there is a solid inflammatory mass with a lot of calcification, and therefore this is ideally suited for a Fraze procedure. I'll not go into the details, instead I can just show you a small video which we have. If you can run this video of Fraze procedure. This is a 3-minute video. So we usually prefer midline to open up the abdomen, and then this is using the harmonic. We open the lesser sac to expose the entire surface of the pancreas, just to show you that what is the burden of the stone disease in this patient and how rarely surgery addresses this one time, unlike endotherapy where you would require multiple such procedures at different intervals over maybe a period of a year to get relief of the stone burden seen in this patient. Now here you can see the pancreatic surface being mobilized and being exposed from the C-loop of the duodenum to its tail. And that's the duodenal end, and then that's the pancreatic duct being identified. You can see being aspirated, and once you're sure about the pancreatic duct, then you open it somewhere in the mid or the distal part of the pancreas, and you can see how the duct is seen being opened at the distal end and one of the stones peeping out. So once you are sure that you are inside the duct, you exposed and transect the duct in its entirety, reaching right till the C-loop of the duodenum. And that's part of the pancreatic head being cored, and you can see both the ducts, infant feeding tubes in the uncinate duct as well as the main duct, and it is important to expose both the duct, and you can actually see the pancreatic juice coming out, and this is basically the roux loop being made, which is done by, of course, a stapler, and the jejunal end being closed over soon. And once the roux loop is ready, you can just take it and do a pancreatojejunostomy using continuous PDS sutures. You usually use 20 PDS sutures. So you can appreciate how the stone burden has been totally removed or taken care of in just one go. So this, I feel, is a procedure which is one time, long lasting, and quite suited for our patients, especially in our part of the country where not many people could actually come over and over again for endotherapy, which would actually require 4 to 5 such sessions. So this is, you can see the opening of the jejunum in its longitudinal length at the antimesenteric border of the jejunum, and the starting of the pancreatojejunal anastomosis. It is not necessary to have a mucosa to mucosa anastomosis because much of the mucosa is already denuded because of the fibrosis in the pancreas. And you can see, you can first do the posterior layer, and then the entire length of the pancreas is drained into almost 4 to 5 centimeters length of the jejunum. And you can see how nicely the entire pancreatic duct drains into the free loop of the jejunum, which in no way can be compared to endotherapy, especially the drainage part and the coring part. The core part is again anastomosed to the same opening in the jejunum, completing the procedure. I'll just go through. So the phrase procedure has not really a very high anastomotic leak rate, just about 2%, and very low mortality rates, and it's fairly standardized, especially in our setup. And if you see the pain relief also, this is one of the series from our own country, and we can see that the pain relief is quite sustained even at 10 years, and this is because the head coring has been incorporated in the drainage. Now, this is just, you can see 75% is the pain relief, and actually only just about 7% developed de novo diabetes. And if you do this early, then actually you can prevent endocrine insufficiency. Now, what is the evidence? Which procedure is better over the other? If you see a different comparison, there are different randomized trials comparing the Whipples versus bigger versus pylorus preserving. Not much difference. The essential point is that when you do resectional procedures, the exocrine and endocrine insufficiency weighs over the pain relief. But if you do a combination of minimal head coring with drainage, you have the advantages of pain relief as well as preserving the endocrine and exocrine function. Now, in terms of doing early surgery, this was the first paper which appeared in Annals of Surgery by William Nealon. This was a very heterogeneous population of patients, but this for the first time showed that if you do surgery in patients with chronic pancreatitis, you can actually preserve islet cell function and even reverse brittle diabetes or de novo diabetes, and you can also improve exocrine functions. Now, subsequently to that, there are two major studies by 𝗟𝗓𝗓 et al., which was first there in 2007, and then I think in 2011. If you see this, and this clearly shows that in patients with advanced chronic pancreatitis, those who underwent surgical procedures, combination of head coring as well as drainage, there were improved endocrine as well as exocrine functions, and further deterioration of these functions were prevented. So there is a role of early surgery, especially drainage and coring, in patients with chronic pancreatitis. Now, in terms of complications, just a few complications. If you see, the most common complication, local complication, is biliary obstruction, and there is a classification of that. I won't go into the details, but if you say stage 4 and 5 actually require surgical intervention, rest can be managed endoscopically, and generally the biliary decompression is addressed by the head coring part of a phrase procedure, and this takes care of the biliary drainage, and you don't really require a separate hepatojejunostomy in patients with chronic, or rarely require formal hepatojejunostomy in patients with biliary obstruction due to chronic pancreatitis. In terms of duodenal obstruction, there are two types of duodenal obstruction: those which occur acutely and those which are really chronic and they persist for 4 years. This subgroup sometimes does require duodenal decompression, which can be addressed in the same sitting during parenchymal drainage of the pancreatic duct. And portal hypertension is usually occult. There's another complication of patients with chronic pancreatitis. But the important thing is that presence of splenomesenteric occlusion is not an indication for surgery in these patients. Many of these patients have this as an occult part of chronic pancreatitis, and usually they would respond conservatively, or when you do just decompression of the pancreatic parenchyma, portal hypertension would reduce. And rarely it is when you have very extensive collaterals, you would basically stage a procedure and do endoscopy first, or you could do decompression of these collaterals and followed by pancreatic drainage. And in just about 1 to 2% of patients where you have an actual splenic vein thrombosis, this can actually be treated by distal pancreatectomy and splenectomy, and this is actually curative in these patients. And most importantly, rarely if you have patients who have bleeding, actual bleeding due to varices, they would undergo splenectomy first. So just to conclude, I know it's getting late and we have to wrap up. Surgery is preferred over endotherapy in patients where endotherapy might not be possible because of stone burden, or because of head mass, suspicion of malignancy, or local complications, which I mentioned earlier. Surgery effectively relieves pain in about 70 to 90% of patients. There were 2 randomized trials. I didn't go into details of that, but if you see what is long term, it's about 10 years plus, and there surgery clearly wins over endotherapy. Early surgery, of course, is getting invoked these days because it might reverse exocrine and endocrine functions, and therefore it's not just about pain relief, it is also about preserving the functions of pancreas, and this is only possible when you do early surgery. Endotherapy does decompress, but the decompression is inadequate, and therefore it might not really address to reversal of exocrine and endocrine functions in the long term. As you all saw, there are so many different types and combinations of surgical procedures. However, this must be individualized. And just to wrap up, if you have a head dominant disease with a mass, you can actually, and suspicion of malignancy, you should go ahead and do a Whipple's procedure. And if you have just a predominant mass and stone burden in the right side, duodenal preserving head resection should be done, which could be either a classical beaker or a different combination of beakers which I mentioned. But you have a dominant head mass together with a dilated pancreatic ductal system, then phrase is the preferred procedure these days, which can of course be done open and laparoscopically, even robotically these days, and I'll show a video of that later. And as a last resort, when nothing works, then these days, especially in the West, the treatment of choice is total pancreatectomy with autocell islet transplant. This has very good long-term results, which are now coming to our own knowledge. And this actually has not really been tried in India, but I think there was just one case report again from AIG, but we really don't know what the results are of total pancreatectomy and islet cell transplant in the Indian context. But definitely it has a definite role in the West. I think that's all from my side. Thank you.
Thank you, Dr. Abhijit Chandra. I think some of us must be raring to get into the debate of endotherapy versus surgery, which has been going on since morning. But there is a difficult situation. Dr. Sandeep has to leave at 4:15, and he has to perform a procedure which is endosono-assisted gastrojejunostomy. Yeah. So I'll request. Chandra and see if he has any other video to. I'll request Dr. Sanjeev Thakur and Vijay Shankar to come on the front seat and coordinate the what is being shown from the endoscopy room.
Now, I would just like to thank Dr. Chandra for
सर सबका डालना है वो पैमेथिकॉन डाल दो नहीं तो बना के रखा था
of a very large topic. I think we should go ahead with the
20 आप क्या रॉथ वास्केट है क्या उससे निकाल दे रॉथ नेट दे दो हाँ ठीक हाँ स्टिफ है बेटर नहीं तो छोड़ दो उससे भी हो जाएगा वी कैन मैनेज दैट ओके ओके सो यू कैन शो दैट अभी तो अंदर ही हो तो दिखा दो ये ठीक है चलता Hi, can you hear us?
Yes, sir.
Okay. So Pankaj is showing the tumor in the duodenum, which is causing a gastric outlet obstruction. And this patient is elderly. I am told he has some comorbidities and not very good case for a palliative surgery for GJ. And let's come back into the stomach. And so before we do endoscopic ultrasound guided gastrojejunostomy, we always clean up the stomach well so that there is no food residue. In most cases, we place a Ryle's tube up front 1 or 2 days before so that the stomach is completely clean. हाँ उसको रखना, वो इम्पोर्टेंट है वो. So this is a very floppy balloon. It is almost 2 meters long, and at the tip is it's like a Ryle's tube only, like a long nasoenteric tube. It has lead balls at the tip. It has, can you see these two black marks? Okay. Can you hear me now? Okay. So the tip is the green color tip, has 6 lead balls inside, and there are 2 black marks. Can you see that? Yes. One here and one there. Stop. Don't inject anymore. So these are the 2 marks of the balloon. So the balloon is here and the balloon is here. These are the mark at the proximal end of the balloon, radiopaque markers which will be visible. Between the 2 segments, once we are in right position, we will inflate this balloon, the forward balloon and the backward balloon. And in between there are many side holes which will be then filled up with saline, contrast and other coloring agent to distend that bowel loop. We will also give antiperistaltic agent at that time to paralyze the bowel. If I can show the proximal end of this tube, it has 4 tubes. So the 2 orange ones are for forward balloon and the backward balloon. This is to pass the guide wire, and this is to fill the water in that area. Clear? Yes. Okay, so now we will pass this balloon over the guide wire. Okay. This takes time, but it's worth the effort. The only reason we are using the over tube is this balloon is very floppy. And if I pass it without the over tube, it will buckle in the stomach and not go forward across the obstruction. आ गया बाहर हो चला sometime. So in spite of using a long wire, it has not crossed the proximal end. So I'll pull it back little bit. आ गया उच्चरा. Okay. but ज़्यादा नहीं. And I'll now fluoro please. So this will now go through the over tube, and the fluoro man can show me the fluoro please.
So would you like to pass a stick device before passing that, like a tension generator or something, just so we try? Here this is very floppy.
I didn't get you, sorry.
Would you like to pass a stick device like a tension generator before this floppy device to insert the part?
It's not necessary because we have the wire. It has to go over the wire. It has to cross the stricture, and the balloons have to be across the DJ flexure, which will be our target area. So the only reason where we cannot, in fact there's a new device which is coming up from the Canadian colleagues who have developed a modified version of it, which is a stiffer tube. Since that is a stiffer tube, then the over tube is not required, and that saves time. Fluoro please, fluoro, ready? बाबा दिखाइए, ये मेरे कंटिन्यूस दिखाइए, एक स्पॉट नहीं, थोड़ा कंटिन्यूस दिखाते रहिएगा. फ्लोरो प्लीज, फ्लोरो फ्लोरो फ्लोरो. नहीं दिख नहीं रहा मेरे को यार, एक बार इसोफेगस दिखाना जरा, वो ट्यूब आया होगा ना. नहीं वो दैट मेटल लॉड था ना, ब्लड बॉल्स इन द टिप. आई एम नॉट, कहाँ है वो, दिखाना जरा सा. आप नीचे से ऊपर एक बार दिखाइए पूरा. आई थिंक आई ऑलरेडी क्रॉस दैट. नीचे जाइए, आप बंद कर दे रहे हो उसको, मशीन को अपनी तरफ खींचिए जरा सा. यार थोड़ा सा कंट्रोल करना पड़ेगा आपको. यू अंडरस्टैंड व्हाट आई एम ट्राइंग टू. आई एम नॉट एबल टू सी दोस लेड बॉल्स बिकॉज आई हैव टू सी दैट लेड बॉल्स. कैन यू फोकस दैट ऑन द स्क्रीन नाउ? Just hunt for them, and it ऊपर पार्ट में होगा. It will be यहाँ पे होगा. नहीं, it has already gone. कहाँ गया? That's why a very good fluoro is paramount for this procedure. हाँ ये लेड बॉल्स दिखे ना अभी आपको, और नीचे की तरफ जाना. हाँ ये बस इसको देखते रहना, इसको सेंटर में ले आइए और इसी को देखते रहेंगे. अब कहाँ चला गया? हाँ बस ये नाउ इट इज क्रॉसिंग. इट इज बहुत ज़्यादा लंबा ऊपर नीचे नहीं घुमाइए आप इसको. नहीं नहीं, कहाँ चला गया? लेफ्ट को लेके जाओ, लेफ्ट को लेके जाओ, पेशेंट के लेफ्ट को लेके. हाँ यहाँ देखिए, इधर डीजे फ्लेक्चर के पास में पहुँच गए हम. नाउ आई एम पुशिंग इट फॉरवर्ड सो इट विल क्रॉस. स्पेशल नहीं, मत डालो, मत जेलिन मत डालना. वाई टाइट, वाई टाइट. हिला क्यों रहा है इतना यार वो? हाँ बस बस यहीं रखना, इसको रखना आपको यहाँ पे. फ्लोरो फ्लोरो बीच बीच में फ्लोरो दिखाते रहना, बंद नहीं करना. हाँ. So now it is going forward, forward. The first radiopaque marker is coming. You can see that. And अब ऊपर ठीक है, ठीक है, ऊपर यहाँ पे सेकंड मार्कर आ जाएगा हमारा. कहाँ है? This is first. आपके अपनी तरफ लेके जाइए ज़रा, अपनी तरफ लेके जाइए अपनी. हाँ इधर बस ठीक ठीक है, यहाँ रख लेंगे. I did not see the radio second radiopaque marker. I think ఇది ఓకేనా? బాగుంది. ఇంకా टाइट करो. वाई टाइट, वाई कहाँ लेके, ये कहाँ चला गया? फ्लोरो 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 फ्लोरो. ये फर्स्ट मार्कर है, सेकंड मार्कर ये ऊपर ही है शायद. हाँ हो रहा, ओके आई कैन सी दैट. ओके परफेक्ट परफेक्ट परफेक्ट. छोड़ दीजिए, स्टॉप स्टॉप स्टॉप. सो नाउ आई फील I'm sure you must have not observed where the two markers are, but I believe the top of the arch is a DJ flexure, and the two marks, one is on the left, it is over the spine, which is the proximal marker, and the one on the right will be the forward marker. So now we will inflate both the balloons with the contrast and saline. So we need two people to inflate. हाँ डालिए. हाँ बाबा जी आ गए आप. तो अब हम पहले फॉरवर्ड बलून करते हैं. स्क्रीन प्लीज. स्क्रीन. हाँ ओके. सो यू सी दैट कॉन्ट्रास्ट, दैट्स अ फॉरवर्ड बलून. पहले एक एक करेंगे पहले. इंत అయిపోయింది 10 डाला. इसमें 30 cc डालना हमको. फ्लोरो एक एक करके करना है. हाँ ओके ओके गुड, दैट्स अ गुड पोजीशन, वेरी गुड गुड. कंट्रास्ट एंड सलाइन है इसमें. So it almost becomes like a cylinder there. 30 हो गया. Okay. Stop. Screen. हाँ that's a good position. So now this is anchored well. अब दूसरे में डाल रहे हैं. तो अब पहले उसको हम पोजीशन में ले लेते हैं. अब दूसरा दिखाएंगे. ऊपर कहाँ है? हाँ ये रहा. इन्फ्लेट इन्फ्लेट. हाँ इनके इंजेक्ट इंजेक्ट. स्क्रीन स्क्रीन स्क्रीन. हाँ ये देखो. सो हाँ डाले डाले डाले, नो प्रॉब्लम. ओके स्टॉप. आप डालते रहो. हाँ कितना हो गया? 10 cc 10 cc. So if the whole team is very efficient, then the procedure can finish in 30 minutes. But the challenges are always there, we understand that, and I'm not worried about it. We will take our time and go cautiously each step wise. कितना हो गया? 30 हो गया complete. Okay, that's a nice position. पूरा डाल दो. Okay, so now we have both the balloons inflated. I would have preferred to see both the balloons in one frame, but because of some regions I'm not seeing both. But anyway, now we will fill the intervening area with saline and contrast. पहले contrast डालिए. उसका कैप होगा श्रीनिवास, देखना ये वो बाद में लगा देना, लीक नहीं होना. हाँ बंद कर दिया ना, ठीक है. Screen screen. Oh sorry, other way around, other way around. So you will now see the two balloons and the contrast getting filled up in between. Can you see that? Some contrast. नहीं हिलाइए नहीं, बस यही सही, भाई यही रही है. हाँ, there's some contrast there, little more contrast to be put. हाँ perfect. Okay, so that's a target area now, target organ between the two things. We can now inject Buscopan. कितना डाल दिया? हाँ डालना. And endoscope ready, endosonoscope ready, endosonoscope ready. लगाइए. Just perfect. That's what I wanted to show. We don't have to fill entire thing with contrast. And also there's a coloring agent, indigo carmine also. The purpose of indigo carmine is that when we place the GJ, indigo carmine will come into the stomach. So that color visualization on endoscopy view will tell us that we are in the right position.
Can you please adjust your mic again, sir?
I'm sorry, adjust my mic, okay. Can you hear me now? It's better? Hello, can you hear? Is it better? Or now?
Yeah.
Okay, okay. So now we have placed two balloons which are inflated nicely around the DJ flexure area, and we are fitting in the EUS scope. Kitna dal diya? 50 only. So the amount of fluid that we normally use between the two balloons is about 100 or 120 cc. So he's already placed 50. Fluoro please आप देख सकते हैं हमको. Fluoro दिखा दीजिए एक बार. हाँ okay बढ़िया. Stop చేయండి ఇప్పుడు. చెప్తా.
So, query is there, what's the diameter of the balloon? How much we
हाँ.
need to inflate it?
So the balloon has a caliber of volume acceptance of 30 to 40 cc. So in a thin built patient we inflate to 30, we can go to 35 and 40. The idea is that the fluid should hold in between, it should not go forward. Now what I am doing is I am taking out the over tube. The over tube job is over, but since it is such a big thing, it will not come out completely. It will hang on this E-pass balloon or double balloon. So that's okay. So now it's hanging. Because bahar nahi niklega, because the other end has 4 channels, so it will hang in between, but that's okay. So now I will take my EUS scope beside the double balloon catheter. Okay, if the cameraman can focus here once. You see the mouth and light on. So I will go beside. थोड़ा jelly लगा दीजिएगा. Buscopan has been given. Thank you. So now I am passing the EU endoscope inside. Go in the stomach. Get the endosono view in view. Unfreeze. And now we see the structures now. So this is the pancreas. We are seeing the PD. And I will turn around and try to see. This is a balloon.
Yes.
Arrow is here. So this is one of the areas. But I want to see that long limb which is distended. I will start hunting for it. I use sometimes, this is the PD which is dilated, so double duct sign type thing is there. Fluoro दिखाएंगे एक बार. Okay. So now with fluoro I will use to, I will, air नहीं on इसका, air on करिए, CO2 on करिए. Screen fluoro please, fluoro. Fluoro दिखा दीजिए. So I am looking at the tip of my endoscope and rotating. I am not going the other side. Fluoro please. ठीक है. This is a better angle. Screen fluoro. So now you see that I have come to the loop which is there. There's a balloon. Screen. Fluoro please. No, I'm far away. Okay, Shinu, कितना डाला है? Put 100. Yeah, I want this. That's what I'm doing now. So I'll 100, 30-40 more. This is a very good loop I am having. Scope tip और बड़ा कर दिया क्या? नहीं बड़ा नहीं. Endoscope tip दिखाइए मुझे. उसमें तुम थोड़ा उसमें हेल्प करो जरा सा. आई एम फोकसिंग हियर, सो आप थोड़ा हेल्प कर दीजिएगा. हाँ. So you can see the turbulence on the EUS image on the screen. So that's getting filled up, but I don't.
We have to prevent leakage from both sides.
Both sides. So this is a balloon there. ये balloon है. Stop, Shinu. So this is a balloon, and this is a segment which is getting filled up above. I will see which is the closest to my endoscope. I'm not getting a. कितना डाल दिया? 100 है. पीछे बंद है ना, लीक तो नहीं हो रहा? एक ड्रॉप भी नहीं है. एक बार फिर से स्कोप दिखाएंगे मुझे. स्कोप टिप. एंडोस्कोप बहुत दूर चले. हाँ ओके बहुत दूर चला गया मैं. So I have to be somewhere there and और दिखाना जरा सा. No, not good. It has to be. These are very crucial parts of the whole scheme of things. और डालो शाना. आगे लीक तो नहीं हो रहा है कहीं? It is not distending as well. नहीं लीक मतलब ये पानी लीक तो नहीं और आगे जा रहा है. So this is a jejunal loop which I will be targeting somewhere, but there is a lot of momentum in between. I don't want that. I want it to be very close to the stomach. That perfect position is important, and that's why sometimes fluoro and endoscope all help. 120 stops now. Never. This is balloon. This is even. अभी दिखाना है scope tip जरा. Scope tip please. Scope tip. This is looking better position wise. Yes. Much better. This is a balloon and that's the. This is a much better position. And now I would like a better scope position और center में कर लें उसको. और डालो जरा पानी. कितना डाल दे शीनू? 120 डाल दिया ना. अब स्टेंट दे दिए. स्टेंट रेडी कर लीजिए. I don't want to puncture the balloon, but I want to puncture little away so that और अच्छा चाहिए. I am very greedy. I want it to go perfectly. It should not go wrong anything. अच्छा ठीक है. Stop now. Stop. और मत डालिए. Still better. Can be better more. ये ट्यूब है. I'm not seeing the tube inside. The tube is here. A tube आया इधर गया. Okay. This is और better है. This is better. थोड़ा और डालो पानी. Stent ready है? Because at that perfect position I will not speak. I'll just do the procedure and then we can speak later. The perfect position now, sir. Nearly perfect. I am still wanting it better now. There is a vessel there. Cautery setting है? हाँ. क्या हो गया? Fluoro. Once again. Yeah. थोड़ा और डालिए पानी. और डालिए. This loop will get distended more. I want that too. This is a better position. That's okay. Small vessel, but that's okay. लगा दो मेरे को कॉटरी देना. कितना डाल दिया पानी? और 170 हो गया. ऑल टाइम हाई है. जनरली 100-120 में हो जाता है. चलो बढ़िया. ओके रेडी. क्या दिख रहा है? विलाई भी दिख गया. सही बोले. हाँ फोल्ड है. जजनल फोल्ड है वो. So let me get the stent out. The tip comes here. Space is little less, but that's okay. Still I can. और डाल दीजिए पानी, थोड़ा सा और डालिए, अभी 10-20 cc और डाल दीजिए। बट बीच में जेजनल वो नहीं दिख रहा, ट्यूब नहीं दिख रहा हमको, ओनली ट्यूब दिखता है, मूवमेंट ऑफ फ्लूइड दिखता है ना, दैट पार्ट इज नॉट सीन। नहीं रुको जरा, रुको, ये गलत लूप तो नहीं है, दिस इज नहीं बट बिकॉज whenever we put fluid na, the fluid swells and that is seen on EUS. I don't want to just puncture without seeing that tube inside. This may be the far end of the balloon and a loop which is just distal to that. Extreme caution is the way to go. Because normally ना we'll see the tube inside. इस part में tube होना चाहिए, यहाँ tube नहीं दिख रहा हमको, tube दिखा? नहीं दिख रहा ना, यहाँ tube नहीं है, although it is distended but the tube is not there. But this also can be done, this is like a free hand now, but whole exercise is then different. But this is very close to it. Okay, this is very good position, let's go in. Okay, I'm inside. So cautery off, but I'm not very deep in. So this is important. I have to be थोड़ा सा readjust कर सकते हैं. I can my position. I can go in little bit more. No. Okay. So I have locked, removed the safety mechanism and deploy the stent inner flange, which is looks okay. Yes. Satisfied? It is opened up, the inner flange is opened up. Yes. It looks nice. You can take a picture here and can pull back little bit more, I think. Oh, okay. This is okay. Now I will deploy the proximal flange in the channel of the scope. I have done that. And then I will go to endoscopy view and deploy the stent. So the blue color is seen. So that's important.
Very nice.
So whenever we see blue color, that means we are in a good position, accurate position. And then I will suck out all the fluid. There's echo here. Echo kyun ho raha? So I'll suck out all the fluid which will come out from the jejunal limb. Decompress. And we can also sometimes see the far end of the jejunum through this small opening of the stent. And this stent will expand to its maximum diameter of 20 mm over next 5 to 7 days. You can see the jejunum loop. Yeah. Okay, the fold is seen. You can see it's not peritoneum. I'm not dilating it. This is not peritoneum. This is jejunum. And we can also inject some contrast through this to be 100% sure that we are in the jejunum. So now deflate the balloon. एंड एक कैनला रखना, उसमें कॉन्ट्रास्ट एंड में डालेंगे बाद में. So are the surgeons agreeing to that? क्यों? We work as a team. Now you see that fold also there. Huh? यार लड़ाई थोड़ी ना हमारी कोई. आप ही लोग कई बार ऑपरेट नहीं करते, हाई रिस्क पेशेंट हम नहीं करेंगे ऑपरेट, तो फिर हम आपकी मदद करते हैं ना कि एसाइटिस है नहीं करेंगे. कभी कभी हम एसाइटिस में भी करते हैं. हो गया पूरा खाली. fluoro please. Our balloon, we will see the balloons now that have completely deflated, and then we will pull it out. So, हाँ नहीं तो वो खराब हो जाएगा. It will hit the stent on the way and can rupture. We being Indians, we always use this equipment as many times as possible. नहीं? It can, correct. That also can happen sometimes, that the stent can get.
So after how much time we can start liquid?
So he can start his oral liquids today itself by 4 to 6 hours later, but provided there's no pain and no discomfort. And tomorrow we can start some low residue diet, like puree, soup, those kind of things. And we will avoid fiber foods. And by day after tomorrow, you can start khichdi, dalia type things also.
So solid food should be avoided.
Like he can take solid in later on once the stent is fully expanded at 20 millimeter, which will happen by 5 to 7 days. Then he can start his solid food, but he has to chew well. If this gets obstructed by a pea or a matar dana, chana dana, then that will cause blocked. So bada chana ka dana baad mein block kar sakta hai. So isliye we will avoid those things. Now we can very nicely see the jejunal loops. It is so good that we can actually take your पच का balloon. दिखाइए balloon दूसरा दिखा दीजिए. एक ही दिखाया आपने. नीचे वाला दिखाइए. नीचे नीचे नीचे. हाँ नीचे वाला पिचक गया. और थोड़ा और पिचकना है अभी इसको. हाँ ये वाला है पिचक रहा है. थोड़ा और निकलेगा इसमें से. That we can actually do ERCP if required. Go through this GJ using either duodenoscope or a forward wing endoscope to the afferent side and cannulate the papilla. Okay, nikal gaya? So we'll pull it out now. Fluoro. It's a lamps only. The same lamps that we use in the morning for walled-off necrosis. The last thing I will do is just put some contrast for the final confirmation for everybody to accept that this is okay. So these are a very gratifying procedures if everything goes fine. One mistake, we can actually. See, do you want contrast or we leave it like that? CO2 नहीं आ रहा. CO2 नहीं आ रहा है. अब आया. मैंने एयर ऑन कर दिया है. CO2 है. चल रहा था. अच्छा. So the question that is often asked is which part of the stomach you will drain. It's very difficult to decide. So we select the point which is closest to the jejunum of the target organ that we have kind of identified and blocked. कुछ नहीं आ रहा. नहीं एयर नहीं आ रहा. CO2 नहीं आ रहा इसमें. I think we can leave it off. There's no point in putting contrast. Thank you. Next case, yeah.
So should we check the stent after 1 to 2 days?
We can. In fact, tomorrow you can do an oral contrast study and see how the contrast is draining. That will be the confirmation of everything. Yeah, so oral contrast can be given once he is fully awake tomorrow morning before we start some semi-solid or a thick soup. But today, once the stomach is soft and clear and there's no pain, then we can start oral liquids from today itself. So that's a very good question, Ashish. That there's a debate of enteral stent versus GJ. Enteral stent is very easy. The guide wire has gone. We can easily place the enteral duodenal stent. But the problem with duodenal stent is goes through the tumor. And if we use an uncovered stent, the tumor can grow inside the mesh and can block it again, as we commonly see. Whereas if we use a fully covered stent, there's a risk of distal migration. And then there are two problems. One, the original problem comes back, and second is to remove this migrated stent which is now stuck in the small intestine. You understand? Yes, so he has a biliary obstruction but not causing symptoms, so we are not addressing that issue. But if suppose he had a obstructive jaundice causing symptoms, so both the procedures can be done at the same session, where we do a GJ followed by a choledochoduodenostomy or a hepatogastrostomy kind of thing. Okay, so we'll switch him and get the next patient in quickly. ठीक है, ये करते हैं, उसे करते हैं. Mic off.
patient with acute pancreatitis. He underwent
Post-traumatic
laparotomy and,
pseudocyst,
repairing was done. He had mild pain,
Acha,
abdomen
isko.
persistently present since then. MRCP suggestive of fault of necrosis with 13 to 15 to 33 mm with extension to lesser sac.
Quarter setting
Upper GI
change kar
endoscopy
diya
was
na?
normal, and US which was currently done.
Arre?
It was suggestive of large wall of necrosis with dilated empty
Sai mein
and
thikon
with
honda?
intraductal stones. So he has been planned for gastrostomy using a hot access stent. Thank you.
एक बार मुझे हिस्ट्री बताएंगे जरा क्या था इसका?
Chronic pancreatitis with intraductal stone and maybe
Same patient from your center, sir.
Mhm.
He had road traffic accident in 15, and then in 2017 he had duodenal perforation with acute pancreatitis. Since then he is having.
Okay, okay, okay.
And now there is a word of necrosis.
हाँ हाँ. ठीक. Okay. So he had a duodenal perforation in the past, huh? Okay. Huh. So I am in the duodenum now. So for those who are just starting the EUS, this is a very good position to start seeing things. So let me tell the anatomy. This is the pancreatic head, the portal vein, the splenic vein behind, and the lower part is the SMV. This is the gastroduodenal artery, and I want to look at the CBD too, which should be somewhere be here. That's a CBD here. This, can you move? This is CBD. L. Okay. So agreed? So just to get a, so the parenchyma is slightly altered ecotexture, not too bad. And I'll now come back into the stomach. This is the right lobe of the liver, segment 6, which is from the duodenum side. I'm pulling back. Now you see the CBD nicely there. This is CBD. CBD here. Okay. And come back. Dhila chhod dijiye. That's a gallbladder which just went by. It's normal gallbladder. And then I start behind. This is the pancreatic genu area, portal vein ke paas mein, which is quite okay. This is the pancreatic duct, thin pancreatic duct here. I'll park it again. And so pancreatic parenchyma has thick hyperechoic strands, but no calcification and no dilated duct in this part. As I pull back, now I start seeing some other vessels. So this is the splenic vein, and behind are the other two superior mesenteric artery and vein. Sorry, this is the superior mesenteric. This is a superior mesenteric vein and artery. I pull back, and now I start seeing the collection. You see that collection here? Quite a thick-walled collection, but not very big. So this is, if I can measure it here, 4 centimeters. By about 28 mm. Okay, so let's move around. It has some debris inside. This is the lower part is debris only. The wall is little thicker only. Let me get some Doppler signals there. So that's artifacts inside the collection. I'm more interested in the wall. Is there any vessel on the wall? But this is the thickest of all the collection that we have drained today. If I can measure it here, this is 4.7, but the size is small, so it should be okay. Okay, Srinu, ready? So we'll have standard steps: 19 gauge needle, puncture, guide wire, cystotome, dilate with a 6 mm balloon because not too big, and then we place a single plastic stent straight. So can we have the fluoroscopy ready at the scope tip? And this has very ecogenic fluid, so I expect little turbid fluid to come out. I'm using a Boston Scientific 19 gauge needle. Let me make it bigger. Fluoro ready? Okay. So here comes the needle now on the right, just next to the blue dot. I'm sorry? Sorry, I'm not able to make out. Since it is a small pseudocyst, some small collection, it's निकाल. So the stellate was not removed, that's why it's not puncturing. Okay, now it's gone in. So stellate has to be removed. I pulled back a little bit, which I missed out. So we'll aspirate only 1 or 2 cc, not much. So it's little brownish fluid. That's all. Stop. Here the aim is to fever to nahi na inko? Just pain. So just amylase may be okay. Although if you had more fluid, I would send for culture, but don't want to decompress it totally. If it becomes too small, then okay. Flora? Tip ready? ये कुछ different type का दिख रहा है Flora.
Sir, the question is why don't you aspirate it once and leave it?
It will form again.
Yes, exactly. Recurrence rate will be very high.
So whenever all the collections, pancreatic fluid collections should be drained and not aspirated, unless.
It is not communicating with pancreatic duct.
I'm not sure. It may be. It's a history of trauma is there, so there must be some kind of a fracture, and upstream duct would be communicating with it. So ऊपर दिखाइए जरा सा. ये थोड़ा सा setting different है इसका. Anyway, ठीक है. छोड़ो. निकाले?
In the history we got that there are multiple intraductal pancreatic stones.
No, there was no stone. Flora. ये कुछ फ्लोरा डिफरेंट लग रहा है ना. आपने कुछ सेटिंग चेंज किया क्या? हाँ बाबा जी, क्या विड्रॉ कर दिया? हाँ थोड़ा काला मत, वाइट कर दीजिए ना, हमको भी दिखेगा फिर अच्छा. काला और ब्लैक सेम ही होता है हमारे यहाँ तो. आपके यहाँ? हाँ ब्राइटनेस. सॉरी मैंने सुना नहीं ठीक से. आई एम सॉरी. We can actually place 2 stents. It is got turbidity inside. You know, क्या दे रहा है बलून? 10 mm बलून दीजिएगा. 2 वायर डालेंगे, 2 स्टेंट डालेंगे. So this is not a very clear. In a pseudocyst, it will be not this turbid fluid. So I will actually place 2 stents. Although space is less, but my main aim will be to place 2 stents. You agree? Flora, please. I'm lost that wire. Not seeing that wire. सुनो वायर थोड़ा टाइट करो. स्क्रीन. आ तो गया. मेरा सिस्टोटोम आ गया. वायर नहीं दिख रहा है. वायर क्यों नहीं दिख रहा है? थोड़ा पुल करिए वायर. कॉइल्ड है नहीं, पर मेरे को वायर दिखना है मुझे एंडोसोनो व्यू पे. उसके बिना मैं नहीं करेंगे. दैट मेक्स इट वेरी सेफ. हाँ ये आया हुआ है. Now you see that? Okay, so it is in one corner. Ready? All set? Pad? थोड़ा आगे कर दे मेरा पंकज, थोड़ा सा. हाँ, thank you. Setting ठीक है? Not वो तो नहीं है, ऑटो कट मोड पर बने हैं. हाँ, now it's very nice. Although wire has coiled back and come to the same position, but that's okay. Okay, it's gone in. So 2 bars it's in. Now we exchange. Balloon, I need bigger balloon. 10 mm pusher tube, 2 stents, small stents, 7374. फ्लोरो में वायर दिख रहा है अंदर. वापस सेंटर में कर लीजिए उसको, स्पाइन से हटा के ना उसको थोड़ा सा ऐसा कर सकते हैं. हाँ, एकदम बंद कर देते हैं आप मशीन को. थोड़ा सा रेडिएशन लग लेने दीजिए, पर मरीज को तकलीफ नहीं होनी चाहिए. So initial my aim was to place only 1 stent, but I changed my strategy to 2 because this fluid is thick and there is some debris inside. 1 stent se block ho sakta hai, and then again we come back to the same problem. So 2 is better than 1. 10 mm balloon. Again I want the wire back in my frame. Okay, here it is. ढीला छोड़ दीजिए, इसको पकड़ना, टाइट नहीं पकड़ेगा. Here the wire, here comes as balloon. गया अंदर? नहीं गया. टाइट वायर टाइट. नहीं बकल हो रहा है. आप बैठिए, मेरे को दिख नहीं रहा, थोड़ा ऊपर का. नहीं एंडोस्कोप 1 मिनट में फ्लोरो में दिखता ना, फील होता है मेरे को. फीलिंग इज इम्पॉर्टेंट समटाइम्स. हाँ, ओके अच्छा. ओ ఏముందా వేరే బలూన్ ఉందా? అది పట్టుకోండి. టైట్ here it comes. नहीं बकलिंग. नया बलून चाहिए इसके लिए यार, थोड़ा सा ये बहुत थिक है. हर केस में कभी कभी नया चाहिए होता है. ये बहुत थिक वॉल है. चलो ठीक है, ऐसे देखते हैं विंडोज. बट आई वुड प्रेफर टू पास द बलून ऑन द EUS view, not an endoscopy view, especially if it's a thick wall. It's not going in. हाँ नहीं, we can. Then we have to use an alternate options. We have to keep improvising each step, but that's सिस्टोटम दे दो. नहीं वो दे दो मेरे को. छोटा बलून है, 4 mm है. टाइट. छोटा चाहिए. हाँ 10-12 दे दो, छोटा बलून. I'll use a new balloon. The reason is that this is a very thick wall. If it was a thin wall, things would have been easy. Here it will not go. And I don't want to now lose the access. So now having switched to endoscopy view, I'll stay at endoscopy view. आप मुझे 4 mm दे दो, 5 mm, 6 mm कुछ भी दे दो, नया देना लेकिन. Then it will go easily. Otherwise, next option is, as we discussed, is to use a bougie or 10 French cystotome, those kind of things. Burn your way in with a bigger caliber device. Sometimes we used to get needle that's a very dangerous device in this situation, because sometimes the needle has to be just a millimeter or half a millimeter out of the tip of the sheath. If it is 1 centimeter or half centimeter, then it can go in a different direction and can cause a perforation or bleed or those things. So I'll just wait. There's no hurry. It's always better to have the best device which is most likely to succeed. क्या है? अच्छा, तो but टाइटन है कोई? स्टोर लॉक है. एक काम और कर सकते हैं, देन वो डायलेटर है, बूजी है. वी हैव बिलियरी डायलेटर्स, वो दे दो मेरे को. 7 या 10 mm अगर 10 फ्रेंच बिलियरी डायलेटर होगा ना. सोहिंद्रा बिलियरी डायलेटर है आपके पास?
10 फ्रेंच है ना.
The purpose is to allow the stent, so the balloon to go in, the collapsed balloon to go across. Here it is buckling, and then even the stent won't go in. A straight stent can go, but straight is a straight stent and can migrate inside. So due precautions have to be taken. I think that brings us to the point of the selection of device and keep things ready before we start a procedure. That's very, very crucial. To have a successful outcome, you have to mentally rehearse. Not only rehearse yourself, but rehearse with your colleague in the room, with the technician and the staff in the room, that what we're trying to do, and be ready for all the steps. Sometimes I may miss, but he would remind, like he reminded at the beginning, did you do an endoscopy for GJ patients? So then I had to request Pankaj to do that, and we found that some lot of significant amount of fluid was there. EDM? So we're using a 10 French biliary dilator, which is quite a good device to have also. It's tapered, so it should create some space in the fistula to allow the balloon to then go in. And let me get back so as you must have observed that I'm always coming back to my EUS image. I'm most comfortable with that, and get the wire in the view. So my best way to find out somebody is expert in EUS is how he is seeing the wire on the EUS image. If he is seeing the wire nicely, he is good. Wire andar hai. Push, tight karo wire. Nahi ja raha. No, it's not buckling again. Let me come closer. No. क्या है? जस्ट टिप क्रॉस हो गया? नहीं. क्या है? नहीं, बकल हो रहा है. It's just there but not going. वायर कहाँ है? वायर बाहर आ गया? वायर निकल गया. वायर निकल गया. स्क्रीन फ्लोरो? हाँ, वायर बाहर आ गया. So we lost the wire, so we have to start all over again. You saw that? So these are the things which happen when we go long. Some leakage of the fluid outside, but that's okay. Let's start all over again, and this time చిన్న బలూన్ లేదా మీ దగ్గర కూడా లేవు? हाँ, यूएस नीडल वो वापस दे दीजिए मेरे को. 19 गेज हमने यूज़ किया था ना, वो 19 गेज नीडल वायर सिस्टोटोम अभी यूज़ किया था ना. Antibiotics is going on. We have risk of infection. In fact, all of them should have antibiotics. ठीक है? Okay, Sinu? मोटा वायर डाल दो ना, मोटा वायर डाल दो। नहीं आया, वो 3.5 नहीं जाता। फ्लोरो प्लीज, फ्लोरो 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 फ्लोरो। अच्छा कॉइल कर दो, अच्छा कॉइल करो, 2-3 बार कॉइल करो। Should not slip out now. We need a long, many loops there. Floro, 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 floro. Continue, continue, floro, floro. जा रहा है, इजी जा रहा है। अच्छा ठीक है, निकालें।
स्क्रीन स्क्रीन फ्लोर मेन चाहिए मेरे को।
हाँ कंजूसी कर रहे हो आप फ्लोरो में। ठीक है, चलो ठीक है, ठीक है, ओके। वायर अंदर लोपल होता, वायर है, सही है।
डार्क, बहुत डार्क है, थोड़ा लाइट कर।
अभी तुम कंफ्यूज नहीं करो उनको। सो सिस्टोटोम, इसके बाद क्या देते हैं फिर? बलून क्या है?
सीआरई देंगे सर, उसको
कौन
सेफ में
कर दिया? ठीक, कैसे कैसे? एक ही है सीआरई आपके पास? एक। हाँ 10-12 वाला कहाँ है? ये है। और 12-15 कहाँ है? दोनों यूज़ हो गया। ओके चलो ठीक है, ठीक है, कोई बात नहीं। तो एक्सियोस का वो है, हॉट एक्सियोस का बूजी, उसको यूज़ करेंगे ना 10 फ्रेंच की तरह। फेंक दिए, वो ले लो ना, हॉट एक्सियोस का जो डिवाइस है ना। सो वी आर इम्प्रोवाइजिंग बाय वन मोर थिंग, एंड आई एम श्योर यू मस्ट हैव ओवरहर्ड मी दैट वी यूज द हॉट एक्सियोस device. The assembly itself after the stent has been deployed is 10 French and can be used to create a little bigger hole. Agree? थक गया सब हो जाता है। स्क्रीन चला गया अंदर? फ्लोर टाइट, फ्लोर आया ना? लेता नहीं आया, नहीं आया, नहीं आया, अभी नहीं आया। हाँ ओके, नाउ बेटर। टाइट नहीं नहीं रुक, आया आया आया, नहीं आया। अच्छा रहा, फ्लोरो में दिख रहा है, नहीं आया। फ्लोरो 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 नहीं आया। ये क्या बकल हो रहा है, बकल हो रहा है। वायर टाइट, वायर नहीं 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 नहीं, वायर टाइट करो, वायर टाइट करो, वायर टाइट करो। ये क्यों नहीं जा रहा? अब आया, अब आया। अब वायर सीधा करेंगे, वायर थोड़ा पुल करो, वायर पुल करो। हाँ अब सही है, अब आया सही। So this angle is better. गया अंदर? फ्लोरो फ्लोर अंदर गया क्या? सिस्टोटम नहीं दिख रहा मेरे को। गया है? मेरे को दिख नहीं रहा सिस्टोटम। एक्सरे में दिख गया आपको? मेरे को दिखाई नहीं किधर गया। इट लग रहा है चला गया, लेकिन आई एम नॉट फीलिंग इट। मैं भी चला गया होगा शायद। हाँ चलो ठीक है, आई विल स्विच टू एंडोस्कोपी व्यू एंड सी। नहीं आया ना? अभी टाइट करो, अभी नहीं आया है। टाइट 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 टाइट, लेट्स गो बाय दिस व्यू ओनली। अब आया. Okay, so let me get the endosono view back and endoscono small, and now we try to. Okay. सबसे छोटा सिस्ट ज़्यादा तंग करता है. ओके, गया गया अंदर है ना. हाँ, ओके. एक दो बार और कर देते हैं इसको ज़रा सा. विल कीप डूइंग इट. डॉक्टर मनु टंडन टेक्निक है, वो यही करते हैं ना, तो उनसे सीखा है कि जब ऐसा होता है सिचुएशन तो कई बार जस्ट कीप मूविंग इन एंड आउट, विल क्रिएट लिटिल बिगर होल देन व्हाट इट वाज मेंट. फ्लोरा सर, अभी मेरे को 10 फ्रेंच वो देना, वो सिस्टोटोमर 10 हॉट एक्सिस का जो डिवाइस है ना वो देना. ओके. इसको ना पूरा बंद कर देना, पीछे पीछे तक ले लो आप. नहीं ऐसा आएगा ना. लोपल पोतुंदा. वाह. क्या है? अच्छा, एक बार देख लेते हैं अगर हो जाता तो. So what we are trying to do is just get the assembly. Can you see the cameraman can focus that this is a assembly device of the hot axios, and with Abhijit is trying to just pull back this wire inside the sheath. It becomes almost like the original one without the stent only. So these are the improvisation which Indians are expert at. हाँ, आ गया, देखा. So you saw that? It's gone in. Thank you, Abhijit. He is master. He knows his baby. शैतान बच्चे को कैसे ठीक करते हैं. So we'll have the cystotome ready, and so we'll now burn with a 10 French cystotome over the wire. You got it? Yes, so this will allow the balloon to then go in, and then we can do. नहीं चला जाएगा, चला जाएगा. Yeah. So this will be the last case. I'm just. Thanks for reminding. Cat, what's the time? Okay, sir. बहुत टाइट है. नहीं पूरा नहीं खींचना. हाँ बस इतना ठीक है. वायर दिख रहा है? वायर. हाँ अंदर है स्क्रीन. हाँ ओके. अब की गड़बड़ नहीं होना चाहिए. हमारा दिख नहीं रहा है. कहाँ है वायर? कहाँ है? बाहर निकल आया. अरे खींच दे क्या वायर? नहीं वायर अंदर नहीं है. वायर बाहर आ गया. आई एम नॉट सीइंग द वायर. ये स्टमक में आ गया वायर. स्टमक में वायर. फ्लो एंडोस्कोपी देखते हैं. स्टमक में आ गया ना. दूर है. अच्छा दूर कहाँ है? ये देखो पुल हो गया वायर. देख रहे ना स्टमक ल्यूमन में आ गया ना. पूरा बाहर आ गया ना. ओके कोई बात नहीं. अभी ऐसा लास्ट स्टेप है. अगर हो जाएगा तो ठीक है, नहीं तो विल लीव इट ऑफ. विल जस्ट पंक्चर विद द सिस्टम. अब इसी से डायरेक्ट पंक्चर कर देंगे. निकालो इसको. इसको अंदर करना. आएगा छोड़ दे. पता नहीं सक्सीड करेगा कि नहीं. आई एम नॉट श्योर. वी फेल्ड ट्वाइस. सो 5 minutes more. Because he has a high risk of infection now because we have contaminated the system. It can be put, but provided you have to have a hot axios. है एक और हॉट एक्सिस है, दे दो. क्या साइज है? 15 बहुत बड़ा है, पर ठीक है, डाल देंगे, वही डाल देते हैं. ठीक है, दे दो फिर हॉट एक्सिस. आई थिंक दैट्स अ गुड आइडिया. वी वर ट्राइंग, इसको ऑटो कट मोड पे कर दीजिए. आई थिंक दैट्स द बेस्ट सोल्यूशन इन दिस केस. $15 mm. हाँ ठीक है, गुड. निकाल दिया. I think thanks for mentioning about the hot axios. I am also a little conservative. I want to save cost, but this is a situation where health becomes primary issue and cost is secondary. There's a fluid अंदर है. Ready? All set? Shinu, ready? Okay, so the cautery setting is little different. Octocut, ready? Chapok sir. Yeah. Okay, okay. Okay, all set? Ready? Okay, so we've gone deeper down. निकाल दिया. Now here the space is little less and below is a vessel, so I don't want to overshoot and hit a vessel. I'll lock it. Just remove the safety valve. And then very slowly withdraw. I'll unlock and push it little more in. I'm not sure it is okay. Okay, now it's opened up. Huh? Yeah, so this is good position. I'll unlock and I can move to endoscopy view. And this time I'm deploying under endoscopy view. There's a black mark which is the mark which tells us where the okay. So I think this is fine. And you can see the inner flange inside, and then it comes as a neck here, and then it opens in the stomach. I think this would have been challenged with a plastic also. Cap कहाँ गया इसका? I think we will. Thank you. Thank you, Babaji.
Thank you so much, sir.
Thank you. वो रहा आपका एक लैग है. Thank you.
This is how we open the lesser sac. You can see the lesser sac being opened by harmonic, which is fairly standard practice to expose the surface of the pancreas. And we lift the stomach, pass a needle through the abdominal wall and then take it out, passing through the stomach to lift the stomach. This is a natural kind of a retractor. And you can see the entire surface of the pancreas exposed and the duct aspirated, and then at the same point, using a hook, we open the pancreatic duct, and you can really see the stones peeping out, one large stones seen. I just want to make a point that this large stone burden can only be managed surgically. It's very difficult to manage them with endotherapy. You can see more stones showing up, as was evident in the CT that had a large stone burden. You can see one of the stones coming out. These big stones would require multiple sessions of endotherapy, and still we won't be sure whether you've done a complete clearance or not. You can see. I wish Sandeep was here and could really see that how we clear the stones, using laparoscopic approach, and you can see the entire duct now being cleared off the stones. And there's just a short video, and all these stones, of course, are kept in a bag, and which can be retrieved through one of the port sites. And then we prepare a roux limb. And that's a jejunum, about 40 centimeters beyond the DJ. And again, using the harmonic, you can just, and then an endo-GI stapler to cut the jejunum off. And then you do a jejunostomy, again using the endo-GI stapler. And you can see both the limbs of the jejunum being joined together using an endo-GI stapler. And that's making of the roux limb, as we all single 60 blue endo-GI used for this, and then the enterotomy site is overseen by using 20 PDS sutures. And then the free end of the jejunum is again brought above on the anterior surface of the exposed pancreas, where the duct has already been defined, as you saw earlier, and that's the enterotomy being made, and then we start the pancreatitis. And that's the cornermost suture being taken, and this also fixes the jejunum loop onto the anterior surface of the pancreas. And again, we use 20 PDS sutures, which is monofilament, easy to handle, smooth, passes through the jejunum as well as the pancreatic parenchyma. And that's the posterior layer of the pancreatitis being anastomosed. You can see this is again a continuous suture with interpursed locking sutures. It is preferable to lock these sutures because there is a risk of about 5 to 10% pseudoaneurysm in the wall of the cut pancreatic parenchyma. And you can really see how long this drainage is. And you previously saw the stone burden and how big the stones were. And we believe that this is appropriate, for our patients. This is one-time procedure. Most of these patients are young, and it does the job, and it is effective in the long term. This is again continuous posterior sutures being taken. I'm sorry I missed the anterior part, which was in some other video. So that actually completes the posterior, and similarly you continue that onto the anterior surface of the pancreas to complete the pancreatitis. And if we go, just to show a little statistics, this was one of the procedures which Dr. Saket helped us, and this was the beginning of our series of about 10 pancreatitis, laparoscopic pancreatitis. And if you see Our real figures, we've done about 48 in all phrase procedures. Open have been 43 and 9 now laparoscopic. This is a slightly old data which we have. And beagers, which we saw pictures in the lecture today, are just 2 in number. Now laparoscopic, most of these procedures are actually LPJ. They are not phrase, which is little difficult to do laparoscopically. And I think this is all. You are in a medical audience mostly. So I hope I could convince you that laparoscopic LPJ, in fact open phrase, is something which is also one of the procedures which would stay in the long-term management of patients with chronic pancreatitis. That's it.
We have done almost 20 plus patients here laparoscopically.
Very good. Then you have surpassed us. Very good. That is the way to go. Yeah.
Mostly we get patients
Yeah.
with atrophic pancreas, non-head mass, so it's quite easy also to do, and it justifies LPJ doing in
Yeah,
this
yeah.
patient, not phrase. And
Yeah.
we have started doing with braided sutures.
It's a monofilament. So what we found, Acha.
Yeah, it doesn't slip. So
Right.
that is one modification we have done. And so we get a lot of chronic pancreatitis patients, especially in young females.
Yeah. So,
It suits them that there's no incision, just laparoscopic discharge in 3-4 days.
so you feel that it is better than endotherapy?
Yes. As a surgeon, I'm more convinced towards surgery.
Yeah, yeah.
There are a subset of select patients that can be benefited by endotherapy, not all.
Yeah, but I think early laparoscopic drainage procedures, which will actually retard progression of the disease, and prevent endocrine and exocrine insufficiency.
Probably it is more relevant in younger patients.
Yeah, yeah, of course.
Endoscopic procedures have
Yeah.
sort of time limitation, I think.
Yeah.
after a while,
I didn't have the chance to go into detail, but if you see that in one of the randomized trials, most of these patients who undergo endotherapy, they don't have this much of stone burden, the single stricture, small stones, and then if you really do endotherapy in these patients, there's no evidence to show that it does relieve pain, but there's no evidence that it would reverse the disease.
and removal of such stones is just
Not possible, yeah.
So I think
Yeah, both should be complementary. I mean, you can't say that surgery doesn't have a
depending
play.
on
Yeah.
the circumstances. For younger patients, I think surgery
Yeah.
definitely.
Early surgery. Yeah. Nowadays it is recommended that you should do early. Yeah.
Thank you so much for coming over.
I request Dr. Deepak to propose a vote of thanks.
We have a very good and wonderful session of this pancreatic disease endotherapy, mainly ERCP EUS related all the problems that we faces, and we have a very good lectures as well as case demonstration. And I must say that we are now a little bit wiser in the management of chronic pancreatitis, especially when there is a need of endotherapy, EUS or role of ERCP. And to make this live workshop, a grand success, I must thank Dr. Sandeep sir, Dr. Abhijit sir, Dr. Ramesh for their participation and their effort. I also thank all the doctors, residents of IGMS who have come and they have
actively participated in the workshop. I thanks Dr. Sanjeev Thakur, Dr. Vijay Sankar, Dr. Rajiv, Dr. Utpal. They have come to this workshop and they have given their views and ideas. And I must also thanks the Olympus company and the pharmaceutical companies who are behind this program. And my sincere thanks to all the staffs, those who are working in the endoscopy, those who have helped the procedures going well throughout the day. So I thanks all of you once again and hoping that we will conduct these types of conferences in the futures also. Thank you. Thank you.
Special thanks to administrative staff and especially Sonal. Sonal has worked very hard for this success, for bringing in patients and arranging the whole thing. Special thanks to Sonal.
One announcement. Next Saturday on 5th of August in Hotel Panache, ASI, Association of Surgeons of India Bihar chapter is organizing a CME on GI surgery. This time the surgeons are inviting all the physicians. Please come. The speaker is Dr. 𝗟𝗓𝗓𝗓 from Max Saket, Delhi. He will be talking about on GI surgery, multiple issues. अब जो भी है GI onco surgery, open topic, one hour. One of you are invited next Saturday, Hotel Panache.